The risk of malignancy increases. The risk of malignancy is 2.8% in India when the TSH is less than 0.4 in a nodule, and as the TSH increases to more than 5.5, the risk of malignancy escalates to 30%. So this was a very interesting study as far as the relation of TSH is concerned in a malignancy. Now, ultrasound is the investigation of choice for all nodules. It has almost replaced physical examination. A very simple, fast procedure done by not only radiologists, thyroidologists, endocrinologists. Everyone does an ultrasound. So, will help. What does ultrasound do? Ultrasound helps select the nodule that need an FNA. It definitely doesn't tell that the nodule is benign or malignant, but it will give a clue whether the nodule needs an FNA. Helps us to identify suspicious nodules. So it is a very informative test than examination, CT and scintigraphy. Now, having said that, today everyone gets an ultrasound done. The downstream of doing the ultrasound is patients get anxious. They are worried. There is unnecessary testing and there is unwarranted treatment sometimes. So all these we need to keep in mind. Now, when an ultrasound is done, there are 5 important features that determine malignancy. So the composition, echogenicity, shape, margin, and presence of calcification. Echogenicity, shape, margin, and echogenic foci are given a score of say from 0 to 2 to 3 points, and ways you add up 3 is indeterminate and 4 and 5 are definitely towards malignancy. So this is how the diagram, this is the diagram showing the different radiological features of the thyroid. So the bottom one is benign. You can see this is a pure cyst. And then we have the very low suspicion, the nodule is spongiform. Spongiform is cystic interspaced with solid tissue, or it could be a partially cystic one. And a low suspicion, as you move higher, you find that the nodule is hyperechoic, it is solid, regular margin. And if you finally see the intermediate suspicion, the nodule is hypoechoic with regular margin, and the high suspicion one has calcifications, irregular margins, and hypoechogenicity. So the risk of malignancy increases with this is how the risk of malignancy increases. So this is the basic diagram that gives us whether you need further testing and whether an FNA is needed. Now moving on to FNA, it is done by palpation wherever it is possible. However, small nodules and posteriorly placed nodules, usually an ultrasound guided FNA is done. 2 to 4 aspirates are chosen per nodule, and most important in an FNA is the adequacy of the sample. So the criteria for cytological adequacy are the presence of at least 6 groups of well-circumscribed, well-visualized follicular cells, and each group should contain at least 10 well-preserved epithelial cells. So the FNA classification goes after the Bethesda classification. Again, you can see it goes horizontally, it goes from benign to malignant. So, and vertically, if you see the colloid is where you can see the colloid depicted on the left side and the nuclear atachia depicted on the right side. So the nodule can be benign, or it can be indeterminate, or it can be malignant on the FNA. Now the Bethesda category has 6 in it. It starts with number 1, non-diagnostic. So what is non-diagnostic? Non-diagnostic means there is no cellular element in the FNA, and this needs to be repeated. So the non-diagnostic has to be repeated. It could be malignant, it could be a pure cystic lesion, and this is followed by benign. So the least malignant is Bethesda 2, which is benign. You see the risk of malignancy is 4%, and the most malignant are 5 and 6, where you see 74% and 97%. So 3 and 4 are indeterminate. So this is an area where we have so many controversies. Now what do we do? In a non-diagnostic Bethesda category, always repeat. The repetition gives a clue whether we should of the underlying etiology. As I said, benign can be followed up because the risk of malignancy is very less. 5 and 6, surgery is mandatory. It is 3 and 4 which are indeterminate, and these areas again need further management. Now, this is indeterminate nodule. They comprise about 25% of thyroid nodules. What do? We have 3 options in indeterminate. When we say indeterminate, again there is a sub-classification. They can have papillary-like features, they can have nuclear edema, they can have follicular neoplasms. So most important in an indeterminate nodule is to repeat the FNAC. However, even after a repeat FNA, you find that 60% remain indeterminate. Or a simple diagnostic lobectomy if we do not have access to other modalities. And then most important is the molecular testing, which is done in certain centers, advanced centers even in India. Now, molecular testing is where you look for, you do it only in indeterminate, Bethesda 3 and 4. Once the molecular test suggests it is malignant, a total thyroidectomy is done. And an intermediate risk of possibility malignancy, you can consider lobectomy, and a low probability, we usually consider surveillance. Now, molecular tests, there are 3 different tests that are being done. The simplest is looking for somatic mutations. The BRAF, AS and the RET are the genes where you look for. And then we use the gene expression or the gene sequencing classifier. And finally, the microRNA based classifiers. A word about scintigraphy in the management of thyroid nodules. It has taken a backside because of its limitation. You do it only in people who have a suppressed TSH. What we use is the technetium 99M, and then the basis of the scintigraphy is that malignant nodules they do not trap, they do not organify, and hence they remain cold, whereas functioning nodules, they trap technetium. So the nodules can be hot or cold. So this is the picture showing the hot nodule, and this is the picture showing the cold nodule where there is no uptake. Now what does the hot nodule tell us? All hot nodules by and large are benign. Cold nodules, as I said, they are non-functioning, they could be malignant. So benign nodules all are hot, but remember at the same time, the fallacy is that most of the benign nodules again do not take up, they are also cold. So if you look at the cold nodules, malignant are 10 and benign are 90%. So the utility, because of these fallacies, you find that the utility of scintigraphy in management of thyroid nodule is less now, and we only use it in hot nodules to diagnose a toxic nodule. So 90% remain cold. Now back to our case now. So this is our case, a lady who is 65-year-old, absolutely healthy, no symptoms, no significant family personal history, a very soft 1.5 centimeter nodule, which on the ultrasound is a spongiform nodule. It comes under thyroids 2, and the size of the nodule is 1.8 into 1.4 into 1 centimeter. We ask for the ATA FNAC until the nodule size is more than 2 centimeters. So FNA is not considered given the nodule size of less than 2 centimeters in this case. Repeat ultrasound. What do? Repeat ultrasound thyroid in 24 months. So to approach a case of thyroid nodule in this way, we need a good clinician, a good surgeon, and a dedicated radiologist and a pathologist. Now, summary of my presentation is 2 important tests in thyroid nodule are number 1 TSH and number 2 is ultrasound. These 2 are mandatory in everyone. Having done the ultrasound, look whether the ultrasound findings indicate the need for further testing. If it is a very small nodule like our patient, just follow them up. Now, if the ultrasound suggests the need for an FNA testing, proceed further with FNA. And this side, when you do the TSH may be low, TSH may be normal, or TSH may be high. In a TSH low, which suggests a suppressed TSH in a functioning nodule, you do scintigraphy. A high or a normal TSH, again the nodule, if needed, if the nodule says it is an FNA has to be done, you do an FNA. And And this is the hot nodule where you do a further follow-up, and a cold nodule, again you need FNA. So once the FNA shows a benign nodule, follow them up. The FNA shows a malignant nodule, do surgery. And the grey area is an indeterminate nodule where you can again pipette in FNA or you do molecular testings. If the molecular testings suggest surgery, you go for surgery. And in a facility where we do not have molecular testing and the nodule remains indeterminate, you do surgery. So this is in a nutshell about my presentation. And finally, what is needed is a good clinical judgment, aided by investigations, will give us a clue to appropriate management of thyroid nodules. Thank you.
Hello. The house is open for discussion.
We are having senior general surgeons at vascular level. Sir, any questions?
Normally, mic is there. So many times, as a clinician, so many times we see all T3, T4 TSH be low, but unfortunately TSH antibodies are not available here. So what to do in that situation? Both, all the three are there. You investigate for any pituitary lesions, there is no pituitary lesion, but still all will be low. FT3, FT4 will be normal. So how do you manage the TSH, the only TSH if you do it?
TSH is the most sensitive test of a thyroid dysfunction. Though I said it is TSH, practically everyone does T3, T4 TSH. But you know, in advanced areas of the world, they really go by just the TSH alone. That is why I said TSH. But in India, everyone does T3, T4 TSH as a package. So if the TSH is normal, you do not do any further testing. And if the TSH is suppressed, that is an area where you need TSH receptor antibodies.
It's not available, that's what I mean. Freely it is not available. Even though thyroid antibodies are available,
Again,
antibodies.
if it is not mandatory, if the patient can't afford, we have worked in situations where we did not do TSH receptor antibodies. So we go by the technetium scintigraphy, and if it is a hot nodule, we start treatment for hyperthyroidism.
There is no thyroid enlargement. It is not enlarged thyroid. It is normal thyroid, but still the hormonal imbalance will be there.
Sir, even if it is a normal thyroid, even if the gland is not palpable, a suppressed TSH says there could be a small nodule, a toxic nodule, where you will still do scintigraphy. So in place of TSH receptor antibodies, earlier what we were doing when the TSH was suppressed is scintigraphy.
So what is the commonest thyroid disorder you come on in clinical practice?
Sir, I am not able to hear.
What is the commonest thyroid disorder you come across in your clinical practice?
You mean to say thyroid disorders?
Thyroid
It is subclinical hypothyroidism is the commonest one.
What about autoimmune thyroiditis? Autoimmune thyroiditis. You will get so many cases of autoimmune thyroiditis. These we see the commonest thyroid problem is the autoimmune thyroiditis or Hashimoto's.
Both are same, sir.
Both are
Autoimmune
same,
and
but that is the
Hashimoto's are same.
Commonest disease we are encountered here as a clinician. Thank you.
Agreed.
Good morning, madam. I am Dr. Nakeshwar, surgical oncologist. Thank you for mentioning the genetic testing. We routinely do in genetic testing here in suspicious nodules. We are finding results very beautiful. Thank you for enlightening.
Thank you so much. Thank you.
Any more questions? Thank you.
Ma'am, one question. Good morning, ma'am. This is Dr. Madhavi. I have seen a recent clinical case, toxic nodule, very small, with elevated TSH, started on levothyroxine, but after even 4 to 6 weeks of treatment, both T3, T4 are elevated and still TSH is on rise. What is the follow workup for such cases, ma'am, but toxic nodule is very small in size, not
So
palpable.
see, if it is a toxic nodule, the TSH has to be suppressed, right?
It's maybe nodule is there, it's not toxic or not, we don't know, but TSH is on rise on initial clinical presentation without any symptoms to the patient.
So like this particular case, if the TSH is high, you can start, if the TSH is so high as to start levothyroxine, please start levothyroxine,
Yes,
and at the same time evaluate the nodule by an ultrasound, and if the ultrasound findings warrant a FNA, proceed with FNA.
Okay, ma'am. But still, even though TSH is on higher side, T3, T4 are also going on higher side, ma'am. How we have to interfere? Any interfering antibodies has to be suspected in the clinical assay methods or so?
Yes, one is interfering antibodies, and two, nowadays, we have so much of biotin usage,
Yes,
we
ma'am.
need to stop these. And then probably rare disorders like thyroid hormone resistance syndromes can have this picture.
Are you having any clinical experience with now T3, this thyroid group? I mean, those who are having still symptoms with normal euthyroid state also, are you suggesting any T3 supplementation nowadays, ma'am?
Yeah, there are some, proceed. Okay, next lecture is there.
Yes, thank you. Yes, thank you.
Thank you.
Thank you, madam. Thank you for the wonderful presentation.
Thank you, Dr. Maithili ma'am, for the wonderful presentation. Next lecture will be by Dr. Alok Sachin sir. Sir is Professor and HOD of Endocrinology at SWIMS Tirupati. So I would like to invite Dr. K.V. Subramaniam sir, Professor and HOD of Department of Endocrinology, Andhra Medical College, Vizag, and Dr. Jaydev sir, Consultant Endocrinologist at Vijayawada, to chair the session. Thank you.
So thank you to ESAP for giving us this opportunity. It is great pleasure to introduce Dr. Alok Sachin, who is a MD DM endocrinologist who has done his MD from SN Medical College, Agra. He has done DM endocrinology from SGPGI and Chandigarh, I believe in 2004. I think it is Lucknow, SGPGI, Lucknow he has done. So the error is here. He's got many awards and honors. He's an excellent teacher, excellent speaker, and an excellent clinician. All of it is there for us to see on the screen. His present designation is a Professor of Department of Endocrinology and Metabolism, Sri Venkateswara Institute of Medical Sciences, Tirupati, Andhra Pradesh. So welcome, sir, to give your talk.
Good morning, everyone. Thanks, Chairperson, for the kind introduction, and thanks, organizers from Guntur and Vijayawada for inviting me to the meeting. I will start the presentation. I am going to talk about pitfalls in measurement of thyroid hormones, and yeah, here it is. So I am going to talk about it in few cases. We'll discuss it as we go with the cases. Part of it has already been told by Dr. Maithili when Madam was discussing about biotin. So we are going to start the cases. The first case is of a 32-year-old lady who presented with complaints of hair fall and weight gain over 2 kg for the last 1 year. It was assumed that she has weight gain and hair fall, so she probably is hypothyroid. Investigations were done, but on examination, thyroid was normally palpable. When investigations were done, a surprise came. T3 was slightly on the higher side, and T4 was also on the higher side, total T4. TSH was less. So when the investigations were done, the picture became confusing. It looked like as if patient is hyperthyroid. So she was further evaluated and ultrasound was normal. Technetium thyroid scan was also done to rule out if she has thyrotoxicosis, Graves or toxic multinodular goiter. That also turned out to be normal. On further evaluation, when patient was asked, she informed that she was taking some over-the-counter medical preparation for her hair fall. The preparation, when we saw the preparation contained lot of vitamins, along with that vitamin B7. So Madam has already told about biotin interference. So biotin interference happens in the assay. She was asked to stop the medicines, and when she stopped the medicines, afterwards the tests were repeated after 2 weeks. T3, which was previously on the higher side, came down slightly, and T4 also came down. TSH became normal. So this was a case of biotin interference. Biotin is used in many immunoassays, which is ELISA on chemiluminescence. The quality of biotin is that biotin and avidin is an albumin protein and biotin is a vitamin. Both of them work like two sides of a Velcro strip. So they come together. So this is used like a biological glue for many of the assays and many of the chemical reactions. So if we see this diagram, if the antibodies are used, which I have biotin on one side, microparticles which are coated with avidin, and then these are the different symbols I have used further to describe it. So when in most of these tests, a microparticle is used to capture the antibody and the immune complex. The microparticle is coated with avidin, and the antibody which is coated with biotin will come and bind with it. When we add the serum, all the analytes in the serum will come down, and this will link with the antibody. Then when we add the next step, which contains the chemical for the tracer for doing the test, that will also bind. And when the machine reads it after a washing step, the machine will read only these things. The ligand, the active tracer machine will read, and based on that, the machine will calculate the amount of hormone present in the blood. So this is an example of an assay for T4. So that is how the assay works. And this assay works, there is biotin and here is avidin. So this is the level where the interference happens. Now what happens if a patient has lot of biotin in the serum? The biotin will occupy the sites on the microparticle, and then the machine reads, machine will find only a less amount of analyte present. So machine will read it in a different way and it will give it an error message. Machine will not be able to understand, the analyzer will not be able to understand that there is an interference in it, and biotin interference will cause an error. So it will happen with T4, it will happen in TSH. Common interference is that T3 and T4 will be read high, TSH will be read low, but it differs from lab to lab, it differs from machine to machine. So biotin interference can be quite troublesome, and whenever there is biotin interference, we advise the patient to stop the preparations, all the multivitamins, and do the test again after 1 week. We take it as a safety precaution. Usually biotin interference disappears within 48 hours, but within 1 week everything will be disappeared, so the patient's reports will come normal. So now we go to the second case. Second case is that of a 16-year-old boy who presented to OPD for follow-up. He was already a known hypothyroid and he was taking thyroxine. He was clinically euthyroid. On examination, thyroid was 2 times enlarged. T3, T4 were normal, but TSH was slightly on the higher side. So somebody had asked a question that what do we do in this kind of cases? Patient was previously also poorly controlled on thyroxine. Further evaluation, we did the free T4 also. First was total T4, we did the free T4 was also normal. On repeated questioning, the patient accepted that in between he was non-compliant with the medication, and just 2-3 days before the testing, he started taking heavier dose so that test will look like normal. So that was the problem. Patient was non-compliant, and that is why this test was coming like this. But sometimes when the patient accepts that the patient is non-compliant, it makes our job easy. But sometimes it also happens that patient accepts the patient is taking the medicine regularly. Patient claims that he is taking the medicines regularly, and there is still problem. T3, T4 is coming on the normal side or slightly on the lower side, and TSH is persistently on the higher side. We increase the dose of medicines, still TSH doesn't get controlled. So we have to rule out multiple other problems in this kind of cases. One is malabsorption. Patients who have atrophic gastritis, patients who have jejuno-ileal bypass, these are the patients who can have malabsorption of thyroxine. Drug interference. There are multiple drugs which will interfere with absorption of thyroxine. So that is cholestyramine, which is therapeutically used for treatment of hyperthyroidism. Then there are drugs like iron, calcium, simple things. These are the drugs which will interfere with the absorption of thyroxine. Then there is excessive utilization of thyroid hormone, which sometimes happens. It is common in children. There is something called hemangioma of the liver, which can sometimes cause excessive utilization of the thyroid hormone, and something that happens in nephrotic syndrome. In nephrotic syndrome, the bound thyroid hormone is leaked along with the albumin in the urine. So there is excessive wastage of the thyroid hormone, and you need to give a heavier dose of thyroxine. The one way to rule out if patient has really malabsorption or patient is not taking the medicine properly is thyroxine absorption test. So the first we need to decide whether there is a need. First we rule out all other causes of thyroid hormone problem. That patient is compliance is there, or if we have doubt, then we will go with the absorption test. We rule out that patient is taking any medicines which could have caused the malabsorption. When we are sure that there is the only two possibilities are left, that either patient is not compliant or patient has malabsorption, we go ahead with the thyroxine absorption test. First we describe that there is a need for the test, and we tell the patient that we are going to perform the test, explain the procedure, give the patient some time. Now there is a reason for it. When we tell the patient, we don't spring a surprise. We tell the patient we are going to perform this test after 1 week, after 2 weeks. So that period gives patient some time to think. Sometimes the patients who are non-compliant will suddenly become compliant, and when you do the testing, just a few days before that the proposed test, you will find that the TSH has become normal or TSH has come down. So that alleviates the need for the test. Then few days before the test, we do the ECG. And ECG is required because the dose which is used for malabsorption, to rule out malabsorption for thyroxine absorption test is quite high. So we should make sure that patient doesn't have a coronary artery disease. For doing the test, we need to admit the patient, if possible, previous night, otherwise same day in the morning. Moderate amount of water can be taken in the night, next day morning also, but 1 hour before the test, we stop the use of water. Lot of dilution can happen if patient has drunk lot of water during the test, so that we don't want. So water is not allowed for 1 hour before or after starting the test. The dose of thyroxine which is used is 1000 micrograms. That is the usual dose. For children, we can use the dose which is equivalent to 7 days equivalent dose. So that much dose of thyroxine is to be given, preferably the same brand which patient was previously using. Same thing can be given. This dose is given under supervision, and after that patient is kept under supervision for next 4 hours for this test. Now there are multiple protocols for thyroxine absorption test. I am just giving one protocol. There are different protocols. I am giving the protocol for 1 day test, but it is possible many places do this test weekly for 6 weeks. So the dose of thyroxine is given, baseline sample is collected, after that hourly samples are collected for next 4 hours. Normal response is free T4 increases by 0.4 nanogram per dl. Normal range for free T4 is 0.6 to 1.2. T4 absorption, calculated T4 absorption is more than 60%. T4 absorption has to be calculated from the way we have given. Volume of distribution, dose of thyroxine which was taken, and what are the total increment and total T4. So based on that we decide if the free T4 increment has happened over 0.4 and T4 absorption is more than 60%, we assume that the thyroxine absorption was normal. Now this test, in the 1 day protocol, we don't do TSH. But if we are doing the test repeatedly, some centers do that weekly for next 6 days, for 6 weeks, then we will see the improvement in TSH also. If patient did not have any malabsorption, the TSH will also start improving, and by the end of 6 weeks, TSH would have become normal. So that is one way of ruling out thyroxine malabsorption. Now we go to the next case, which is of a 40-year-old gentleman who presented with complaints of weakness, lethargy, thyroid was normally palpable, only biochemical abnormality was mild degree of anemia. Patient was reassured, started on iron and folic acid, but patient did not have much improvement, and patient kept on coming. Finally, after 1 year, when we repeated the thyroid function test, we found out that the free T4 had come down, TSH was in the same range. So it was diagnosis of central hypothyroidism was made. On further evaluation, it was found that patient had low serum cortisol, and on imaging a small size pituitary gland was seen. So this is a condition of central hypothyroidism. The way to diagnose this in this case was normally central hypothyroidism with come with lower free T4 and normal TSH. In this case, in the beginning, free T4 was normal. If it is seen on follow-up that free T4 has fallen by more than 20% on the follow-up. The catch is it should be done in the same laboratory, same method. If the laboratory has changed the method of free T4 estimation, then also this estimation cannot be done. So the comparison has to be done. If free T4 is seen to be falling, it will go in favor of central hypothyroidism. Then we need to, at this point, we need to rule out some other medicines which can suppress the TSH. In the last slide, we'll go and we'll discuss the medicines which can affect the TSH measurement. So this patient had central hypothyroidism. He was started on hydrocortisone and thyroxine therapy. So with this, I will come to the last case of the presentation today. This was a 40-year-old lady who was hospitalized with breathlessness. She was diagnosed as a case of unstable angina, started on heparin and other medication. Due to past history of palpitation, somebody thought that we'll try to rule out thyrotoxicosis. Free T4 was done, TSH was done. Free T4 was elevated as was expected, but TSH was coming surprisingly normal. So the physicians didn't know what to make out of it, and a consultation to endocrinologist was sent. When we saw, we found that the patient's thyroid was normally palpable, clinically euthyroid, repeat tests were ordered, and this time in the repeat test, we also ordered the total T4. Free T4 was still high, but total T4 came normal, total T3 was normal, TSH was normal. So this time we assessed the free T4 estimation. Free T4 estimation was done with the routine method, which most of the labs do, and this routine method is basically a shortcut. It is a calculation depending upon the binding of the tracer available in the blood, by the tracer available in the machine. So that is the routine free T4 estimation. The classic way of doing free T4 estimation, or for that matter, any free thyroid hormone, any free hormone, is dialysis method. Dialysis method is very time consuming, very labor intensive method. Most of the labs don't do it. So the laboratory method of free T4 is just a simplified way, which can be a problem in many cases, including pregnancy. So here the problem was in the free T4 estimation, the way it was done, but it was probably because of another interference, and that interference was heparin. There are some drugs which will displace thyroid hormone from the binding sites, common drugs, Lasix. Then there can be aspirin, NSAID, many NSAID, heparin. All these drugs will cause displacement of thyroid hormone from the binding site and will lead to elevation of the free thyroid hormone. So in these cases, clinical evaluation, total hormones, everything has to be seen. Only then the diagnosis can be made that this is drug interference for free thyroid hormones. These are some of the common abnormalities seen in thyroid hormone estimations. Sick euthyroid syndrome. Patient is already admitted with some other chronic condition or some other sickness, and at that time the estimation finds that the TSH is from the normal to low side, T3 is low, T4 can be high, normal or low. Pregnancy. During pregnancy, the routine estimation finds that T3, total T4 are high, free T4 can go in any direction, and TSH is low. The problem with our free T4 and free T3 measurements in most of the labs is that the binding sites this is not the correct method, and in pregnancy it often gives the wrong estimation. In the pregnancy, normal value for total T4 will be almost 1.5 times of the normal T4. If the normal T4 value of a non-pregnant adult comes to 120 nanogram per ml for a non-pregnant adult, then for the pregnancy, this value will go to almost 180 nanogram per ml. So that kind of difference happens during the pregnancy. Normal TSH and high T4 can sometimes be seen in acute psychosis. There is something called high dose hook effect. Now, high dose hook effect is something simple to understand if we understand that each test has a limited range. Test is designed to measure something in a range. It is like this hall. If the hall is designed to accommodate 150 guests, and if we try to stuff 300 guests into it, what will happen? So the capacity of hall will not be good, and the performance will not be good. Guests will have problem. Same thing happens with a test. A test which is designed to measure TSH between 0.4 to 40, if you put serum in it, which has 400 milliunit of TSH in it, then the test will not be able to perform. So that kind of performance problem comes with high dose hook effect. This will happen only when very high amount of TSH is present. It is routinely not seen Most of the labs now have good tests, but once in a while you will find somewhere where the TSH is coming low when we expected it to be high. And when the lab starts doing the dilution, from first we do the normal, then after that we do dilution by 1:10, you will find that TSH starts rising. So that is high dose hook effect, something very uncommon, but previously we used to see it a lot. The last is a condition where TSH estimation may be wrong. The TSH estimation, there are many drugs which will interfere with the secretion of TSH, like glucocorticoids. Patient is on prednisolone for bronchial asthma or arthritis. Dopamine, patient has been hospitalized and patient was on dopamine. Metformin, something very common. With use of metformin also, some patients suppress TSH. And somatostatin receptor analogs, octreotide, lanreotide, with that use also, TSH secretion may go down. So these are the problems that can happen in some of the patients with the thyroid hormone measurements. So I would like to conclude the talk by telling that history taking and clinical examinations are important for evaluation of patients with thyroid disorders. Biochemical evaluation is only an aid in the workup. Do not try to diagnose thyroid disorders based only on the biochemical lab reports. No laboratory evaluation is 100% accurate, and all the time most of the laboratories will try to indicate that there can be a problem in the thyroid function test. If needed, repeat the test, use a different method or use a different lab. Thank you.
Thank you, Alok. It is a beautiful and appropriate assessment of the difficult thyroid hormone assessment. And the topic is open for discussion. See, we see so many reports, and so many times the reports are not to our interpretation. Sometimes we have increase in the total T4, increase in the TSH sometimes, and see both. And again, there was otherwise also, some sir has asked previously regarding this type of abnormality. And you see a lot of things in your practice. That's what is more important, and any questions are solicited. Please, somebody can give mic there. I know. Okay.
Sir, just to throw some light on amiodarone as well, sir. Amiodarone and thyroid slightly.
Sorry. So amiodarone has multiple effects on thyroid hormone. Number one, amiodarone is almost 34% full of iodine. So it contains lot of iodine. Our iodine requirement of a normal adult, of a non-pregnant adult, is 100 to 150 micrograms of iodine per day. Now, if you are taking a amiodarone tablet of 75 mg, it contains 37 mg of iodine. The amount of iodine which body has ingested with one tablet is almost 100 times that of the daily requirement. So that affects the body in a different way. Lot of iodine can alter the way thyroid hormones are processed. In some people, it can cause suppression of thyroid hormone synthesis. That is number one. Then amiodarone itself will cause suppression of TSH. Amiodarone will further, because of the lot of iodine, some people who had a mild, low autonomous, low functioning at a very low level, autonomous thyroid nodule, will suddenly go into thyrotoxicosis. So that is called type 1 thyrotoxicosis. Amiodarone with iodine can suppress thyroid hormone synthesis, so it can cause hypothyroidism. Then some people have a reaction to amiodarone which causes destructive thyroiditis. So with destructive thyroiditis, for a temporary period, the thyroid hormone secretion will go very high, which will continue for 2 to 3 months, and after that, patient will go into hypothyroidism. So amiodarone can cause anything. It can cause hypothyroidism, it can cause hyperthyroidism, thyrotoxicosis with thyroiditis. All kind of pictures are possible with amiodarone use. So we need to be little careful when we find a patient who has been taking amiodarone. The problem with iodine is, once you ingest enough amount of iodine, it will be there in the thyroid gland for very long time. So even after stopping amiodarone, the effect on thyroid function test may continue for next 3 or 4 months. It may not revert to normal.
Thank you, sir.
Sir, one case, a young lady was referred because of the levothyroxine requirement was around 500 micrograms per day. In spite of using 500, clinically frank hypothyroid, investigations free T4 less than lower limit of normal, TSH is always high. I have done a levothyroxine absorption test with 600 micrograms, has increased to 0.92 nanograms per deciliter in levothyroxine absorption test. So frankly, ruling out malabsorption. Again, in spite of increasing dose of levothyroxine, good brand, hypothyroidism never was controlled. What could be the reason?
It was a patient was taking the medicine under supervision.
Yes, sir. Second time after this levothyroxine absorption test, it was a supervised dose.
But under supervised dose also patient did not improve. Then we need to rule out other condition if patient was taking some other medicine, some of the commonly used antacids, aluminum hydroxide, sucralfate, or some other medicines, calcium, iron can interfere with the absorption of thyroid hormone. The next problem can be if patient really has a need with excessive thyroxine. That can happen if patient has nephrotic syndrome and has albuminuria. Next can be there are some other drugs which will not interfere with the absorption of the thyroid hormone, but will cause increased need for the thyroid hormone because of increased metabolism. So anti-epileptic drugs, phenytoin, carbamazepine, these are the drugs which can interfere it. So we need to rule out all the factors one by one. But thyroid hormone malabsorption was not there. You said that the increase was more than 0.9. That we need to rule out all other causes to find out what was happening. And if nothing else works, maybe a trial of T4 and T3 can be given.
So thank you, Dr. Alok Sachin, and thank you to all the audience for asking all the questions. Thank you.
Thank you, Dr. Alok Sachin sir, for the wonderful presentation. Next topic is by Dr. Gautam Meher from Vijayawada. So, sir is speaking on the role of combination therapy in the management of hypothyroidism. I would like to invite our chairpersons, Dr. P. Srinivaslu sir, who is the professor and HOD of Department of Endocrinology, Kurnool Medical College, and Dr. B. Vivekanand sir, Associate Professor of Department of Endocrinology, Andhra Medical College, Vizag.
Good morning to all. The next topic is role of combination therapy in the management of hypothyroidism. To speak on this, I would like to introduce Dr. Gautam Meher, who is a consultant endocrinologist, Gautam Diabetes and Hormone Care, Suryapet, Vijayawada. He pursued MBBS from Rangarai Middle College in 1998, obtained MD from Kastur Middle College, Manipal Academy in 2003, DM from LLR Middle College in 2008. Over to you, Gautam sir.
Yeah. Good morning all. I would like to thank the organizers for organizing such a great event here, and I'm very thankful for that. So today I'm going to talk about the role of combination therapy in the management of hypothyroidism. So basically, if you take the history of levothyroxine treatment, it started off with desiccated thyroid extracts. So this thyroid extract went from the pork origin, and basically there was the element of both T4 and T3, but basically the concentrations were not standardized, and the shelf life was rather unstable. Later, T3 and T4 were more purified, and with this, patients were being treated with hypothyroidism with levothyroxine, with T4 or with T3. Later in 1970, what happened was there came this observation that T4 is converted to T3 with the deiodinase enzyme, which is normally present in the body, and so there's no point in giving T3, and based on this observation, T4 has become the predominant form of treatment. So basically, humans, all of us, activate T4 to T3, and all the levothyroxine doses, they restore the body reservoir of T3. Hence, so we need to give T4 to the patient in hypothyroidism, and there's no pretty need to give T3 separately. However, there is evidence that, which I'll be telling in the next slides, that it is not fully restored even in levothyroxine treated patients. And even if you treat patients with levothyroxine, there are about 10 to 15% of the patients who still have complaints. Their complaints don't resolve. So that makes it like, do we have any gap in therapies here, and do we need extra supplementation in the management of hypothyroidism? The patients tend to have persistent complaints, like the initial symptoms are still there, and the complaint of persistent psychological symptoms, and they don't feel normal. Like some vague symptoms like being tired, lack of energy, cognitive issues, musculoskeletal problems, weight problems, increase in weight, diffuse symptoms, constipation, depression, etc. So we usually brush it away, thinking of these as psychological symptoms. So you don't really think of start evaluating these patients, but you think of innumerable causes like the various endocrine causes like diabetes, adrenal insufficiency or hypopituitarism, hematological causes like anemia, end organ damages. All these have to be taken in the spectrum of the clinical feature. You don't evaluate for all this with investigations. So you look at the patient, see all the associated symptoms, and then focus if he has any other issues apart from the hypothyroidism. Like other nutrition deficiencies like B12, folate, vitamin D deficiencies, hypercalcemia or any electrolyte imbalance, drugs like beta blockers and statins, stressful life events, alcohol excess, obstructive sleep apnea, fibromyalgia, polymyalgia rheumatica. These are all the causes like a patient can have vague symptoms which can be attributed psychologically or which overlap with symptoms of hypothyroidism also. So here I am talking about the predominant form of treatment is levothyroxine therapy. So how do we add, is there a place for levothyroxine or T3 therapy? So basically, we need to check out patients if they are if they need T3 apart from T4 also. So first thing you see is post-surgical or post-radioablative patients. Usually the T4 and the T3 are wiped out. So in these conditions, if the patient does not have any relief of symptoms, probably you need to check the T3 levels and consider T3 treatment in these patients. And in patients with hypothyroidism, the T3 production is there, but usually they don't feel well with levothyroxine replacement. And if you check, probably the T3 levels are low, normal, or low. T3 replacement has to be avoided in some cases, like especially in older patients with cardiovascular disease, because the risk of arrhythmias is higher. And patients have been treated with the levothyroxine T4 treatment. They have really done well. And again, there is a resumption of treatment. So you need to check out for other possible causes of those vague symptoms which the patient complains. Subclinical hypothyroidism, there's not much role because T3 production is adequate. In pregnancy, T3 treatment has to be avoided because the fetal neurogenesis is dependent upon the levothyroxine, like the T4 therapy, especially during the 12 to 18 weeks of gestation. And previously, when they used to use desiccated thyroid extract with high levels of T3, there was an impaired fetal neurogenesis because of those extracts. So hence, it's better to avoid T3 therapy in pregnancy. So when did this T3 really come into in this place of treating hypothyroidism? When did they start considering it? Even after the observation that T4 is enough for treatment, when did they start considering it? So the normal physiology is the T4 is basically a prohormone which gets converted into T3 at the tissue level, and the T3 is the one at the cellular level which leads to relief of symptoms and takes care of the hypothyroidism. But not all studies. T3 really did come into the normal range. So there were some studies, patient had adequate levothyroxine therapy, but T3 really didn't come into normal. And few studies they have seen that the T4 replacement, over replacement with T4, and only when the TSH is suppressed to less than 0.3, the T3 was uniformly reduced. T3 was uniformly normal or uniformly present. And as I've said before, in post-ablative or post-surgical patients, the T3 is also less. Probably you need to consider T3 treatment in these patients. And initial studies have shown that multiple randomized control, that combination therapy did not show any benefit compared to combination therapy of T4 and T3 compared to levothyroxine alone. And usually the basis is the T4 to T3 ratio in the body. If you see per microgram comparison, it's 13:1 is to 16:1. So we need to when we think of replacing this thyroxine replacement with T4 or T3, we need to consider this ratio. And during this initial randomized control trials, the T3 used was either excessive or even supraphysiological. And hence, what we need to do is those initial randomized control trials had some flaws regarding the usage of the T3 doses. And probably in the future, if there is a slow release T3, and if it's combined with T4, probably we'll have better treatment of hypothyroidism. What about the efficacy of this combination treatment of T4 and T3? Among various randomized control, only one trial has shown benefits in mood, quality of life, and psychometric performances. And few meta-analyses, or two meta-analyses, like one with 11 RCTs and another with 7 RCTs, there has been no preferential patient preference with combination therapy, and there has been no benefit in terms of fatigue, pains, anxiety, depression, or quality of life. So, meta-analysis did not show any benefit there. Few studies, however, showed benefit, like they had the reference will come later. Benefits in mood, fatigue, and psychological symptoms, especially if the T3 doses were higher, especially when the ratios were between 10:1 and 5:1. And if the T3 ratio, if the T3 is higher and the TSH is much more suppressed, these patients even had a 1.8 kilo weight loss also. So in some trials, patients had a preferential, they had a preference of combination therapy rather than levothyroxine, especially in crossover studies. And though they didn't have much statistically significant improvement of quality of life symptoms, they preferred the combination therapy. Desiccated thyroid extract, there was one trial which showed a preference for the patient and improvement of symptoms, not much preference, improvement in symptoms, but there was a preference for the patient regarding the thyroid extract. Coming to polymorphisms, polymorphisms are, we have this deiodinase enzyme. If this deiodinase enzyme, because of the polymorphism, if it is deficient, then probably the TSH is normal, T4 becomes normal, and the T3 is low. And these patients tend to have persistent symptoms, and addition of T3 in these patients will help resolution of symptoms. And in these studies, what they have seen is those patients with the most hypothyroid symptoms, like severe hypothyroid symptoms, had the most benefit. So polymorphisms, if you think the patient has a normal TSH and T4 with a low T3, we need to consider for gene polymorphisms and give replacement with T3. So coming to the, after this data, coming to the practical aspects, what are the formulations we have? We have levothyroxine in the market, which is very common, written by all. And this is, there are many benefits with this levothyroxine because it has a long shelf life, it is very cheap, and it takes care of most of the symptoms. Lethiorenine hasn't been in our Indian market, but it has come only recently. And desiccated thyroid extract was there previously, but now we don't have that. Coming to replacement, we don't have any fixed combinations. So rather we give both the T4 and the T3 as separate pills. T3 is coming up recently in the market, comes as 5 micrograms and 20 micrograms. Both the tablets are scoreable. So we have 2.5 gradations of tablets. So we can, from right now to 5 micrograms to 20 micrograms, we can go in gradations. And you decide the dose based on the ratios. Like the T4 to T3 ratio can be between 13:1 to 16:1. So one bottom line is 15:1 is the ratio which you can calculate and give it to the patient. I will give some examples. If the total T4 replacement for the patient is 75 to 100, then your T4 will be 50 to 75 and T3 will be 2.5 micrograms twice daily. If it is 112 to 137, the T4 will be 88 to 112 and 5 milligrams and 2.5 will be the T3 dosage. Similarly, 150 to 175, the T4 will be 112 to 137 and 5 milligrams twice daily will be the T3 therapy. And if it goes to more than 200 to 250, the T4 will be 150 to 200 and 75 to 500. So basically, the ratios have been calculated around 13:1 to 16:1. T3 treatment has some issues if you give it as a immunotherapy. What they have seen is the risk of heart failure and stroke are higher. However, the risk of atrial fibrillation and osteoporosis were elevated, but they were not statistically significant. When you are giving a combination therapy of T4 and T3, usually the monitor is by TSH as you do it regularly. If the TSH is mildly elevated, then increase the levothyroxine, the T4 dosage. But if it is greater than T4, greater than 10, then increase both the T4 and the T3 dosages. However, if the TSH is suppressed but detectable, then see the ratios. If the ratio you have given is 13:1, probably the T3 concentration is higher and reduce that dose. And if your ratio is between 16:1, if you have calculated the dose as 16:1, then reduce the T4 dosage by 12.5. And if it is totally undetectable, reduce the doses in the same proportion. T4 monitoring and T3 monitoring are not needed when you are giving combination therapy. And because T3 has a very short half-life, and if you start checking out T3 levels after giving the 2 hours after giving the T3 dosage is going to be very high, and if before the next dose it goes into troughs. So lots of peaks and troughs are there. So check out only the TSS. T3 is not needed. And if a patient is on combination therapy and you want him to bring back to levothyroxine therapy, what you need to do is see that T4 dosage and add the T3 dosage into 4 times, because T3 is 4 times metabolically more active than T4. So suppose if the patient is taking 12.5 micrograms of T3 and 50 micrograms of T4. So what you do is 50 plus 12.5 into 4. So you make it into 100 micrograms of levothyroxine. So summarizing, 15% of the patients have unresolved symptoms in hypothyroidism. Basically, in those patients, probably you need to check out the T3 levels and decide upon if you want to give a combination therapy or not. Select the patients based on criteria, as I've said. And in Hashimoto's, if the T3 is consistently low and you don't have any other symptoms to the causes I've told before, and then surgically ablated or radio-ablated patients also. And if the patient has, most of the patients usually benefit with levothyroxine, but as I've said, 10 to 15% with low T3, you can consider combination therapy in these. The ratio is bottom line 15:1, and monitoring is by TSH values. Yeah, so this is my talk on combination therapy.
Yeah, thank you, Dr. Meher. I think one of the doctor has the same question, where the patient has symptoms of hypothyroidism despite of having everything normal. I think, doctor, if you got any questions, you can ask. And Dr. Meher, I think in practice right now, are you using the combination? Right?
Not actively, one or two few patients in single digits actually. But the thing is, there were concerns about T3, especially the short half-life. It goes into a peak and goes into troughs. You have to give BD or TID. And there's this issue of arrhythmias and heart failure, worsening of heart failure, probably new heart failure. So that has gone into disfavor. And till now, we used to have this notion that T4 is converted into T3 naturally in the body because of this deadeness. So there's no need for T3 replacement. But with few data which is coming up, where 15% of the patients don't have adequate T3 levels, if they have persistent symptoms, even after you replace with levothyroxine, probably you can give a trial of combination therapy in these patients. And the case becomes stronger if the patient is surgically ablated or post-radioiodine ablation of thyroid.
What is the concept of having the tissue normalization of FT4? Can you comment on a ratio of FT4, FT3 versus reverse T3 ratio?
Yeah. This is microgram to microgram dosage. Yeah. Okay. You're talking about the levothyroxine dosage or the tissue level? Yeah, the dosages which you give are between 13:1 to 16:1. So bottom line, remember it as 15:1. That's the normal this one. And at the tissue level, it is 4 times more metabolically active than T4. T3 is 4 times more metabolically active than T4.
Okay. Any other questions? Okay. Thank you, Doctor.
Oh yeah, thank you.
Thank you, Dr. Gautam Meher, sir. So next topic will be diabetes update. So in this, the first session will be chaired by Dr. Durga Prasad, consultant endocrinologist from Diet Hospital, Kakinada, and Dr. Kiran Kumar Gola, consultant endocrinologist from Visakhapatnam. So the speaker is Dr. Ramya Varda. She will be talking about diabetes in young. So I would like to Dr. Durga Prasad and Dr. Kiran Kumar to introduce the speaker. Thank you.
So the next session will be diabetes in young. Introducing speaker. Speaker is V. Ramya. She did her DM Endocrinology from Andhra Medical College, Visakhapatnam, Andhra Pradesh. And now she is working as a consultant endocrinologist, Apollo Hospitals, Visakhapatnam. Over to you, Ramya.
Warm good morning, one and all. In the first place, I want to thank Dr. Lavanya and ESAP Guntur chapter for inviting me here. And today my topic is diabetes in young, which is like a very common topic. Let's see what's new in it. And there is like a rampant increase in type 2 diabetes, especially in young. We see day in and out young adults between 20 to 30 years presenting with a very high blood sugars, and we need to evaluate properly whether it is just only type 2 diabetes or any other diabetes we are missing. So this is the topic overview. Let's see the prevalence. So diabetes in young is classically defined as onset of diabetes before 40 years of age. And there is a global prevalence of diabetes is about 8%, and which is growing to increase in a exponential level. So the thing is, the earlier the onset of diabetes, the long-term exposure to the hyperglycemia, and more early the onset of complications. And at the end of like a few articles, it's clearly mentioned, though the duration of both type 2 and type 1 diabetes are the same, the complications are more in individuals with type 2 diabetes than type 1. So the prevalence of diabetes globally is like 74 million adults are diabetes in India, and the incidence in AP is like 8.4% and 10% of diabetes and pre-diabetes. So this is a picture showing the like proportion of type 1 and type 2 diabetes in adults between 15 to 19 years of age by search study. This clearly is showing the proportion of type 2 diabetes is more in American Indian in between 15 to 19 years. It's around 80%, whereas in other race it's only like 35%. The more is a type 1 diabetes. And this is a study done in North India about the etiology of diabetes in young. And the results being, the proportion of both type 1 and type 2 are equal, it's about 40%. And the next common thing is FCPD, which is like most negligible. Maybe we generally miss the diagnosis unless they present with either pancreatitis or done a routine ultrasound for other region, they present, we come to a diagnosis of FCPD. Otherwise, we generally miss it. The other less common etiologies being like MODY and mitochondrial diabetes and flatbush diabetes. So this is like normally a ground diabetes classification. Coming to the clinical profile in Indian scenario. The diabetes type 2, especially in India, is different, like Asians is different from other countries, because in India they present with type 2 diabetes even with a lower BMI, especially due to increased abdominal fat, which is like more lipotoxic, and increased clinical and biochemical measures of insulin resistance and systemic inflammation. And India, there is increased prevalence of conversion from T diabetes to diabetes. It's like more, like 14 to 18% compared to other countries. And diabetes in India is 2 decades earlier. This is like an ICMR India Diab study. The endpoint, the conclusion is there is a growing prevalence of diabetes. It starts between the age of like 24 to 34 years in both rural and urban areas of India. So finally, like previously it's thought, it's like mainly due to insulin resistance, but later on further studies indicate it's not the insulin resistance, it's also the beta cell insufficiency that is leading to early onset diabetes in people in India. So lean type 2 diabetes is more prevalent in India, especially in undernourished regions. These are the most common risk factors. The first thing I want to highlight is early life determinants. Previously, when a gestational diabetes woman, we never, the child, we never insist there is a risk of diabetes when they become young. But yes, the studies recently showed clearly it has an effect on the fetus, even if it is a SGA baby or any fetal distress, or the fetus exposed to the hyperglycemia and pregnancy definitely has a risk of diabetes in being in an adolescent age. The other common risk factors are like obesity, physical inactivity, socio-economic factors, and female sex and PCOD and NASH. So, and I want to highlight like a very thing, the new clusters, which is a study done by Mohan et al. And Shashank Joshi et al., identifying the new clusters of diabetes in India. So these are the 5 unique clusters identified in Scandinavian population. The unique clusters to India being severe insulin deficient diabetes, mild age-related diabetes, and insulin-resistant obese diabetes, and combined insulin resistance and deficient diabetes. 3 and 4 are unique to Indian population. So this is what we are discussing. This is the common South Asian phenotype. They'll get diabetes at a younger age with a lower BMI, and there is a rapid decline in the beta cell function, low levels of adiponectin, and increased non-alcoholic fatty liver disease, increased abdominal and visceral fat, and low muscle mass and low vitamin B12 and D. So this is the new clusters identified in India. The most common, like severe insulin deficient diabetes and insulin resistant diabetes, constitutes almost 25% each. And the most common thing is mild age-related diabetes. And this combined insulin resistance and deficient diabetes is only 12%. The importance of classifying the diabetes is like the treatment differs depending upon it's like insulin resistance or deficient. The more the deficient, the earlier the insulin initiation for a better glycemic control. So it like the classification helps to plan therapy based on the pathophysiology and helps to predict the prognosis and prevent diabetic complications. If we notice here, like certain type of diabetes has like certain risk of complications, like retinopathy is more in insulin deficient, and nephropathy is more in combined insulin resistant and deficient diabetes. So depending upon that, we can like focus on the complications to prevent it. And the other common diabetes in young is monogenic diabetes, defect in a single gene rather than our common garden variety diabetes and type 1, which is a polygenic. So this is briefly the 4 types of monogenic diabetes we have. And the common thing, how we diagnose is, the only thing is by genetic analysis, which is expensive, and we are not like, it's not done in a more frequent way. And if we identify it's like a MODY rather than on insulin, like certain types of MODY well responds to sulfonylurea. That is the only thing we can do. We can switch off from insulin to sulfonylurea in these individuals. And another important thing in classifying it as MODY is C-peptide. The value of C-peptide is adequate in diabetic individuals with MODY. So urinary C-peptide creatinine ratio more than 0.53 rules out like insulin deficiency. It is used to distinguish between type 1 and monogenic diabetes, which will be shown in the next slide. So this is a common approach to young diabetics presenting less than 45 years. So if it is less than 6 months, definitely, no doubt it's a neonatal diabetes. And the presentation itself is DKA and antibody positive. DKA and antibody positive, definitely type 1. And if the C-peptide is adequate, even beyond the 1 or 2 years, then we can consider it as MODY. And coming to this part, like if the C-peptide is adequate with no features of insulin resistance and paternal diabetes with deafness and maternally inherited, we'll consider it as mitochondrial diabetes. And insulin resistance without obesity with abnormal fat distribution, we'll consider it as severe insulin resistance syndrome. So this is like a flow chart from a newer article. It's like how will you approach an individual with suspected type 1 diabetes. So if we suspect it's a type 1 diabetes, if it is antibody positive, so there is no doubt it's type 1. And if it is negative, then considering the age. If the age is less than 35, and there is a strong family history and features of monogenic diabetes, then we consider testing for C-peptide. If the C-peptide is adequate, like more than 200 picomoles per liter, then genetic testing for monogenic diabetes. And if the C-peptide is less than 200, we still consider it as type 1 diabetes. And coming to the second half of the flow chart, more than 35, and it is unclear whether it is type 1, type 2 or MODY, then we consider repeating the C-peptide. That is, we are not able to withdraw the patient from insulin even at the end of 1 year and 2 years. We consider repeating the C-peptide, and if the C-peptide is adequate, more than 600, it's still type 2. And if it is less than 200, it's like type 1, and in between, it is indeterminate, and we are going to repeat the C-peptide again after 2 to 3 years. So coming to the risk assessment, it's like from ADA 2023, we need to screen children who entered puberty or after 10 years of age who are obese or overweight with one of the risk factors. We need to screen. The screening should be started from 10 years of age. The risk factors being maternal history of diabetes or gestational diabetes, family history of diabetes in first or second degree relatives, and the signs of insulin resistance. So the screening should be started in obese children as early as 10 years. And if the tests are normal, we consider to repeat at a minimum interval of 3 years. And the normal, as an adult test, we use only fasting plasma glucose, 2-hour plasma glucose, and HbA1c. And in an Indian article like Anup Mishra et al., it is recommended screening should be started from adult diabetes from 25 years rather than like 40, like before the ADA article which shows in 5 years back, it's like screening regularly from 40 and 45. Now the screening time decreased to, like age decreased to 25 years. So coming to the diagnostic dilemmas in especially children and adolescents, HbA1c validity is questionable. And fasting and OGTT criteria are not validated in youth. And CGM, the abnormal HbA1c is associated with overall and night hype time average sugar, whereas abnormal OGTT is associated with more time spent above normal range. So coming to the priorities in the management, obviously the lifestyle modification will be always the first option, followed by pharmacotherapy and metabolic surgery, and management, prevention and management of complications. The goals are the same as like on adults, less than 7, HbA1c less than 7%, and the more stringent goals less than 6.5% for diabetic individuals with a short duration, lesser beta cell dysfunction, and significant weight loss with lifestyle modification. And this in today's study, which is done in young population, hypoglycemia is rare in adolescents with type 2, even with insulin. So the thing is, even with lifestyle modification on metformin, if the HbA1c is more than 6.3, it clearly indicates, increased risk of like poor glycemic control, and it indicates beta cell dysfunction. Earlier the beta cell dysfunction and rapid progression to be on insulin. Coming to the lifestyle modification, similar to that of adults, comprehensive lifestyle to lose 7 to 10% of weight, and moderate to vigorous intensity exercise 30 to 60 minutes, at least 5 days in a week, and decrease calorie dense food. And this is like an article published in Frontiers of Endocrinology showing the role of yoga in improving the glycemic control. So as it is similar to the, every physical activity, it improves the insulin resistance. At the same time, vagal stimulation decreases the inflammatory cytokines and blood pressure. Coming to the pharmacological approach, so this is from the ADA 2023. So young diabetics with a HbA1c less than 8.4% with no ketosis or acidosis will initiate with metformin as adults, and we can titrate up to 2 grams. And if the HbA1c is more than 8.5%, along with metformin, we'll initiate with a basal insulin of 0.5 unit per kg and titrate. And if the adults presents with DKA or hyperglycemic state, we'll treat it as normal with IV insulin followed by basal bolus regimen. And now, if we get the pancreatic autoantibodies done, if it is positive, we'll treat it as type 1. And if it is negative, we'll just continue with metformin. And if they are not able to maintain adequate glycemic control with a basal insulin, we'll add prandial insulin. And the recent guidelines show glucagon GLP-1 analogs are approved in children more than 10 years of age. So liraglutide and once weekly exenatide are approved for the treatment of diabetes in children more than 10 years. So despite on metformin and basal insulin, and if we couldn't achieve the good glycemic control, liraglutide is approved. Coming to the role of metabolic surgery, yes, children with a BMI more than 35 with poor glycemic control despite on metformin and insulin. So the next option will be metabolic surgery, and the outcomes being there will be remission of diabetes and improvement in the glucose homeostasis, resolution of sleep apnea, and improvement of NAFLD and CVD risk factors. So the diabetes remission rate is 68 to 100%. So coming to the complications, so starting with nephropathy, as we said, the earlier the onset of diabetes and poor glycemic control, earlier the onset of complications. So blood pressure more than 95th centile for the age, height. So we'll try to manage with a lifestyle modification. If still at the end of 6 months, it's more than 95th centile, consider adding AC inhibitors or ARBs. And as adults, the protein intake should be restricted to 0.8 gram per kg, and urinary albumin creatinine ratio and EGFR and potassium annually. So this is a new thing, estimation of serum creatinine and cystatin C, which we normally don't do. This is advised in ADA 2023. This can be done as in a regular routine. So in a non-pregnant youth with diabetes and hypertension, when do we consider adding AC inhibitors? When there is albuminuria, more than 30 mg of milligrams per gram creatinine, and strongly recommended if it is an overt nephropathy. And this is nothing new. Neuropathy screening as in adults, annually and regular examination. And in the SEARCH study, the incidence of neuropathy in young adults is around 26%, and more than half of them has autonomic neuropathy. So the prevalence of neuropathy in Indian cohort is 3% when the duration of diabetes is less than 5 years, and it is increased to almost 50% if it is more than 15 years. And retinopathy is also same every year. And the thing is, if the patient is very stable, we can have a examination once in 2 years. Coming to the NAFLD, which is just a most neglected one. So routinely we can have a AST, liver enzyme test, once in 1 year in type 2 individuals, because now NAFLD is very prevalent, because most of them, even they are not obese, with a lower BMI also, they have abdominal adiposity and fatty liver. So AST and ALT annually, and type 2 diabetes in young has a more risk to progression to fibrosis, cirrhosis and hepatic failure. Ultrasound abdomen is less sensitive. Elastography is useful for advanced fibrosis and cirrhosis, and always liver biopsy is standard. Weight loss is most effective treatment. The other treatments being metformin, vitamin A and cysteamine has no, it's no clear benefit. And the other complications, OSA, coronary vascular disease, PCOD are the other complications of diabetes in young. And the thing is, the oral contraceptives, it's not contraindicated for PCOS treatment, even they have a mild NAFLD. And definitely metformin has a role, even there is no dysglycemia in type 2 diabetes, to improve the menstrual irregularity and hyperandrogenism. And the other important metabolic component that need to be addressed is dyslipidemia. So it should be screened once the patient achieve a good glycemic control, and then annually. And the goals are the same: LDL cholesterol less than 100, triglycerides less than 150. And if the LDL cholesterol more than 130 milligrams per deciliter, should achieve good glycemic control, and despite regular dietary counseling, if still the LDL is more than 130, we need to consider adding statins at the end of 6 months to maintain LDL less than 100 milligrams per deciliter. And the triglycerides, if the fasting triglycerides more than 400 and the non-fasting more than 1000, we need to optimize glycemic control, and we need to start fibrates to maintain triglycerides less than 400 milligrams per deciliter to prevent pancreatitis. And routine screening for cardiovascular evaluation for cardiovascular status is not required in young with diabetes. But this is what we are discussing. Even the duration of diabetes of type 1 and type 2 is similar. The risk of cardiovascular complications, atherosclerosis, is more in type 2 diabetes. And finally, the conclusion is diabetes in young is a unique clinical entity, and diagnosis and management requires a holistic approach. It has a long-term implications. We need to have like a country and population specific guidelines, because the type of diabetes is different in different regions. And definitely healthy lifestyle plays a role. Yeah. Thank you.
Very nice lucid talk by Dr. Ramya, ma'am. House is open for questions. Any questions, please?
Type 1, sir. Most of them present macrovascular, no, they generally present with a micro. At the end of second decade, they generally present with cardiac events. We never, peripheral artery disease is also very common. I couldn't exactly figure it out the number, but it's common after second decade.
I had a patient, she is 13 years old, and she developed CVA, and she is type 1. And I want to know whether we can, these clusters can be classified in the young also. You told about the clusters.
Sir, that is more to the type 2 diabetes rather than type 1.
Thank you.
Yeah.
Good morning, madam. Do you want to add anything related to the post-COVID era with increased incidence of type 2?
Yes, sir, definitely. We saw number of cases previously with a good glycemic control, HbA1c at the time of diagnosis of COVID being also less than in the non-diabetic range. Along with the steroids, yes, we saw a number of cases even without steroids per se with a COVID infection presenting with diabetes. It's type 2 diabetes only because they respond well to the OHS and metformin. We don't have any study or something, but definitely we saw type 2 diabetes per se with a COVID infection even without any treatment of steroids or remdesivir. As we know, the viral infections per se is one of the etiology, but they are not type 1. Surprising. Type 2.
Yeah, according to newer classification of WHO, slowly progressing type 1 and hybrid diabetes, these two has been included in the classification. Hybrid diabetes, how often do you see? Like these children are not dependent on basal bolus regimen and not even surviving without insulin also. They are requiring small quantities of insulin. And of course, insulin sensitizer like metformin has to be added. These hybrid DM cases, the clinical course, how it will be now?
We need to manage with, with the stringent goals of less than 6.5 to 7%. There are many young individuals, yes, with metformin and maybe like a beta cell deficiency. They require small dose of insulin. It's like a same thing like an adults. With the stringent goals, we can manage them long term and prevent the complications.
In those cases, we will have a doubt like at what age group we can start like gliptins or sulfonylureas. Only we are left out with options with metformin and insulin.
Above 18 years, we can start gliptins. But GLP-1 analogs are approved more than 10 years.
About 10 years now, this one. This slowly progressing type 1, this C-peptide, how often do you like, those patients who are presenting with DKA, but still they require less quantities of insulin, their C-peptide levels are not too low, they are not negligible, they are somewhat detected. Yearly we have to check
that is what in the newer guidelines they said to repeat once in 3 years.
Once in 3 years.
3 years, not yearly.
Because nowadays these cases are rising like they are not dependent on basal bolus regimen. Even BD premix insulin also they are getting controlled. Even if you try to switch to basal bolus, we are getting hypos sometimes. That's why.
Once in 3 years as well.
Thank you.
I have one question, ma'am. We see many day-to-day practice lean diabetics, and in the middle age, around 30 to 40, we have, as you told, type 2 diabetes with SID variant versus it may be LADA also or MODI also sometimes. So apart from genetic test, because MODI responds better with sulfonylurea, LADA we have less result to start insulin type. So apart from genetic, what other, throw some light on how to approach?
Apart from genetic, maybe C-peptide can help us. Strong family history and C-peptide may help us to differentiate whether it type 1, type 2 or...
C-peptide relatively usually preserved, not very low, it won't be not very low and not high enough.
C-peptide adequate, more than, according to our values, more than 0.6 nanogram per ml. It's adequate C-peptide. We cannot classify it as type 1, MODI bar type 2. Considering... yes, any with more 18 years, greater than 18 years, we can start SGLT2 inhibitors. After, I'm not sure. It's not given, sir. In the 2023 guidelines also, it's only GLP-1 analogs are approved.
Can you throw some light on usage of aspirin in type 1 diabetes?
Aspirin, sir, yes, asymptomatic, we are just not screening with. We are not sure unless they have a very strong, like even in a young, if they have hypertension, dyslipidemia, and a strong family history of coronary artery disease, then we can start ecosprin. I'm not, if you can.
That's same as type 2?
Yes, sir, same as type 2. But actually, it's not very clearly mentioned in any other guidelines to starting. But strong family history with all the metabolic features, we still can start.
I can close the session.
Yeah, thank you.
Thank you, Ramya, for the wonderful presentation. Next, I would like to invite Dr. K. Srikanth, sir. Sir, consultant endocrinologist, Endolife Hospital, Guntur. Sir is the first endocrinologist in Guntur. And also Dr. Makineni Ashok, sir. Sir is consultant endocrinologist at Ashok Diabetes and Endocrine Center, Guntur. So the next topic will be on remission of type 2 diabetes, facts and myths. So I would like the chairpersons to introduce the speaker.
So introduction of Dr. Deepthi. She graduated MBBS from Rangarai Medical College and did a PG in Pediatrics from Andhra Medical College. She did a DM Endocrinology from Andhra Medical College. So now she is practicing at Pinnacle Hospital, Visakhapatnam, under Coastal Diabetes and Endocrine Center, Visakhapatnam.
Good morning, everyone, and warm greetings. I would like to thank our chairpersons and the organizing committee who has given me this opportunity. Now, the topic here is diabetes remission. What are the myths and what are the facts? There have been tall claims about diabetes remission in the media, where people have claimed that certain type of diet can cure the diabetes. Like some would claim that the millets can completely cure the diabetes. Some would claim that the fruit juices will completely cure the diabetes. There have been several claims, mostly by the non-medical persons, who have said that the diabetes can be cured with their magical program or magical remedy or pill, whatever it is. So let's see what are the truths and the myths behind it. I would like to cover my topic in this. How do we define the remission, if there is one? What are the interventions that have been done that have resulted in the diabetes remission? What are the mechanisms for the remission? How do we diagnose that the person is in remission? And how do we follow up these patients who are in remission? Diabetes remission is defined as abatement or disappearance of the signs and symptoms of diabetes, and it implies that the diabetes is not active and progressive, but the improvement may not be permanent. So just like a patient who is in remission, a cancer patient who is in remission, there is still a chance for this patient to go back to the disease state at any point of time. And so the person in the remission, they require ongoing monitoring and support to prevent the relapse. Diabetes reversal, it is the process of returning to glucose levels that are below the diagnostic thresholds of diabetes. The terminology that we should avoid is diabetes resolution, which implies that the initial diagnosis may be wrong, or the patient has been completely cured, or their permanent disease-free state has been established. So that we need to avoid telling a patient that your diabetes is resolved when they go back to their normal glycemic levels. And another term to avoid is diabetes cure. So people may think that the diabetes has been cured, they can lead however, eat however they want or whatever they want, and they can fall back to this diabetes again. And there are few more subclassifications of this remission. One is partial remission, where the patient's glycemic control has been below the diagnostic level of diabetes, but still they are not in the normal range. This is similar to our pre-diabetes state. And the complete remission is patient who has gone into normal glycemic levels without any diabetic medication for at least 1 year. Prolonged remission is complete remission, that is maintaining normal glycemic levels for 5 years and beyond. From the Wikipedia's, what we know till now is type 2 diabetes is a progressive disease, and it is caused by a combination of insulin resistance as well as insulin deficiency due to beta cell defect. And even with our best efforts and the evidence-based therapies, 50% of the patients that are diagnosed with type 2 diabetes eventually will require insulin for their optimum glycemic management over a period of 10 years. So this has been challenged by few of the findings, that there is remission of diabetes after the bariatric surgery, and after Roux-en-Y bypass, there is 30 to 63% remission after 1 to 5 years after the surgery. The highest remission rates are seen after the biliopancreatic diversion, followed by the Roux-en-Y bypass, then the sleeve gastrectomy and the gastric banding. So the normalization of glucose levels in these patients were seen even before there is a significant weight loss. And the fasting plasma glucose normalized earliest. the weight loss the glycemic improvement that is seen after the bariatric surgery was thought to be due to the incretin effect, and the fasting plasma glucose that is normalized earliest doesn't depend much on the incretins. So there has been a search for a mechanism that is beyond the incretin effect. And the glucose levels were also improved in one patient where the surgery was cancelled because of some complication, but still the patient improved because the patient continued to be in the same protocol in the post-operative period. So it implies that there are mechanisms that are beyond incretin effect, which were thought to be due to the reduced caloric intake during the post-operative period. So this has led to the three wonderful studies. One is counterpoint, counterbalance, that followed by the direct studies. In the counterpoint study, if you see, the duration of diabetes is less than 4 years, and these patients were on either diet or metformin. When these people were given soups and shakes diet with only 600 kilocalories of caloric intake per day, they could have a weight loss of approximately 15 kilograms, and they all responded by normalizing their glucose levels. So in the counterpoint study, there is 100% remission rate. And in the counterbalance study, there is counteracting the beta cell failure. So what has been thought as, even in the previous talk where we have seen, there is insulin resistance and insulin deficiency. Once there is insulin deficiency, then the patient has to be started on insulin, and it is a progressive course. In the counterpoint study, there is complete remission, 100% remission, and in the counterbalance study, where the duration of diabetes ranged from newly diagnosed to up to 23 years of duration of diabetes, there were still responders in these, and the approximate weight loss in these also around responders, it is 15 kg. In the counterbalance study, what they found out is the shorter duration diabetes, where the participants had diabetes for less than 4 years duration, they had higher rates of remission compared to patients who had diabetes of more than 8 years duration. And in the direct study, it is mainly by primary care led diabetes remission study. In this, they've given again the meal kits containing either shakes or soups. They have to take these shakes and soups for approximately 8 weeks, and followed by there is gradual reintroduction of the normal diet, and they have been followed to maintain this, whatever the weight loss they have achieved, they were followed to maintain this weight for 12 months. Again, they were followed. The responders who have lost more than 15 kg weight, they could go into remission, and the remission rate here is 64%. So there is a new ray of hope that once you are diagnosed with diabetes, it is not the progressive course. It can be reversed, or it can be put into remission. And the durability of these results, so is it only for the study period? What about their durability? When we look at this, there is a remission even in patients with less than 5 kg weight loss, and the highest is with 15 kg weight loss. The absolute, so there has to be a magic number that the 15 kg weight loss would ensure diabetes remission. But nevertheless, there are people who remitted even in the control group, but they've lost less than 5 kg. And these remission rates were sustained if the patient did not regain the weight that they've lost during the study period. And in this, we can see that the 45.6% who are in remission at 1 year, and it has declined to 35%, and those who could not maintain the remission were the ones who have regained the weight of approximately 6 kilos. So, till now we've seen that whatever they've done, it is a drastic dietary approach, where they've gone for a meal replacement therapy of over 8 to 12 weeks, and they've lost a significant amount of weight. Another studies, since this was done in UK, and there was few more that are replicated. Diadem study was done in the Middle East, and even in the Middle East population, there is a significant weight loss which has resulted in resolution. In the intervention group, there is remission of approximately 61% at 1 year. In the Verta Health, where they followed the ketogenic diet, and they were given virtual assistance to maintain a healthy lifestyle and also to engage in a physical activity, they could achieve 17.6% remission at 2 years and 25% at 1 year. And so, for remission to occur, there has to be some substantial intervention, either in the form of a metabolic surgery or a low-calorie diet, and sometimes it has been done with meal replacement with liquid calorie diets for a few months. So, what has resulted in this reversal? So, the main premise for this studies is the twin cycle hypothesis. Till now, it has been postulated as insulin resistance and insulin deficiency. In the twin cycle hypothesis, there is a calorie excess over a period of years which accumulates in the liver, which results in the hepatic insulin resistance. The main purpose of the liver is continuous glucose production. This continuous glucose output is restrained only by the insulin action. So, because of the insulin resistance at the level of the liver, there is slightly a higher glucose output from the liver, which will prompt the beta cells to produce higher amount of insulin to curb this glycemia. So, the hepatic triglyceride accumulation or fat accumulation resulting in the hepatic insulin resistance will result in increased glucose output followed by the fasting hyperglycemia, as well as initially fasting hyperinsulinemia. Once it fails, there is fasting hyperglycemia. With the positive calorie balance, in this we can clearly see the point to note among these two pictures is there is a positive calorie balance with the pre-existing muscle insulin resistance. There is accumulation of liver fat with increased glucose output from the liver, which will drive basal insulin secretion to go up. With eventual fat accumulation, there is also fat accumulation elsewhere, that is in the pancreas itself, pancreas also. We know that acute phase insulin response is decreased by the fatty acids. So, prolonged calorie excess with ectopic fat accumulation both in the liver as well as the pancreas will eventually decrease insulin production from the beta cells. So, once there is a drastic weight loss or with calorie restriction, there is redistribution or there is loss of this ectopic fat. Mainly the ectopic fat is lost from the liver initially, where the changes are seen within 1 week. So, once there is establishment of these low calorie or extremely low calorie diets, there is decrease of hepatic fat within 1 week from 12% in the pre-intervention to 3% after 8 weeks. And it has started from week 1 itself, which has resulted in normalization of the fasting plasma glucose as well as the normal basal insulin secretion. With continued intervention, there is also decrease in the pancreatic fat that has resulted in normal first phase insulin response, which has been never heard of before, where we've thought that once the beta cell defect is there, it has been considered progressive. So the difference between the normal person and the person with the diabetes is there is fat accumulation in the liver, which results in the hepatic insulin resistance with higher glucose output and higher plasma insulins. With weight loss, there is decrease in the body weight resulting in normalization of the liver enzymes. So it has been postulated that hepatic insulin resistance is the primary culprit that will drive all other pathogenic mechanisms in the type 2 diabetes. And the thing that to be noted here is that the beta cell function has continued to improve even beyond 8 weeks until 1 year. In this, where we have seen, even in non-responders, the hepatic fat as well as the pancreatic fat, they both reduce, but the insulin response, first phase insulin response is seen only with the responders. So it can be maybe because of the longer duration of diabetes, or there can be genetically these people have a lower beta cell reserve or insulin secretion capacity. What has been thought till now is like with onset of diabetes, there is a progressive decline with apoptosis or death of the pancreatic beta cells. But these findings again conclude that there can be redifferentiation of the. It is not due to apoptosis of the beta cells, but it is due to dedifferentiation, which can go into redifferentiation, so which keeps on improving over a period of 1 year. Even beyond the intervention period, it kept on improving. This has come from the study where they've seen that the first phase insulin response kept improving even up to 1 year. And there is also another thing that where we have seen, though the counterpoint, counterbalance and direct studies, in all these studies there has been a good chunk of weight that is lost, which is 15 kg. All the responders have lost 15 kg. But there are few who have lost less than 5 kg, but still they went into remission. So, and also till now we consider that overweight and obese individuals will certainly have insulin resistance. With this, we came to know that there is a personal fat threshold where a few people can carry around extra pounds and still can be metabolically normal, and few can be in what is now considered as normal BMI, but still then can have metabolically unhealthy obesity. And if total body fat falls and it is sustained for a period of time, and the remission can be sustained. Remission is possible with weight loss, and remission is seen with even with less than 5 kg, though it is small, and it keeps increasing with weight loss with 86% at 15 or more kgs of weight loss. And people who reversed it kept it if they did not regain. And reduction in the liver fat and fasting plasma glucose was seen within a week's time, and first phase insulin response recovered with the decrease in the pancreatic fat. As I've told earlier, it is due to the redifferentiation, which was never thought till now. So in all these people, it is the duration of diabetes. The lesser the duration of diabetes, they had better results. Those are overweight or obese individuals, once they lost the weight, they had remission. And in all these studies, they were not on any insulin therapy. So let's see if there is something else. To whom do we consider remission? So in this picture where we have seen, at the time of diagnosis, probably there is some beta cell failure, which may be due to permanent beta cell loss, but not all is lost. And in the initial period, people can be tried for remission. And with the progress of the disease, there is a irreversible damage either due to lipotoxicity and the glucotoxicity, or they inherently have a lower beta cell mass. The main, can any duration of diabetes be offered remission? In people with longer duration of remission, there are few responders. So even though the guidelines still say less than 6 years, there are people who responded to extreme calorie diets even though their duration of diabetes is more than 8 years. And should everyone be on these meal replacements? In this Chinese study, what they've done is Chinese medical nutrition therapy. There is 5 days of modified fasting where they've given 840 kilocalories of meals, then 10 days of ad libitum food intake, then again 5 days. So, and it has continued for 3 months of period. At the end, they've noticed that there is, after 12 months of follow-up, there is 44% remission. The thing that we need to look here is the BMI of these patients ranged from 19.1 to 30.1. So people whom we think as normal BMI still underwent these trials and they could see remission. And in the study that is done in Bangalore, in the new onset, newly diagnosed diabetes, patients some were on insulin. And also, if you look at their glycemic levels, the fasting at the baseline was 220 and the postprandial was 340, their A1C was over 10. So the studies that were done prior, they were never, the exclusion criteria was more than 9, it is excluded. But in this study where even with 10, they went into remission with 5.9 and 5.9 at 1 and 2 years of the follow-up. So remission can be possible even if patients are on insulin, even with a higher HbA1c. And if you notice here, the responders and the non-responders, those who had reversal, the only significant change is significant weight loss between the responders and the non-responders. So probably one can try even in high glycemic, even with high glycemic levels, they can still be considered for remission. And around 50% of people from the direct trial we have seen that 50% could not achieve remission. And even those who could achieve remission at 1 year, which is 46%, 2/3 went into relapse and they could not sustain it beyond 2 years, or they could not make it till 2 years. And another study where we have to glean some insight is from Look Ahead trial, where they've seen intensive lifestyle intervention was not clinically significant in reducing the events when compared to standard care. So do we say that the intensive lifestyle intervention is not effective? Not so. But those who were followed with pharmacological management also, they also did well, on par with intensive lifestyle intervention. So how do we follow these patients? So do we, as we know that diabetes management is multi-pronged approach, not just the glycemic approach. So patients who already are on therapy for secondary prevention, those who had myocardial infarction or any atherosclerotic cardiovascular disease, in these patients the disease that can be modified with the OHAs or injectables like GLP-1 analogs and SGLT2 inhibitors, in these patients, though the remission by definition is without any anti-diabetic medication, these patients can be continued and they may gain more benefit by continuing the GLP-1 analogs and SGLT2.
Sum it up. Here. You can sum it up.
Yeah.
Time is...
Yes, almost. So the take-home message is remission is not cure, and rapid weight loss with extreme diets could be done, as it was stated earlier. And rigid diet was easier to follow as stated by the participant rather than when they were in the follow-up. Any macronutrient composition and any diet style can be followed. Yes. And remission can be achieved even in patients with longer duration of diabetes. Thank you.
Excellent presentation, Dr. Deepthi. So I invite any audience to have at least 1 or 2 questions.
In the same studies, sir?
What are your view on total fasting of 2 days of 1 week, once in a week, 2 days total fasting? What are your views, madam?
Total fasting, like it was done either as an alternate day fasting with on the day of fast, the modified fast, where they've allowed like 500 kilocalories, and the next day is ad libitum. So alternate day, or it can be 5 days of restricted and 2 days of ad libitum, or 2 days of restricted and 5 days of ad libitum. It was done in a different styles. As long as there is net calorie deficit and there is weight loss, there is definitely a metabolic improvement, both in terms of glycemia as well as hypertension and dyslipidemia.
What is your take on total? You agree with regular restriction or total intermittent, total free of food or food?
It's not whether I agree or not, sir, but the data has shown that it can be done in any way, and people have shown results. Even the initial study was with only 600 calories, which is considered like moderate or modified fasting. With 540 calories, it is considered as modified fasting. Even with 600 calories, they did for 8 weeks and they went into remission without any complications. Even in the non-responders, there is 50% reduction in the medication usage. So even though these look scary, the extreme diets look scary, but still they can be. There is only one which I would like to bring to your notice, sir. One lady who is 88 years, who tried this extreme on her own, she ate like 1 to 1.5 kilos of raw bok choy, and she went into mixed edema coma. It has been published in NEJM. So these can be done, but under supervision.
Thank you.
Yes.
You mentioned 3 studies. One is counterpoint, am I right? First one?
Yes, sir.
And second, last one is direct.
Yes, sir.
How did they achieve 100% in counterpoint? But this direct shows only 64%.
Yes, sir.
So what it was done in counterpoint? How they did it?
One reason could be, sir, they were treated only with diet and metformin in the counterpoint, and the duration was only 4 years. In the direct, it is 6 years, and maybe it is there is discrepancy, or there is genetic. There is certainly a genetic component with beta cell reserve and beta cell response. That could be one reason. And the calorie wise, this is 600, that is 840, 800 to 840. I do not think there is a significant difference because the weight loss is slightly higher in direct compared to counterpoint. Direct is a larger scale study. It involved 300 plus individuals, whereas counterpoint is a very small study. It's a pilot study. So
do you think we can do direct studies in India? Because it's very good. 64% of the people,
yes, sir,
they attain. Why it is not popular? Why many people are not doing that?
We'll close the session.
Yeah.
Thank you, sir.
So, thank you, Dr. Deepthi. So, the next session is on role of technology in the management of type 2 diabetes, diabetes mellitus. The session is chaired by Dr. V. Suresh sir. Sir is Professor and HOD of Department of Endocrinology at AIIMS Mangalagiri, and Dr. Shravani madam. Shravani, she's a consultant endocrinologist from Vizag. So, I would like the chairpersons to introduce the speaker.
So we have Dr. Abhijit Bhograj to talk to us about diabetes technology in diabetes. He is DM Endocrinology from MS Ramaya Medical College, and he has received an award, Inspiring Endocrinologist of India, and currently is working at Bangalore in Columbia Asia Hospital. Over to you, sir.
Thank you, sir. And thank you, Andhra Pradesh Endocrine Society, for giving me this opportunity. Thank you, Dr. Srikanth, for inviting me to come here and speak to all of you all here today. So this whole topic and aspect of what we are technological problems. So yeah, I think the slides are not changing. So being over-dependent on technology is also a problem. So to start off, what was the journey that led to me looking at these aspects of what we can do with the role of technology in diabetes? Well, I'd like to take you back probably 7 years, where the use of the Libre Pro started to become more and more popular. And what that did when we started to see that much amount of data with regard to diabetes, it kind of changed the whole aspect of what we were seeing about the patient. Otherwise, they used to come with one single report, fasting PP, or even no report also. They'll just come and say, please take care of my sugars. So we were able to manage diabetes with very little information. And then when we started to layer in CGM, it started to give us a different understanding of what was going on with our patients. So the solution that we started to work on 7 years back was to get all this data, to make sense out of this data. Now we are also experimenting with non-invasive sensors as well, which looking at sweat. Right now the accuracy is not that great, but I'm extremely confident, and these sensors work for 3 months. So now with the current sensors, IoT sensors, we have only which are working for 14 days, but now for 3 months we can give you continuous glucose data of our patients. So using all this information, using this learning, we are now beginning to make sense of what is going on with our patients. I'm sure all of you will agree with me, these are the basic pillars. There's nothing new over here. But the point I want to make with this slide is, it takes 1 hour, 60 minutes or even 2 hours to take the correct history with regard to the lifestyle of our diabetic patient. Spending 5 minutes is not going to do justice, but it takes that 1.5 hours. So where am I going to get this 1.5 hours? I don't have it. So that is where technology is going to come in to help us to make a difference. And that is what we are talking about when it comes to an analytics platform. An analytics platform collects all this information. And when we look at the 7-sugar platform, what all are the information we are collecting? From the glucose data comes in from your glucometer, it could come in from your CGM, it could come in from any device that is capturing the glucose readings. We are looking at your physical activity. All of us have smartwatches. Your phone itself is a good enough device to tell me about your physical activity, what needs done. When I'm going to sleep, the sleep data. Now the smartwatches, again, they analyze sleep data. But the phone itself, putting the phone to when you're going to bed and when you pick it up in the morning, that kind of behavior we are seeing with most of our patients. So we are able to analyze sleep data with very little information. I don't need too much of gadgets or gizmos. The phone itself does everything. The most other important part is the food. Just by looking at photographs, we are able to tell a lot more of our information about our diabetic patients than what we were able to do before, because they lie all the time when it comes to the food. So using all this information, we are set up a rule-based analytic system. This is all what we have learned from the textbook. We are telling the machine, this is the guidelines, this is the range you're going to be looking for, these are the changes, and if the ranges are varying, then you're going to give me an alert. And that is when the bots start to come in to tell us this is what is going on. So that is the basis of any technology-based system what we are seeing. And when you get all this information, the intelligent part of it is how we report this data. And all of us have been trained to look at a report and make changes. So that is the whole aspect of what we are looking at. So let me start off the first aspect of food. And I think food plays obviously one of the most important aspect about diabetes management. So what we did, and because we have this much of data points, we are able to constantly look at our own patients' data on multiple. So we took a 30 patient subset, and these individuals were already stabilized with their medication. So they were on constant medications. All we looked at, were they eating more carbohydrates or less carbohydrates, split them into two groups. And what we found, just by reduction of half a idli, one chapati for some individuals, half idli for some individuals, around 12 grams to 15 grams of carbs per meal reduction, we were seeing almost around 40 to 50 reduction in their average blood glucose. Again, we know this information, but what is the importance of this? Now we have the technology to capture this point and to relate this with our patients. So you're eating this much less, one chapati less is equal to this much of glucose reduction, which you can average throughout your whole day. And that is where we are starting to make these correlations. What works for one individual may not work for the other individual. In an early stage of diabetes, even if I reduce that much of carbs, I'm not going to see that much of a spike. So what difference does it make there? Again, if you are overloading on carbs, I know in matter of time when the duration of diabetes increases, it is going to further increase. So that is what we are looking at when it comes to simple aspects of carb, understanding the whole correlation between the meal and the rise in glucose. People will come and argue all the time, I'm eating the same thing, why do I need to speak to the dietitian? I'm like, this is not to teach you something new. It is helping you to understand at this point of time, your body is reacting in a certain way. 6 months from now, your body is going to be reacting in a different way. So before this, what was your body reacting? That is what we are using the technology to capture, lock in, understand of every individual. So we are personalizing the diet on that level. So when they came down on their carbs, obviously medicines also came down. And when they start to see this kind of improvement, when you give them this information about their own body, they are listening to us a lot more seriously. Time in range went up by around 6.4%. And when you talk about any changes, the variability also starts to improve when it comes to stabilizing, eating correctly, following the patterns. Same thing, whatever we are recommending, but now we are correlating it with how their body is reacting, showing them evidence, this is the change that is happening, locking in these numbers. So the platform will lock in. At this point of time, you ate this much of carbs, this is the kind of reaction I can expect. So when you have all these data points, that particular individual you are able to understand with a certain type of a carb load. So that is the level of understanding we can personalize our diabetes management without us having to remember anything. So the platform will do everything the same. Next, when we have this many data points, when it comes to eating patterns, what we started to realize, not only are we making what we are seeing changes with regard to the variability, meal time variability, a 20-minute change in your meal time. So if I'm eating every day, and when you look at lunch or breakfast, a 20-minute meal time variability led to a higher glucose variability in those individuals that we were looking at 20 minutes. Some individuals at 40 minutes, if they change their meal time every day by 40 minutes, we were seeing the variability for the next 12 hours increase in these individuals. Again, this is not something we can practically do in a clinical scenario. That is where technology will start to come in to make, and that is what we are seeing, the correlations. In the beginning, the correlations will be there will not be there with the carb, but when you have this kind of inputs of breakdown of how HbA1c changed, what is the raise in glucose, what are the points of variability that changed, then you have a pattern with certain types of meals. And once you not only are able to get quantitative and qualitative, you make these patterns of these individuals, and once you know they're consistently eating in a certain type of pattern. So what we saw in the same subgroup, around 80% of them were taking higher carb load. We all know that majority of Indians eat, but Do you know which patient is high and which patient is not? 20% of them were eating correctly. So you know, once you have this kind of eating pattern, you are profiling the patient in a different way. You know that this individual eats more carb, particularly at lunch, particularly at breakfast or dinner. You have all these points of information for you to make your clinical evaluation and your suggestions much more better. Protein intake also, when you are starting to see them lose muscle mass, they're getting more and more weak, you already know their eating pattern. So you're not going to spend more time understanding what is their protein intake. The platform is calculating all these data points just by looking at photographs. So first week you can see taking high carb load, 2 types of rice. They think eating brown rice is healthy, so eat more of it, makes it even more healthy. So that is the whole aspect. When you see the plate, you are able to clearly define how much of carb to reduce, what to add, what to minus, and your instructions become a lot more smarter. And once you get a pattern of eating, you know this individual is going to behave in a certain way. And when you add the glucose data to this, at this point of time, the peak happened at 1 hour or the peak happened at 1.5 hours with the influence of the fat or the fiber. So all of these calculations are being done by the platform, in which we are now getting dietary advice on a much more personal level with the help of CGM data and looking at food photographs. Once you get information, you have to report it, and that is what we are doing. So getting the patterns, understanding the individual, locking in the glucose values for different meals, putting it in a report and giving them feedback. If you don't give this feedback, the patients will not engage. You need around 15 photographs for us to make a good assessment of what the typical meal is, and you can do a CGM once in 6 months or a year based on the kind of level of their diabetes duration is. Now moving on to physical activity. All of them are now coming with smartwatches. The data is there on that smartwatch. Or even the step counter on the phone makes all the difference for us to make good clinical judgments and to use that information to see how their diabetes is progressing. So when you look at the higher physical activity, this is a different subset. These were early diabetic and maybe around 10 to 15% of them were on metformin, remaining were only on lifestyle modification. So median age with a highly physical active were a younger population rather than the one who were less active. Again, 20 minutes of exercise. So now again they will argue, I don't have time. I don't have time to exercise. I don't have this. When you present them with evidence, look, in your body, by not being active for more than 3 weeks, this is the weight change you're going to have, this is the amount of A1C change you're going to have. So that is the level of personalization you will be able to do if you're tracking these components, making these correlations with the blood glucose. And so that is what we are able to do because we have the technology to support it. So just by increasing steps by 2000 steps or increasing physical activity by 20 minutes, the group which were more physically active were able to get their weight down by 4.6 kgs and have a better BMI versus the change in body weight in the less physically active. This change in body weight also is part of your assessment when it comes to the follow-up of our patients. So obviously they will have better A1C reduction, but again my point here is, what I want to tell here is the simple aspect. I'm going to motivate the patient to be using more of physical activity rather than going up on the medication. When we present them with the evidence, look, by doing this, this is the kind of A1C reduction you had when you were highly physically active. Now with the body change and the weight gain with lesser physical activity, this is the kind of A1C change that you can expect. So that is what we are learning on an individual level. So we are motivating them to make these changes. Again, if they are not in a physical position to do exercise, what are my alternatives is what we will be looking at. If it is giving us the correlation, then I'm going to find another alternative in order for us to do that. So A1C reduction also, we have proof in our patients. And when it comes to decreased BMI, again, it is known to us. Here, all we are doing is locking in. By creating these patterns, this much of physical activity is required for this kind of weight reduction, and consistent changes, whether you're going up or going down, will change your body weight by X. is what the platform will be able to tell you and report. Same with even glycemic variability. And so what we saw at 20 minutes of intense physical activity, the glycemic variability reduced for another 12 hours. It happened in some people, didn't happen in some people. Again, what was our learnings? It was basically trying to see what is the level of intensity of activity they were doing. They were telling us they're doing physical activity, but we are not seeing that kind of positive change that were there. Then again, we go back and tell them this is the level of intense activity, this is the time for us to do the physical activity, it will give you better results. All of that is possible because you have profiles, you have reactions of how the body is reacting, and you have numbers to present to the user in order for you to make a plan. Next point, we were talking about hepatic glucose output in the night. What we saw in people who had poor sleep, again this is data from smartwatches. What we saw in people who had poor sleep, definitely we were seeing increased variability, higher average glucose levels in these individuals. So tracking sleep is also extremely important. I cannot ignore sleep anymore. It has to be part of my history. And then when the patient is coming back, I have reports about their eating pattern, physical activity pattern, sleep pattern, mood, and definitely looking at symptoms. Then I'm definitely at a higher power when it comes to my treatment outcomes. So that is the power of what data can do to us, and reporting this data in a smart way to the patient as well as to the doctor, it makes all the difference when it comes to what we are seeing in the end of the day. So this micro reporting and smart reporting, that also can be automated, and that is where we are working towards using these smart reports for the patient, making these correlations. All of these are rule-based. These are, as per our guidelines, we are giving them outputs of when they're checking their blood sugar levels, this is what the change that they are. If they're eating in a certain pattern, these are the changes that they need to make. All of it is what we are seeing. And we're coming to a level of artificial intelligence where we are coming to tell you what your future holds for you. That is the level of what technology can bring, and it all starts with the aspect of collection of this data of our diabetic population. And using this inputs from the mobile phones, processing it in multiple EHRs, with an analytics platform, we are able to give you this level of personalization when it comes to diabetes management. And we are moving on to a personalized, predictive, and a preemptive type of diabetes management. So how is now AI helping us? It's able to recognize almost around 60 meals. So what you see on the top, just by taking the photographs, the AI will tell me this is an idli, this many idlis, this many chapatis, but right now it doesn't have the intelligence to tell me how big or small the idli is. So we are still training this AI models to do that. But when I know this person is taking, what is the standard size this person is doing, I'm making logical assumptions. I'm able to quickly generate these reports in order for me to give outputs and changes. So if somebody is eating 6 idlis, I'm able to clearly define that there are 6 idlis, this much is their glucose when they eat 4 or 5 idlis. Again, through calculations, I'm able to tell them, you have to come down on your carb load. So such kind of training can be automated. It can be done with systems which we are building to help our patients. With regard to the glucose predictions also, for the next 3 hours of glucose data, we can tell you where your numbers are, and the accuracy of these prediction models also are improving. With more and more correlations, we are able to personalize diabetes on a scale which has not been seen, and this is extremely important because of the number of cases that we are seeing who require good diabetes management. So this is a simple aspect. Bots are coming, natural language processing is coming in a big way. We are so hopefully next time I'm able to do, I'll be able to present a complete research paper in 5 to 10 minutes because of the data that we have. So that is the level of technology that we have. With regard to the bots are able to give you suggestions. It is able to explain your reports. So it saves us doctors a lot of time. And that is how we are going to be using these new technologies. We don't need to be scared about it, but definitely we are going to see this change in a matter of few months. Impact, I don't want to focus on impact, but what I want to say is we are able to pick up people who are not doing well rather than people who are doing well. So that is where technology is going to help us. All the time we will always like to showcase that we're doing great, this is the impact that we've had, this is the positive things. But how many of our patients are actually not doing well? How many of them are struggling to manage their diabetes? So that is where a platform will quietly be able to tell you these things. Even though we are giving them the right treatment, we're giving them the right advice, but they're not able to do that. So we can focus on this 12% group that are there, spend more time so that we are able to, identify where the problem areas are happening, rather than, be happy with all the patients who are doing well and following your orders correctly. So that is where a platform will help you. It will be able to be mass manage diabetes in a better and more efficient manner is what we are looking at. And definitely AI is going to reduce the challenges when it comes to the time we spend with our patients, and we are able to do this more smartly because it is from every step of our analysis, assessment, and the outcomes, all of it we can take the help of these new systems that are coming into place in order for us to manage diabetes better. So this is our Sunday clinic in Bangalore. We see more than 1,000 patients every Sunday, and in this rural subgroup of patients who come to this center, almost 300 to 400 are diabetics. This is a group of farmer population where we were thinking that again, diabetes is a rich man's disease, but our help, and when it comes to Indian diabetic population, we do need to scale up. We do need to get our minds together in how we are going to challenge this burden that we are all going to be facing. And that is where technology is going to help us. Thank you.
Thank you, sir. Thank you for the lucid presentation. And I have one question for you, sir.
Yes.
What are the practical difficulties you are facing while using this technology in your daily practice?
So,
especially with CGMS and insulin pumps.
So usually what we thought was, when it came to taking photographs of food, quite a lot of the elderly population will not be able to manage that. And so one, age was a definite barrier for us to adopt the technology. And will they be able to use an app? Will they be able to, follow these instructions? So thankfully, what we started to see from when we started off and now, the adoption is improving, and more people want answers to why their glucose is not being controlled. They're not accepting the normal anymore. They want answers, they want information, they want feedback. So it was a challenge in the beginning, adopting the technology, especially in the elderly population. But usually we assign somebody else in the house to help them, and in order for us to get these data points. What we saw was, again, trying to keep it simple, like 10 to 15 photographs of food gives us a good idea of their physical activity. Just keeping the phone, we just activate the fitness part of it, keep the phone in their pocket and tell them to walk around. Then we have a pattern throughout the day what their physical activity is. Basic history, we are able to look at. Sleep part of it, again, just by looking at sleep questionnaires, looking at when they went to bed, woke up, how they're feeling. Simple information like that also is enough of information for us to make our conclusions. And so we felt that it could be a challenge, but I think the world is changing pretty fast. And usually people who find it challenging, we assign somebody else to help us collect this information.
Now the session is open for questions.
They did very good service to people, and he was awarded Padma Shri, right? Your dad.
Yes,
give him a big hand.
Thank you, sir.
Thank you. Thank you.
next will be the inauguration. So, as we are behind schedule, I would like to invite Dr. K.A.V. Subramaniam sir, Professor and HOD of Department of Endocrinology, AMC Vizag. Onto the dais, Dr. Maithili madam, retired professor of Department of Endocrinology, AMC Vizag. Dr. Suresh sir, Professor and HOD of Department of Endocrinology, AIMS Mangalagiri. Dr. Alok Sachin sir, Professor and HOD of the Department of Endocrinology, SIMS Tirupati. Dr. P. Srinivasalu sir, Professor and HOD of Department of Endocrinology, KMC Kurnool. Dr. Jayanti Ramesh sir, Professor of Department of Endocrinology, AMC Vizag. On to the dais. I would also like to invite our distinguished guest, Dr. Nandakishore sir, IMA President, elect President, state onto the dais, and also
Hari.
2 minutes. I would like to invite Senior Endocrinologist Dr. K. Srikant sir onto the dais, Dr. Padmalata madam, Endocrinologist onto the dais, Dr. Satish Chandra sir, Endocrinologist from Vijayawada onto the dais, and our observer for this day, Dr. Nagur Basha, Assistant Professor, Department of Gastroenterology, GMC Guntur, onto the dais. So there is a lightning session, lamp lightning. And
Godavari Express na ticket. Ticket se lebo.
I'd like to request everyone to stand for the prayer session. We shall proceed with the lightning.
गणनायकाय गणदैवताय गण
डाउनलोड चेन मध्ये अरे अभी बस
गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि वक्रतुण्डाय गौरीतनयाय धीमहि
I would like to invite Dr. K.V. Subramaniam sir to deliver a note. Thank you.
Very good morning, respected seniors in the audience, my dear colleagues, and my dear little friends. I welcome you all to this Endocrine Society of Andhra Pradesh state level meeting, which is being conducted at Guntur. I thank Dr. Lavanya accepting readily to conduct this meeting, annual meeting on this day at Guntur. I also congratulate the team Guntur, all the endocrinologists here, for being actively involved in conducting today's meeting. At this juncture, I wanted to remind you all that next year, the Endocrine Society of Andhra Pradesh is hosting the National Endocrine Society of India meeting at Visakhapatnam. So in this section, this is a pre-event where we are all trying to meet here and decide what to do in the next happenings. And seeing at the audience, I'm very happy because the endocrinology in Andhra Pradesh used to be very small, with only around 4 endocrinologists approximately 20 years back in total Andhra Pradesh. That means we are talking about this part of Andhra Pradesh, excluding Hyderabad. Now I think almost there are around 100 endocrinologists in this part of Andhra Pradesh. So that's how the branch of endocrinology is growing. And endocrinology is the only one super specialty branch where it has intimate relationship to all the branches in the medicine. Whatever branch you are there, usually we have a good interaction with all the branches. So with these few words, I thank all of you and thank Dr. Lavanya and Team Guntur for conducting this meeting very well. I also thank our pharma friends for giving their good financial and logical support in arranging everything. Thank you and thank you very much.
So, good morning everyone. This brings to the other session. The topic is an upstream approach with oral semaglutide, treat early and treat better by Dr. Anantaraman. And we have Dr. Padmalata Madam, retired Professor of Medicine, Consultant Endocrinologist at Guntur, and Dr. Sridevi Madam, Consultant Endocrinologist Manipal, Bangalore, to chair the session.
Good afternoon, everybody. This is my pleasure to introduce Dr. Anantharaman, a good friend of mine. He works at Magna Centers for Obesity and Diabetes in Bangalore. Previously, he was associated with teaching hospitals. Now he is into the full-time practice. Over to you, Anantharaman.
Thank you, ma'am. It's great to be here and great to catch up with old friends, and also great to make new friends today. And I thank Endocrine Society of Andhra Pradesh for having me over here for this talk. I'm going to talk today about a product, semaglutide. So why should we treat early, and is it a better treatment? So these are two things which we look at. So this is my financial disclosure. I've been compensated by Novo Nordisk for giving this talk, but basically I'll be talking about the science surrounding this topic, and there is potentially no conflict of interest. So people with type 2 diabetes and obesity have an increased risk of mortality. So getting diabetes itself marks you out as having, a lesser chance of survival over the next 10, 15, 20 years. So this is something that is very well known to all of us. And we also know that among Indians, there is a lower lean body mass and a higher subcutaneous fat. We have got a more of a obesity problem rather than people abroad, actually. So if you look at the same BMI, so if you take an Indian with a BMI of 30 and a Westerner with a BMI of 30, our BMI of 30 is much worse than the BMI of 30 of a Westerner, because it has got a much worse physiological impact, basically. So the focus on weight should be more acute in Indians and not less acute. So let's understand the pathophysiology and interplay between diabetes and obesity at first. So there is a physical environment where there is excess intake of food, less physical activity, alcohol intake is more, and on top of that there is a environment of day-to-day life where sleep is less and inability to be active. For instance, I use a standing desk in my clinic just so that I should not sit for a long time, actually. I'm not sure whether everybody will have the opportunity to do that, actually. Many of my patients are actually IT employees, they are sitting all the time, and so it applies to all of us also. So though we do exercise, say maybe I do exercise about half an hour to 1 hour every day, but still I'm sedentary for the most part of the day because my work demands that I sit and work. Though we say, you should be physically active, apart from the Queen of England, very few people are able to do it. So social environment is again a problem. So because of all this, what happens is that, the environment on top of the genes promotes adiposity and adiposopathy, abnormal fat cells, and there is beta cell decompensation. The consequence of the complex interplay between the genes and the environment is what is causing this diabetes and obesity epidemic. On top of that, you have medication-induced weight gain, and if you have give an agent which causes hypoglycemia, that triggers weight gain, and that weight gain paradoxically worsens the diabetes prognosis. Say, for example, if you give a sulfonylurea upfront to a patient with type 2 diabetes, and they have subclinical hypoglycemia little bit throughout the day, so it can cause weight gain, and that may be the reason why the sulfonylurea stops working after 3-4 years. We know that sulfonylurea does not work beyond like 3-4-5 years. There is tendency to failure of sulfonylurea. That could be also the reason. So people with diabetes have always found it more difficult to lose weight than people without diabetes. So in various studies, when you compare the ease with which people lose weight, so people with diabetes find it much more harder. It could be because of the constellation of genes that got them the diabetes in the first place, or it could be due to the agents used to treat diabetes. It's very difficult to tease out the differences between these. So over a 24-month period with intensive lifestyle management, non-diabetic people are able to lose 4 kgs, whereas with the same kind of activity, diabetic patients are able to lose only 2.8 kgs. So why is weight loss in general a challenging thing? So you can see the one thing in the previous slide was that the weight loss was not massive. It's only about a few kilos weight loss with just lifestyle. Why is it so difficult to lose weight? The main thing is that when you lose weight, the hunger and preference for calorie-dense food increases because of decrease in the satiety hormones and increase in the hunger hormones. So as soon as you start losing weight, the homeostatic mechanism kicks in. And also at the same time, you also start reducing your energy expenditure. So whatever your basal metabolic rate is there, you actually drop the basal metabolic rate, and therefore you are actually gaining weight, whereas you want to lose weight. So it's an uphill task for people to lose weight. So what are the available treatment options? So when it comes to lifestyle, diet and behavioral therapy, it's very important. I think everyone should do it because, it is free. I mean, anybody can do it, and, there is no potential side effect for lifestyle based therapy. I mean, it's considered part of this thing. So behavioral therapy is also important. It's not just, you just give a diet chart. You need to actually follow up with the patient and do that. And somebody has to support the patient, that is required. But it may not be very less expensive. If you see, when you look at the cost of various therapies, therapy for lifestyle intervention may actually be more costly than if you see, the cost of liraglutide or semaglutide even. So, because if you want that kind of involvement, somebody should tell you how to lose weight and all that. And people do spend a lot of money on weight loss and trying to be healthy. So when it comes to pharmacotherapy, we have got various options. One set of options is orlistat, which is basically a lipase inhibitor. Then we have the GLP-1 analogs, liraglutide and semaglutide injectable is approved for weight loss. And then we have the other classical appetite suppressants, which work mainly on the central nervous system, naltrexone, phentermine, topiramate, etc. And then of course weight loss surgery, which classically reserved for the most obese actually, for those to lose weight. The remaining 80% do not lose weight, they really need a treatment. And people with lifestyle modification regain most of their weight when they stop the lifestyle modification. So all this is reason for the need for a therapy, pharmacotherapy. So if obesity is a disease, the solution has to be a drug therapy for the vast majority of people, because bariatric surgery, of course, is reserved for the most, those who are having the highest BMI. It has never been tested that widely in the 30 BMI, 35 BMI category. So you can see that weight regain does occur even after bariatric surgery. The percentage of weight regain after a sleeve gastrectomy can be 7 kilogram. It can be 4.8 kilogram median, and with one anastomotic gastric bypass, the most effective one, it is 2 kilogram. So there is no procedure which is free of weight regain. I mean, it is not 100% successful. So when it comes to pharmacotherapy, so there are medication out there which can actually reduce weight and maintain weight as long as you use the medication. So you can see that the curves are not, again reconverging, and there is a persistent weight loss. As long as you keep giving the medicine, the weight loss is maintained. So there is no recidivism that we see even at 24 months. So what are the effects of available anti-diabetic drugs on the weight? GLP-1, SGLT2, metformin and pramlintide causes weight loss. DPP-4 is weight neutral, and insulin and meglitine cause weight gain. So definitely GLP-1, SGLT2 will score over others. So GLP-1 act by working on the central nervous system, reduce energy uptake, food cravings are reduced, see CART neurons, which again reduce hunger, energy intake and food cravings. It again inhibits neuropeptide Y and agouti related peptide. So these are satiety increasing hormones actually. And, by inhibiting neuropeptide Y and agouti-related peptide, satiety is improved. So it improves satiety and reduces hunger. So this is how it works. It works on the central nervous system in the arcuate nucleus of the hypothalamus. Whereas SGLT2 inhibitor causes weight loss exclusively by calorie loss through urinary glucose excretion. So see, if the arterial glucose is 200 and venous glucose is 180, the difference is the calorie lost in urine. It's very simple. But when you lose a lot of calories in urine, you also stimulate the neuropeptide Y and ghrelin, which are orexigenic hormones, which increase appetite. Okay, so the balance between this appetite increase and this thing calorie intake, that's why you do not have indefinite weight loss with SGLT2 inhibitor. So whereas you can have prolonged weight loss, see if you give GLP-1 analog based therapy for weight gain or obesity, so you can have weight loss going on for many, many months. This does not happen with SGLT2 inhibitor because it quickly resets within a matter of a few weeks. So the appetite increasing hormones kick in and the person loses weight unless they do something else in addition like a diet or an exercise. So you can see that the energy intake increasing in clinical trials. So after after you start the SGLT2 inhibitor, by the 10th week or 15th week, the energy intake actually increases in those who are having SGLT2 inhibitor, limiting the efficacy of SGLT2 inhibitor in weight loss. So should we treat upstream or downstream? So upstream treatment would mean that we treat a patient with obesity when he has still not got type 2 diabetes, when he has still not got hypertension or coronary artery disease, and when he has still not got obstructive sleep apnea or NASH. So obesity causes a multitude of complications, or is a risk factor for multitude of complications occur due to obesity. It seems a logical approach. So let us look at the importance of weight loss. In the DPP-4 study, a significant type 2 diabetes reduction was seen with reduction in body weight. So when you look at the DPP-4, who were successful in preventing diabetes are the ones who lost weight. So weight loss is a very, very important metric when you're following up a patient who's trying to prevent their diabetes from developing. If someone has pre-diabetes and they want to prevent type 2 diabetes from occurring, are they successful in reducing weight? Is a very important question we need to ask. The same is seen in the Look Ahead trial. So degree of HbA1c and FPG reduction was proportional to the magnitude of weight loss. Even a modest weight loss did improve glycemic parameters very well. And this 5% weight loss is a very significant weight loss. In the direct study, where they did intensive lifestyle modification, I think you heard earlier speakers allude to the direct study. It's a very important GP-based study in UK, which showed that, if you lose 10 to 15 kilogram body weight, 60% of patients with type 2 diabetes are actually going into remission. Okay. And at year 2, even at year 2, 60% stayed remitted. It's excellent actually. If you lose 15 kilogram body weight, those who are extremely obese, the remission rate is very high, close to 80%, 70%. So almost something that comes to nearly to a cure. And of course, blood pressure, triglyceride, HDL, LDL, everything comes down. And in the Look Ahead trial, the CVD risk was also lowered for people who reduce weight successfully. So let us look at the result from the semaglutide Pioneer trial program. So oral semaglutide showed a significant A1C reduction versus a range of comparators, be it as a monotherapy versus empagliflozin, sitagliptin, liraglutide, and with insulin. There is a 1.5% HbA1c reduction. It's important to note that even against liraglutide 1.8 milligram, oral semaglutide 1.4 milligram was more effective. You can see the star over there, 1.2% HbA1c. It's very important to note. So change in A1C from baseline, if someone has an A1C of more than 9% baseline, it reduces the A1C by 2.6%. This is actually from all the trials. So it gives you very effective HbA1c lowering. So first of all, it is a very, very effective drug. So we are used to thinking that sulfonylurea are effective drugs. These are really, really, efficacy is very high. So oral sema shows clinically relevant weight loss across the Pioneer program. So there is good amount of weight loss. So you get about 4 kg. It beats all other drugs by a margin. Up to 5 kilogram weight loss can be there. Let us look at the comparison with empagliflozin. This is very interesting because we all give SGLT2 inhibitor because the patient can lose weight. So SGLT2 inhibitor, 0.8% weight loss. Semaglutide produces 1.4% HbA1c reduction. But when it comes to weight loss, SGLT2 inhibitor was reducing 3.8 kg. This is reducing 4.7 kg. It's superior to empagliflozin, definitely. This is in a head-to-head in the same RCT. So it's got a very high value. There is a better 70% better HbA1c reduction with a 24% better weight loss that you see with liraglutide, oral semaglutide versus empagliflozin. There is a superior waist circumference reduction, which is also seen. More important than that is the quality of weight loss that you see. So when you lose weight with empagliflozin, you lose actually a little bit of lean body mass. So if you're reducing, say, 1.6 kilogram, out of that 0.5 kilogram is lean body mass. It's not actually fat. But if you're losing 3.8 kilogram with semaglutide, your only 0.3 kilogram is the lean body mass loss. It's not that it will be zero, it is much lesser. The body fat loss is superior with semaglutide. So let us look at the evolving guidelines, how guidelines have changed. Okay, so in this is the latest ADA guidelines. It says that if you want to put a patient, if a patient comes to you with obesity and type 2 diabetes, let us not worry about their cardiovascular risk. Let us not worry about whether they have CKD or not. But if they want to reduce weight, the very effective agent for reducing weight, top of the pile, is actually semaglutide and tirzepatide. These are right at the top. Okay, so these are the best agents that we have as of today in 2023. Things may change next year also. There are a lot of new GLP-1 agents coming up, but as of today, this is the best drug. So it has entered the guidelines. And in people with HF, CKD and established CVD, we can think of using SGLT2 and GLP-1 together. Like for example, somebody requires SGLT2 inhibitor because they have CKD, and you can also put them on GLP-1 analog. You can probably minus the metformin. There is no evidence that metformin actually prevents outcomes like CVD or reduce cardiovascular death, etc. So if you want to remove the metformin and put only GLP-1 and SGLT2, that is also that is the implication of the statement from ADA. It's not a must that you use metformin everybody. That you should try to onboard a GLP-1 and a SGLT2 inhibitor if it is possible, if at all it is possible, in patients who have CKD, HF, and multiple risk factors. So this is a index patient. Ma'am, do I have time? 3 more minutes. Okay, this is an index patient. I think, who has 46 years of age. He had a parental history of MI, married with 2 children, sedentary job, works. It describes almost any patient that we see. A1C is 8.1%. So he was given sulfonylurea metformin. He has progressed basically because of that. So he continues to have a A1C of 8.3%. He has symptoms that may be due to atherosclerosis, shortness of breath, fatigue, and hypoglycemic episodes and weight gain. So from 46 years till 49 years, in 3 years' time, we have done nothing to his control. His A1C has worsened. His body weight has actually increased by 3 kilograms, though he needs to reduce weight as a person who is having type 2 diabetes. He has not been able to do it. You can see that the LDL cholesterol is also staying the same. So if you decide to, for example, if you decide to treat this patient with semaglutide, what is likely to happen? Based on the evidence that we have shown abundantly, you are likely to drop his A1C down to 6.8% over a 5-month period, or over a, over year 4, year 5, and there is a lot of, it is very sustainable, the weight loss and the reduction in HbA1c. It does not rebound like what rebound happens with sulfonylurea. After 5 years, the sugar starts rising. So as a 52-year-old, so he's 3 years older, mind you, and A1C has come down by a good percentage point, by 2.6 percentage points it has come down. And the weight has come down to 78 kilos. He has lost a good 12 kilogram weight. He feels like a new person, right? And LDL cholesterol has also come down, probably consequent to his weight loss. So it's almost a miraculous treatment, I would say. So we all know that, we have a limited lifespan on the earth. We have about 80 to 100 years. So in 3 years' time, if you use a drug which will get somebody's A1C down, get somebody's weight down, get somebody's cardiovascular risk down, I think you should give a serious thought to using the drug. So by using a drug which changes the cardiovascular outcome, that changes the outlook of the patient early on in the course of therapy, you're actually doing this thing. And we should discuss this option with almost all patients that we have. So cost is there. I mean, it is a costly drug, but we should give the option, that we should educate the patient saying that this option at least is available for them. So, and develop long-term complication we can definitely prevent by this approach. So we could have, we do, when we continue the oral semaglutide, this particular patient is likely to do much better. Thank you.
Thank you, Dr. Anantharaman, for such a lucid and clear presentation. We'll take 1 or 2 questions as the time is very short.
Safety profile, tolerability is much better than liraglutide clinically. When you look at tolerability, head-to-head tolerability also versus liraglutide, tolerability is little better than the injectable liraglutide which you have all along been using. Though, having said that, some patients will discontinue the drug because they are not able to tolerate it. So, but that does not mean that is not a side effect per se. So, when you look at adverse effect or severe adverse events, they are much lesser in the GLP-1 group. If you tolerate the drug and if you're taking it for months and years together, you can safely reassure the patient telling that nothing will befall you because you're taking the drug. You're not likely to have some, unknown skin rash or an unknown cancer or unknown event because of this drug. Because when you look at the RCTs, the events on the semaglutide group are much lesser when compared to the placebo group actually. So that's how we need to assess actually. So we have got, that's the advantage of doing so many outcome driven trials, that we have abundant data to reassure our patients. It is superior, sir. It is superior to liraglutide for weight reduction. Gastric upset is a GI side effects. It can be anything. So some people feel nausea, some people feel constipation, some people feel intestinal hurry, some squeezing sensation. So they've not finally gotten into what is the kind of symptom that is due to GLP-1 and what is not due to GLP-1. It's because it's a myriad of symptoms, and these symptoms are very common. Okay, all of us, from the common practice, we know that gas is the most common symptom for all our patients, isn't it? So it's very difficult to separate the wheat from the chaff in this area actually. So it's almost impossible. But when RCT, we can look at the GI side effects in the GLP-1. It's definitely more than in the comparator. So definitely there is a relationship between GLP-1 and the GI side effects. So some people will end up discontinuing because of this, but for those who continue it, it's excellent.
So thank you, sir.
Thank you.
We'll close the session.
Thank you.
Our Guntur General Hospital Superintendent Dr. Kiran sir is present here. So I would like to invite Dr. Kiran sir onto the stage, who is the Superintendent of GGH Guntur, to deliver a note. Thank you, sir.
Good afternoon. Already it is so much late. I am a little late comer. Thank you for inviting me for this wonderful occasion of Endocrinology Society first conference. And as far as endocrinology is concerned, I am Dr. Y. Kiran Kumar, Professor of Surgery, and also working as a Superintendent of Government General Hospital. So actually, ఈ ఎండోక్రైనాలజీ అనే దానికి వచ్చేటప్పటికి ఎక్కువ కామన్ మ్యాన్లో వాట్ ఆర్ ది కామన్ డిసీజెస్ అంటే ఎండోక్రైన్స్ అనగానే థైరాయిడ్ గుర్తొస్తూ ఉంటుంది. బేసికలీ యాజ్ ఎ జనరల్ సర్జన్ వీఆర్ డీలింగ్ విత్ ది థైరాయిడ్ డిజార్డర్స్, ఎస్పెషలీ టాక్సిక్ గాయిటర్స్ అండ్ హైపోథైరాయిడిజం. ఇవన్నీ చూస్తూ ఉంటే పేషెంట్స్లో కూడా ఇప్పుడు అవేర్నెస్ ఎక్కువ ఉంది. బట్ ఎండోక్రైనాలజీ ఇన్ జనరల్ టోటల్గా ఒక పక్క చూస్తేనే మనం డయాబెటీస్ అదొకటి ఇంపార్టెంట్ డిసీజ్ అనిపిస్తూ ఉంది. నేను ఈ మధ్యకాలంలో అబ్జర్వ్ చేస్తే ఎక్కడికి వెళ్ళినా కూడా విజయవాడ గవర్నమెంట్ హాస్పిటల్ అక్కడ కూడా సూపరింటెండెంట్ చేశానండి. అప్పుడు కూడా ద పీపుల్ హూ ఆర్ సిట్టింగ్ అరౌండ్ మీ 10 మెంబర్స్ అడ్మినిస్ట్రేటివ్ ఆఫీసర్స్ అందరూ కూర్చొని ఉంటే వాళ్ళలో 9 మెంబర్స్ ఆర్ డయాబెటిక్. 9 మెంబర్స్ డయాబెటిక్ ఉండేవాళ్ళు. సో ఇంత ఎక్కువ ఉంది అనేది నాకు ఆశ్చర్యం వేస్తూ ఉండేది. బట్ డయాబెటీస్ అయితే మాత్రం ఇప్పుడు కూడా దట్ ద పర్సంటేజ్ ఆఫ్ ఇన్సిడెన్స్ ఈజ్ మోర్ దెన్ వాట్ వీఆర్ టెక్నికలీ స్పీకింగ్ 30% అనుకుంటారు, కానీ ఇట్ ఈస్ మోర్ దెన్ 30-40% అనిపిస్తూ ఉంది. సో డయాబెటీస్ ఒకటే సింగిల్గా ట్యూబ్యులర్ విజన్ లాగా చూస్తున్నాం అంటే డెఫినెట్గా ఐ ఫీల్ మోస్ట్ ఆఫ్ ది ఏరియాస్ పీపుల్ విల్ హ్యావ్ ఏ ఓన్లీ ట్యూబ్యులర్ విజన్. ఇట్ ఈజ్ ఏ జనరల్ డిసీజ్ అన్నది కొంత పబ్లిక్లో లేదో అనిపిస్తూ ఉంటుంది, కొంత మెడికల్ ఫెటర్నిటీలో కూడా ఫ్యాకల్టీలో కూడా ఒక్కడ బ్లడ్ షుగర్ అది ఒక్కడ చూడటం, బ్లడ్ షుగర్ లేకపోతే HbA1c సమ్ అదర్ పారామీటర్స్ వరకే మనం కన్ఫైన్ ఉన్నాం అనిపిస్తూ ఉంటుంది. బట్ ఇన్ జనరల్గా చూస్తే మాత్రం ఇట్ ఈజ్ ఏ వాస్కులర్ డిసీజ్ ఆఫ్ మైక్రోవాస్కులర్ డిసీజ్. వాట్ మై ఫీలింగ్ ఈజ్ వన్స్ డయాబెటీస్ డయాగ్నోస్ అయిందంటే ఇట్ ఈజ్ ఏ ఫస్ట్ హార్ట్ అటాక్ అన్నది some of our diabetologists or some of the physicians' words. So first diagnosis ayindantene already that patient is having one heart attack vachindi, already having a microvascular disease anadi. When I went to diabetology courses at Chennai, I heard that word. That is also true అనిపిస్తూ ఉంటుంది. సో అదే కాకుండా మేము చూస్తే దాంట్లో వాస్కులర్ డిసీజ్, పెరిఫరల్ వాస్కులర్ డిసీజ్ ఇప్పటికి కూడా రెమెడీ లేని డిసీజ్ అనిపిస్తూ ఉంటుంది. మోస్ట్ ఆఫ్ ద టైమ్స్ దే ఆర్ ల్యాండింగ్ ఇన్ ది యాంపుటేషన్స్. సో ఇది చూస్తూ ఉంటే డయాబెటీస్ ఒకటే ఒక ఎండోక్రైనాలజీ అనుకునే సిస్టమ్ నుంచి ఇవాళ అవేర్నెస్ అయితే మాత్రం హ్యూజ్ పీపుల్ అందరూ కూడా అవేర్నెస్ అయితే చాలా ఎక్కువ ఉంది. నాట్ ఓన్లీ థైరాయిడ్ ప్రాబ్లమ్స్ ఆర్ డయాబెటీస్, ఇవి కాకుండా కూడా నేను అబ్జర్వ్ చేసింది అదర్ ఆస్పెక్ట్ ఆఫ్ ఎండోక్రైన్స్, ఎస్పెషల్లీ దిస్ ఇన్ఫెర్టిలిటీ వర్క్. అవి కూడా అక్కడ కూడా ఎండోక్రైనాలజిస్ట్ రోల్ అయితే మాత్రం చాలా ఎక్కువ ఉందో అనిపిస్తూ ఉంది. సో ద అవేర్నెస్ షుడ్ బి దేర్ ఇన్ ది పబ్లిక్ అనేది నా పర్సనల్ అభిప్రాయం. బట్ ఇవాళ కూడా మనం విలేజెస్లో చూసుకుంటే అంతగా ఈ ఎండోక్రైనాలజీ గురించి పీపుల్కి తెలియదేమో అనిపిస్తూ ఉంది. సో అవేర్నెస్ క్రియేట్ చేయాల్సిన అవసరం మనకు కూడా ఉంది. ఈవెన్ ది రూరల్ పాపులేషన్లో ఇవాళ కూడా దాని గురించి అంతగా ఫోకసింగ్ లేదేమో అనిపిస్తూ ఉంది. బట్ మెట్రోపాలిటన్ కల్చర్కి వచ్చేటప్పటికే పీపుల్ ఆర్ దేర్ టు ట్యాకిల్ ది ఎండోక్రైనాలజీ ప్రాబ్లమ్స్ ఇన్ ఆల్ సిటీస్. బట్ if you go to the first class towns like Satanapalli, Erpidurala, Repalli, అక్కడ అలాంటి చోట డెఫినెట్గా ఎండోక్రైనాలజీ గురించి చాలా తక్కువే మనం చూస్తూ ఉంటాం. బట్ అర్బన్ పాపులేషన్లో మాత్రం పీపుల్ ఆర్ కమింగ్ విత్ ఎండోక్రైనాలజిస్ట్, విత్ క్వాలిఫైడ్ ఎండోక్రైనాలజిస్ట్ దే ఆర్ కమింగ్, అండ్ వండర్ఫుల్ drugs, wonderful treatment they are offering to the patients. So with this small lecture I want to close this session. My speech. Thank you very much.
Thank you, Kiran sir, for your kind words. The next topic is gestational diabetes. What is new? We have Dr. Alok sir, Professor and HOD, SWIMS Tirupati, and Dr. Bharani, Consultant Endocrinologist at Bharani's Diabetes and Endocrine Center, and Consultant Endocrinologist at Ramesh Hospital to chair this session. And to speak on this topic, we have Dr. Lakshmi Nalini from Hyderabad.
Treatment. So what is new in pathogenesis? Gestational diabetes, we all know that it's because of multiple factors. So broadly, these factors can be divided into three groups. That is, the genetic factors, the epigenetic factors, and environmental factors. So genetic factors, the genes that are responsible for insulin secretion, insulin resistance and glucose metabolism, there are over a dozen genes like this, ranging from IRS1 to FTO, wherein expression of these genes and presence of these genes itself confers a risk of GDM. So during pregnancy, it's not just insulin resistance, simple insulin resistance, but it is inflammation-driven insulin resistance which is seen. A study was done wherein 31 factors, genes were, and their products were analyzed, and it was found that these 6 factors modulated the chronic inflammatory response and led to GDM. The insulin resistance per se mainly comes from these factors. So after the genetic changes, we have the epigenetic changes. There's so many factors and genes that are expressed in a different way, which leads to the epigenetic changes. Quoting Robin Sharma here, your environment influences your mindset. So environment definitely influences everything, including gene expression, and that is nothing but epigenetic changes. So epigenetics, what are the new insights that we have about this? So epigenetics is the study of changes in gene expression, and genes react to a pregnant woman's metabolic status via epigenetic mechanisms. And even a slight increase in glycemic levels can be associated with epigenetic adaptations, that is DNA methylations. And DNA methylation can tell which gene is expressed or not. As you all know, all of us house minimum of 6 lethal genes. But if they are expressed, we should not be alive now. But we all are hale and healthy, or apparently so, because those are not expressed. So expression of a gene is as important as the presence of the gene also. And also expression of inflammatory genes depends on their epigenetic changes like DNA methylation, and maternal glycemic levels during pregnancy were found to be associated with placental DNA methylation and mainly those of inflammatory genes, leading to chronic inflammation, thereby insulin resistance and gestational diabetes mellitus. Now, there is another concept regarding epigenetics. There is something called nutrigenetics in GDM. What is this nutrigenetics? As the word says, it is something related to nutrition and genetics, and thereby conferring an epigenetic modification leading to this. So nutrigenetic is the study of effect of genetic variation on dietary responses and the mutual interaction that is related to GDM and expression of a disease impact. So dietary factors can induce epigenetic changes that in turn can affect genome stability and expression of microRNAs and many other proteins. So in short, when we are talking about nutrigenetics in GDM, it is about maternal nutrition and thereby the fetal nutrition. Based on the fetal nutrition levels, the fetal hypothalamus responds. And this hypothalamus goes into a certain programming mode, which is either balanced or imbalanced. If there is an imbalance between orexigenic and anorexigenic peptides, then that leads to obesity. And if it is a female child that we are dealing with, then this maternal malnutrition is transferred to the fetus, which is a female fetus, and this is again going through the generations. So we have seen about pathogenesis, we have seen about the genetic factors, we have seen about the epigenetics. So what are the new things regarding screening and diagnosis? We all know what is GDM. Then what could be new about it? So there are many other biomarkers which are present even before GDM is screened with glycemic levels. These biomarkers can be expressed, and most prominent of them is adiponectin. We see that the study done by Dr. S.V. Madhu and his group showed that there was a sensitivity of 100% and specificity of 95% for adiponectin, which makes it an excellent marker in first trimester itself. So let us proceed towards a case to understand this much better. There's a 30-year-old lady who presented with 6 weeks of gestation, and her preconception BMI was 27. Both parents are diabetics. Elder sister had GDM. So a lot of risk factors are present in this case. And 2 years back, she was found to be pre-diabetic, HbA1c 6%, fasting 110. So in this patient, we see now at 6 weeks, we found fasting plasma glucose is 114 milligram per deciliter, and HbA1c is still 6%. So do we label her as diabetic? Because GDM definition comes into picture only between 24 to 28 weeks. But we are dealing with a person who is metabolically abnormal at 6 weeks. What do we do about her? This is a new scenario regarding GDM that we are facing. increasingly with each year. So would we label her as having GDM right now, or what would we call her? These are the questions in front of us. How do we monitor her glycemic status? Do we even monitor it? So understanding what we know and going to what we don't know will open up new insights. So over diabetes, we all know when fasting is more than 126 and 2 hours after 75 grams glucose if it is more than 200, or when random is more than 200 with symptoms, or HbA1c more than 6.5 is over diabetes. So conventional diabetes, as we just now spoke, is between 24 to 28 weeks when we test with IAD-PSD criteria most commonly followed, fasting 92, first hour 180 and second hour 153 is what we all know. But this woman is not in 24 to 28 weeks bracket. So what is new here? The new thing here is something called early GDM. There is a new entity right now that we call early GDM when we diagnose it before 24 weeks. If we follow ToboGM study, they said it before 20 weeks. So IAD-PSD criteria when applied, it is I don't have the screen here. Right. So applying IAD-PSD criteria here, GDM is, early GDM is when fasting plasma glucose is more than 92 milligram per deciliter, but it is still less than 126. So what does ADA have to say? ADA 2022 gave it a new name, a very fancy name calling early abnormal glucose metabolism, wherein fasting was more than 110 or HbA1c was more than 5.9 in a woman who is much before 24 weeks. So this is our patient. So back to her, she is 6 weeks. She is her fasting is 114 and HbA1c 6%. So she comes under, with the IAD-PSD criteria, early gestational diabetes, a new entity that we are dealing with every day. So which test do we consider? Is it fasting 114 or HbA1c 6%? So which test is more appropriate? Let's see. All the three things, FPG, OGTT and HbA1c have been evaluated, and fasting plasma glucose cutoff has been arbitrarily given based on IAD-PSD criteria of 92. If it is OGTT, we see that we take the same guidelines as conventional GDM because of lack of any proper guidelines so far. We know that there's an entity of early GDM, yet we are not in a position to say what is the cutoff, what is the diagnosis. We still don't know what are the treatment goals. There are many things which we still don't know about early GDM. The screen is gone again, please. So when we talk about HbA1c, the screen is blanking out frequently. Right. I'm sorry about that. So HbA1c values, if they are between 4.8 and 5.9, more or less we can say that the woman is okay. Even though we say that pre-diabetes starts from 5.7, it was found that abnormal effects or negative outcomes of pregnancy in both mother and child have been observed when HbA1c level in early trimesters is also more than 5.9. So after saying all these biochemical tests, what does radiology have to do? Just a correction over there, it is not the diagnosis, it's the screening part we are still in. We know that radiology, ultrasonography we use to monitor fetal growth, to detect congenital abnormalities. This is all what we know, and to decide on the mode of delivery based on the weight of the baby also. But what is not known about ultrasound is that we can monitor placental changes and possibly predict GDM at early stages of pregnancy. And how can we do it? By measuring the changes in placental vascular indices like vascularization index, flow index, vascularization flow index. These parameters can precede biochemical diagnosis of GDM and can offer us some help in identifying this early GDM. So early gestational diabetes, okay, we've identified with screen. So what? What are the diagnostic implications of this? We need to understand that. So fasting plasma glucose, when it is more than 92, it has a linear association with this mother becoming abnormally glucose, having abnormal glucose levels between 24 to 28 weeks. That is, the risk of conventional GDM is linearly increasing. And irrespective of development of conventional diabetes, perinatal outcomes are also affecting. So this mother
who's had abnormal fasting plasma glucose in maybe first trimester may become normal in between 24 to 28 weeks, still perinatal outcomes are abnormal in this mother. So that is a very important point that we are seeing here. And OGTT levels, when we are taking, we are considering the first trimester OGTT is usually not so good. We are just applying what we know for 24 to 28, but the mother is totally different in the first trimester versus the mother in 24 to 28 weeks. So first trimester OGTT is not an accurate predictor, and try and avoid doing that. And HbA1c, you know, the data is very conflicting because there are many factors which can change HbA1c value. Something as common as anemia can also change HbA1c. So next is, what do we know about screening? We'll move from what we know to what we don't know and what is the emerging evidence. We all know that screening of overt diabetes is necessary, and overt is when HbA1c is more than 6.5. And screening and treatment is essential and prevents negative outcomes when we screen and treat between 24 to 28 weeks. And beneficial effects also we know. So what is it that new evidence is coming about? Early gestational diabetes we have to identify because there is a negative outcome of early gestational diabetes which is increasingly observed. And optimal treatment targets in early gestational diabetes may be different from conventional diabetes. We still don't know what is optimal. That is still a gray area. And more frequent fetal monitoring has to be done, probably to avoid over-treatment and subsequently fetal undernutrition. So untreated early gestational diabetes may be associated with worse maternal and fetal outcomes even if OGTT becomes normal between 24 to 28 weeks. This is the point which we have missed many times till now. So what does ADA have to say about early screening? ADA says that screen for early abnormal glucose metabolism using fasting glucose between 110 to 125. This is for the Western population. Indian population being prone to metabolic abnormalities much more. IDP-SG criteria stand much more preferred in Indian population. So it states that also screen all women, all pregnant women between 24 to 28 weeks because of the risk that is seen. So what do we know? We know that ToboGM has come out, the full study has come out. There are 2 more RCTs which are pending. We are hoping to see the outcomes of treatment of early gestational diabetes. The Pinto study and TESGO study are eagerly awaited, especially in the light of a few inconclusive parameters of ToboGM study. So now we have seen about screening and diagnosis. What is new in GDM treatment? So this is the mother. We go back to this mother and we come back from what we know to what we don't know. See, she is 6 weeks antenatal, fasting is 114 and HbA1c 6. Should we treat our patient? Is it a valid question? We still don't know whether to treat or not. Are we causing SGA by treating? Are we doing a very important step here by treating her and preventing a negative outcome? We still don't know. So in this patient, mother, interventional studies, they tell us that early GDM should be screened. They should be treated. But the outcome in all these studies is very variable. This is a systematic review which was published by Dr. Bhattacharya's group, wherein total 9 studies were identified and compared. 1 study showed better neonatal composite outcomes with early intervention, whereas 4 studies showed no difference and 4 studies showed worse outcome. So where are we? Back to square one, we don't know how things are. So all this comes from this question of what should be her glycemic target. Where should we stop, or where should we further proceed and treat her intensively? That is the question that we are facing. We know that the conventional targets are less than 95, maintenance of fasting plasma glucose less than 95, first are less than 140, and second are less than 120. We know these conventional values, but are these applicable to early gestational diabetes? Another question we have to ponder about. So to answer this, we'll study the ToboGM pilot which was done. ToboGM pilot says that early treatment may result in a trade-off between decreasing macrosomia versus increasing fetal SGA. So it's just essentially a trade-off between these 2 parameters. So take a clinical decision is what ToboGM pilot has said. Nothing much came out of it. So ToboGM has come out, the study has come out. Out of 44,000 women when they had done, finally they were left with 793 women, wherein when adverse neonatal outcome was seen, in those individuals, in those mothers who were intervened and treated, 5% lesser negative outcomes were observed. Whereas when it comes to pregnancy-related hypertension, there was not much of a difference in both the groups. And neonatal lean mass, when it was compared, that also was not significantly different. So definitely adverse neonatal outcome is different when we are intervening early. So that is the take-home message from TOBO-GM. So from the TOBO-GM, the RCT, the latest RTC published in RCT that is published in any GM tells us that we have to intervene and treat to prevent negative outcome. So coming to the last aspect, the pharmacotherapy of treatment. So what do we know about it? We know that insulin is preferred. We know that metformin is used in India and certain guidelines guide this. Refreshing those guidelines, the maximum dose of metformin to be used in pregnancy is 2 grams against the maximum dose, which is 2,750 milligrams in non-pregnant women. And it is clearly stated in Indian guidelines that metformin should be used only as a second line, and only the use, it has to be preferred and can be used in the first trimester, but it is not preferred, and insulin is the preferred drug. That is what 2018 Government of India guidelines say that. So which insulins are preferred? Isofen, as basal insulin, isofen and levemir are preferred. And for rapid acting insulin, it is regular insulin and and aspart and Lispro. They are preferred. Glulicin is not preferred, and Glargine and Glulicin cannot be started after conception. If the mother is using prior to conception, you can continue it, but you cannot start Glargine after conception. This is what we know already. But what is new here? The latest thing about this is FIAS, that is fast-acting insulin aspart, is approved to be used in India in pregnancy. Degludec is the most recently approved basal insulin. Approval was gotten January of this year. So these two insulins are the new entry molecules now. And then very important note about metformin. So what does ADA have to say about metformin? ADA says the same thing. Insulin is preferred and should not use metformin nor glibenclamide as a first choice. And metformin, when used to treat polycystic ovary syndrome and induce ovulation, it should be discontinued by the end of first trimester. This is very important to remember. Often it is just continued till the mother delivers. So we should not do that, and we should discontinue metformin by the end of first trimester. And when we see MIG-TOFU study, the two groups had diverse results that were coming up, but then one arm clearly says that at birth also metformin was associated with increased perinatal complications. At 2 years also mid-arm circumference and skin fold was much higher, and at 9 years also all these parameters were much higher. So this is something we have to ponder about, though there were a lot of confounding factors in this study. Still, it holds good. There is something different in those individuals. Metformin is significantly crossing placenta. So, taking the dictum of medicine, primum non cuare, are we doing any harm or are we not doing any harm is a question we all need to ask when we are using metformin. Till we don't have data, use it according to guidelines, use it judiciously, and use it within the limits stipulated. And then this is another study about metformin. This is a PEDMED study wherein PREGMED study follow-up, it was done and children were seen. Children in metformin group had a higher BMI Z-score than those in the placebo group. Yet another study, in almost 141 children it was seen. And increased BMI in metformin exposed children might indicate a potential risk of inferior cardiometabolic health later, and implications on adult health cannot be excluded. So are we missing out something? Are we seeing small gains now and easy way of treatment now and causing bigger harm to our next generation completely is a very big question in front of us. So summarizing my talk, what we have learned is the genetics is very important, and epigenetic changes play a major role, including the nutrition of the mother. And nutrigenetics that's where it comes into play in GDM. And early gestational diabetes is something we are seeing increasingly every single day. And it is recommended to screen high-risk individuals, and we call it early GDM if fasting plasma glucose is between 92 and 126. And treatment it is preferred to use insulin. Metformin can be used if needed and can be started only after 20th week. And the newer insulins that are okay now to be used during pregnancy are Fiasp and Degludec. Thank you so much, and I acknowledge the help from Dr. Lakshmi Nagendra, endocrinologist from Mysuru.
Thank you, Dr. Lakshmi. So now we can, sorry, Dr. Nalini, can we take any questions now? So while audience are thinking about something, so can I ask that early gestational diabetes, if a mother comes today till we have any guidelines, how will you treat this patient?
I would say that we have recently worked on our own data of 33,000 mothers, and the results are just out and we are analyzing the data. We find that negative outcomes are indeed higher. We are also seeing a little different from Tobogm, which has come out. We are seeing even gestational hypertension is much more. So we are intervening with lifestyle measure. That is always the foremost policy. I'm a part of Fernandez, which sees a lot of pregnant women and those individuals with early GDM also. So here we are treating them with lifestyle intervention as a first step. As of now, because there's paucity of data about where to stop, we are using the conventional modality itself, and we are monitoring very frequently with ultrasound how the fetal growth rate is happening. We are charting the percentiles and we are going about these mothers very carefully.
I think no more questions. Thank you.
Thank you so much.
Thank you, Dr. Nalini, and thank you, the chairpersons. Moving on to the next session, the first endocrine update of this day. The topic is approach to hirsutism, and I would like to invite the chairpersons, Dr. V. Ramya and Dr. Aishwarya. Ramya is a consultant endocrinologist at Apollo Hospitals, Visakhapatnam, and Ramya Endocrine Clinic, Vizag. And Dr. Aishwarya is a consultant endocrinologist at Origin Endocrine Center, Vijayawada. And I would like to ask the chairpersons to introduce the speaker, Dr. Sailaja.
Welcome, Dr. Sailaja. She completed her MBBS from Andhra Medical College and DM Endocrinology from SWIMS Tirupati, and she is currently practicing in Tirupati. Over to you, Dr. Sailaja. Please continue with that.
Thank you all and warm welcome, and I thank the Endocrine Society of AP Guntur chapter, Dr. Lavanya and the team for giving me this opportunity to talk on the session today about the approach to hirsutism. Coming to the historical aspects of hirsutism, the first cases of hirsutism or androgen excess were way back in 3,400 years BC, which has focused on the male pattern of hair growth in females, and it was associated with menstrual cessation. So Charles Hasselman is a notable photographer in New York, and way back in 1870s, he focused his photography on the show people of the Barnum and Bailey Circus in New York, and he has published the human show or show people who were available in this. So these were the people, if you can see the beard lady, which was photographed and available as cabinet cards, and the dog-faced boy. These were all published in a monogram, which was available in 1800s. So coming to the definition of hirsutism, it is defined, as we all know, excess growth of terminal hair in the androgen-sensitive areas in a female. So hirsutism typically is a sign of increased androgen action on the hair follicles. Either it could be because of increased androgen levels or increased sensitivity of the hair follicles to the normal circulating androgen levels. So we need to differentiate. We need to differentiate hirsutism from hypertrichosis, which is here we can see in the picture a boy having diffuse hair growth all over the body irrespective of the androgen levels, and it is generalized in the non-sexual distribution, and typically it's in the villous hair growth, not the terminal hair. So what's the difference between a villous hair and a terminal hair? Structurally, there are 3 types of hair. And the first is the lanugo hair, which is seen in the newborn period on the fetus, and usually regresses gradually. The other is the villous hair, which is usually present before the puberty, irrespective of the androgen levels. Next slide. So it's non-pigmented hair, and we have the terminal hair, where the villous hair gets turned to a pigmented hair under the influence of the androgen levels. It is larger, coarser, and pigmented. So this is what I was telling. So coming to the paradoxical response of the androgens, androgens have a paradoxical response on the scalp and on the face. So as such, because of the androgens, because of the effects of the androgens on the villous hair, in the androgen sensitive areas, the villous hair turns to terminal hair, thus causing the beard formation in a female, while on the scalp, the androgen's effect on the pilosebaceous unit will reduce the villous hair and forms the male pattern baldness that is called as the androgen alopecia. So you can see typically 2 different features in an excess androgen state in a female, where there will be loss of hair on the scalp and excess hair growth on the androgen sensitive areas. So coming to the causes of hirsutism, most common, accounting for almost 70% of the cases, is polycystic ovary syndrome. The other causes are the non-classic CAH, rare causes like the androgen secreting tumors of the ovary and the adrenals. Other endocrinopathies like acromegaly, Cushing's syndrome, we should also rule out if the patient has any signs or symptoms of endocrinopathies like acromegaly, hyperprolactinemia, hypothyroidism and all. So coming to the first DD of hirsutism, polycystic ovary syndrome, here the androgens may be normal or mildly elevated. So the elevated hyperinsulinemia usually causes the increased GnRH pulse frequency, with the result there will be LH predominance over the FSH. If you can see, the LH by FSH ratio will be more than 3, associated with increased androgen secretion because of the reduced sex hormone binding globulins. So this is the pathology of PCOS. Now coming to the milder androgen subtypes, that is like the idiopathic hyperandrogenemia, which is may be associated with insulin resistance. Here the patient will be having normal menses, no irregular cycles, normal pattern of ovaries on the ultrasound, no PCO pattern, but elevated androgen levels can be seen, and no secondary causes like the endocrinopathies or any other elevated hormones. Next we have quite commonly we see the idiopathic hirsutism, which is usually a diagnosis of exclusion. Quite often we see with girls coming up with hirsutism, but when checked, the fasting androgen levels come normal. It's mainly because of the increased sensitivity of the hair follicles to the normal androgen levels, and if we find out from the history, the girl will be having normal menses, no ultrasound findings of PCO. So in such women, the androgens will be normal, the testosterone and the DHS. Coming to the postmenopausal hirsutism, most of the time the reason is because of imbalance between the drastic fall of the estrogens when compared to the gradual fall of the androgen levels. And also as the aging progresses, the sex hormone binding globulin falls down, so with the increase in the free androgen index. So quite often we see postmenopausal women coming with excess hair growth. The next DD for the hirsutism is the congenital adrenal hyperplasia, wherein it is defined as the deficiency of one of the enzymes which are responsible for the adrenal steroid hormone synthesis. So because of the deficiency of this enzyme, the precursors get shunted to the alternative pathway and resulting in increased androgen secretion. So CAH, classic CAH is of two types, the salt wasting and the simple virilizing. Usually presents at birth with ambiguous genitalia, electrolyte disturbances, vomitings, failure to thrive with androgen excess. So now the topic of interest for us is not the classic CAH. We have the milder form of CAH, that is a non-classic CAH, wherein the child presents in the peripubertal period either with primary amenorrhea or primary infertility with hirsutism. So the most common reason for this non-classic CAH is 21-hydroxylase deficiency with elevated 17-hydroxyprogesterone levels. So we need to check the early morning follicular phase 17-hydroxyprogesterone levels, generally done in the fasting state. Less than 2 nanograms per ml rules out non-classic CAH, but if it is borderline 3 to 10, then we need to do the stimulation test with the cosintropine, where 250 micrograms of cosintropine is given. And after 1 hour, we collect the 17-hydroxyprogesterone. If it is more than 10, confirms non-classic CAH. Accordingly, we have to manage the patient. So other rare causes of hirsutism are the androgen-secreting tumors in a female, where it can be from the ovary or the adrenals. So most of the time, more of the voice, broadening of the shoulder girdles, clitoromegaly, temporal hair recession, and acne and all. So other causes which have to be ruled out before tagging the patient as having the normal profile and defining as idiopathic hirsutism, we need to rule out if the patient has any galactorrhea to check for hyperprolactinemias. Both hypo and hyperthyroidism can cause hirsutism, so we need to rule out with the thyroid profile if the patient is having any symptoms. Acromegaly, growth hormone excess state, and Cushing syndrome. But these 4 endocrinopathies rarely present with isolated hirsutism. Usually they manifest with other signs. So the last but not the least, the DDs for hirsutism is the drug-induced. Most commonly we see the glucocorticoid usage and topical testosterone being used by the partners, wherein the second partner usually gets the hirsutism, which can be local hair growth, or the drugs which can be used as performance drugs, anabolic steroids by the gym athletes, and also for the hypoactive sexual disorders. So in such cases, you can have local hirsutism or even sometimes even hypertrichosis, hyperhidrosis, sorry. So coming to the physical examination, we know quite often the modified Ferryman-Galway scoring, which consists of scoring the 9 androgen-sensitive areas in the body, and the grading we know mild to moderate, severe, and 0 is absence of terminal hair. So these are the 9 androgen-sensitive areas: the upper lip, chin, chest, upper abdomen, lower abdomen, upper back, lower back, and the upper arms and the thighs. So these are the androgen sensitive areas which we need to see while evaluating for hirsutism. So there are some limitations for this even. The one thing is, most of the time the girls present with local hirsutism of the upper lip and the chin. So we may not be able to generalize these patients are having an FGS of more than 8 to be categorized as hirsutism. So that is one reason. And most of the times these girls resort to depilatory procedures like shaving or threading or plucking and all. So we cannot, it comes as to false low values in such patients. And it also depends on the race and ethnicity, like the East Asians and the Native Americans, they have low hair growth on their body when compared to the Mediterranean people. So the FGS score of more than 3 is considered to be hirsutism in the Native Americans and also in the East Asians, while 9 to 10 is considered for the Mediterranean people. And there are no cutoff values for the Indian hirsutic women as of now. So coming to the physical examination, as I was telling, we need to see for any, if the child is obese, we need to see for the clinical signs of insulin resistance like acanthosis, abdominal obesity and all. Cushing syndrome, broad violaceous striae, buccal, dorsocervical hump, or if there is any temporal recession of hair or moon phases, proximal myopathies, we have to see. Signs of visualization, which I was telling in the previous slide regarding any voice changing or the musculature of the body with hirsutism. So Endocrine Society guidelines suggest against checking for the hormones if the patient has mild hirsutism. But yeah, the hormonal profile should be checked if the patient is having moderate to severe hirsutism, sudden onset of hirsutism, or rapidly progressing hirsutism. We need to check for the hormonal profile. So what are the hormones that need to be checked? The baseline is the total testosterone levels and 17-hydroxyprogesterone along with the DHEAs. So total testosterone is the best initial evaluation for the androgen production. Direct free testosterone assays are not accurate, but yeah, we can check the free testosterone levels if the total testosterone levels are significantly elevated as a second step after checking the total testosterone levels. So why we shouldn't go for the free testosterone levels in the first go is the immunoassays that are available for free testosterone are not accurate. If it has to be done, it should be done by the equilibrium dialysis, which is available in very few specialty labs. So always go with the total testosterone levels as the first investigation of choice for hirsutism. Next, the next investigation is 17-hydroxyprogesterone. We have to check prolactin, thyroid profile, 24 hours, urine-free cortisol if we are suspecting other endocrinopathies. And radiology-wise, we need to go for the ultrasound and the higher-end tomography or the MRIs. So how to broadly differentiate whether it's a benign cause or a malignant cause? So peripubertal girls presenting with slow progression hirsutism, rarely signs of virilization seen, then it's mostly benign, usually can be PCOS or non-classic CAH. But late onset postmenopausal women most commonly affected with rapid development of hirsutism within few months, like 3 to 6 months, when compared to the peripubertal women almost like months to years. So with signs of virilization indicate an vigorous or an androgen secreting tumors, whether it can be ovarian or adrenals. So this is the algorithm for the evaluation of hirsutism. So we have few case studies where a 15-year-old girl presented with primary amenorrhea with excess hair growth on her face of 1 year duration. So this is like gradual hair growth. On examination, she's obese with acanthosis and acne. FGS scoring was 3/36 and the LH was elevated. If you can see, the testosterone, total testosterone was elevated. DHAs were mild, borderline on the upper normal range. 17-hydroxyprogesterone baseline was elevated, but when checked for the cosintropin stimulator, 17-hydroxyprogesterone was within the normal. This was the girl with acne, terminal hair on the chin and acanthosis. So she was a known case of PCOS and managed with the oral contraceptive pills. Now we have a second child, 17-year-old short-statured girl presented with primary amenorrhea. On examination, she had no breast bud. Axillary hair is there. Pubic hair was almost P4. She was having hirsute faces. With FGS score was 15/36. She came for the primary amenorrhea evaluation. Workup was being done. The thyroid profile, FSH, LH, prolactin were in the normal range, and 17-hydroxyprogesterone was elevated with elevation of the DHEAs. Then the free testosterone was directly done for this patient, and it was elevated. The ACTH was basically done because on the ultrasound, the bilateral adrenals were reported to be prominent with no focal lesions, so ACTH came as normal. Estradiol was elevated, electrolytes were within the normal range. Ultrasound was almost normal, ovaries and all, but the adrenal glands appeared prominent with no focal lesions in the adrenal glands. So MRI was almost normal, and adrenals were found to be normal. So this was a patient who came with primary amenorrhea. If you can see, there is hirsutism on the upper lip, and the chin hirsutism was not visualized in this pic. So there is a temporal recession of hair, and typically she has a masculine faces. And now she was being diagnosed to be non-classic CH. She was being started on hydrocortisone, and now she is being kept on the progesterone because her estradiol levels were normal. Now we have she's on follow-up. I think she came recently 1 month back, so not full workup was done regarding the treatment. So 45, now we have third case, 45-year-old lady, known diabetic and hypertensive for 3 years, excess hair growth over the body for the last 3 years, with loss of scalp hair and oily face and acne over the face. So the serum testosterone was elevated. So as she was having the workup was done because of the striae over her abdomen. So the 8 AM cortisol was elevated, then the patient was admitted and the overnight dexamethasone test was done which was elevated, midnight cortisol was elevated. To confirm the diagnosis, the patient was subjected to low dose dexamethasone suppression test which confirms Cushing's. ACTH was collected, was elevated, then the patient was subjected to high dose dexamethasone suppression test with more than 50% reduction in the serum cortisol. So she is an ACTH dependent Cushing syndrome. MRI pituitary was done and microadenoma in the right half of the pituitary. She was the patient who presented to our OPD when I was doing my DM in SWIMS. So this was the patient preoperatively. The patient had this loss of scalp hair and acne with healed scars on the cheeks. And after surgery, she underwent the transpenoidal hypophyseectomy. And post-surgery, she had an improvement in her scalp hair and she was quite contentful with now. And post-surgery, the levels have come down. She's on follow-up now at SWIMS. So the fourth patient and the last presentation, the 53-year-old postmenopausal woman for the last 5 years presented with temporal recession of hair with excess hair growth on the face, which was only for the last 3 months, which has affected her quality of life. Actually, she has come for hypothyroid management. She is non-hypothyroid and TSH was elevated. She had an FGS score of 12/36. In view of her hirsutism, pelvic examination was being done and no pelvic masses were felt. Then the TSH was elevated, she was managed accordingly and the dose was adjusted, testosterone was elevated, DHAs were in the normal range. Then the ultrasound was done with an endometrial thickness of 12 millimeters, which was quite high for a postmenopausal woman. MRI abdomen was done, which shows a soft tissue lesion 2 by 2 centimeter sized in the right ovary. With a clinical diagnosis of right ovarian tumor, query testosterone secreting. This was a patient with the temporal recession, if you can see on the lateral view, and the faces was almost like hirsute faces on the hirsutism on the upper lip and chin. So she was subjected in view of the endometrial thickness being high and estradiol was elevated for this patient. The patient was subjected to total abdominal hysterectomy with bilateral salpingo-oophorectomy, and histopathology has come as endometrium showing benign endometrial polyps with the right ovary harboring the Sertoli cell tumor. Testosterone done after 1 month of surgery was within the normal range. So this is a patient with androgen secreting tumor, Sertoli cell tumor of the ovary presenting as postmenopausal hirsutism. I was wondering why the patient was having an endometrial thickness of 12 millimeters with estradiol being elevated. There are quite good number of studies where hitting in endometrial hyperplasias and elevated estrogen levels. So that could be the reason for her endometrial thickening of 12 millimeters. So she was subjected to total abdominal hysterectomy along with the oophorectomy. So these are the 4 cases, quite different. 2 are the perimenopausal menopausal women and 2 are peripubertal women. So take home message of today is PCOS is the most common cause of hirsutism. Hormonal evaluation basically should include total testosterone and 17-hydroxyprogesterone levels. And if you are suspecting, go for the DHEAs even. And it's better to avoid free testosterone in the first option for the investigating. It's always better to go with the total testosterone because the assays available for the free testosterone are not accurate. So we need to, if the total testosterone is more than 1.5 nanogram per ml or DHEAs more than 7 micrograms per ml, it always points towards either ovarian and adrenal tumors respectively. So we have to do an MRI abdomen to see for the adrenal or the ovarian masses. Peripubertal onset, mostly benign like PCOS or non-classic CH. Postmenopausal hirsutism, we need to check for the DHAs and testosterone.
and see for if they are very rapid and sudden onset hirsutism, it's always better to go for an aggressive approach with MRI abdomen to see for any harboring tumors either in the ovary or in the adrenal. Generally, the adrenal tumors usually are malignant and they are associated with other hypercortisolemia, and also we need to check for the blood pressure and also the cortisol levels, because most of the time they are malignant. I thank one and all, and especially the Endocrine Society for giving me this opportunity. Thank you.
Thank you, ma'am. That's an excellent presentation. And any questions?
So I was thinking idiopathic hirsutism, we are checking only testosterone levels as baseline investigations. Would it be any beneficial checking the downstream metabolites like DHT, looking for any 5-alpha excess activity? And I was also thinking at the present or at the stage of presentation, could it be like a very early stage of PCOS or a subclinical phase where we are not picking up the biochemical parameters or the ultrasonic parameters?
Yeah, there are even mild forms of PCOS, like what I was telling, the idiopathic hyperandrogenemia. So most of the times the testosterone assays that are available are only for they are regulated only for the higher levels, like for the men. For the women, testosterone, the upper limit is 0.6 nanogram per ml. So the assays which are available for the testosterone now are not that accurate for checking the testosterone levels in the women. They are only, they are available and they are streamlined only for the male testosterone. So if you can see that most of the times the PCOS women, when we check the testosterone, they come normal within the range. And most of the time, I have seen like 80 to 90% of the hirsute girls who have come to me, all the time they come normal. Because there can be mild elevation of the testosterone in these girls as being seen in most of the articles, but it will be still in the range only. So there can be mild elevation, but that is not noticed in the biochemical testing. That happens in the female hirsute cases. So it won't be that high like in the male, and these assays are streamlined only for the male testosterone values.
And it's like in PCOS guidelines, only when the testosterone is elevated, we'll start with anti-androgen.
Yeah.
But there are like many girls, as you said, with hirsutism, not mild, like it's like FG score around 16 with a normal testosterone levels. So are we going to start OC pills along with anti-androgens?
It's always better, because anti-androgens, if the patient is on anti-androgens like spironolactone or flutamide, we need to assure that they are teratogenic, and if they are planning for pregnancy, they should stop. And as such, the anti-androgens, they can cause the menstrual irregularities. So it's always better to add an oral contraceptive pill. But yeah, definitely if the patient is on dual therapy of these two, hirsutism will come down. But definitely once they stop for, if they are planning for, and again it's the back, the hirsutism will be back, because.
Yeah. Another question is like normal girls with regular cycles with normal testosterone, they have like a focal hair over the chin, upper lip. Is it to be treated with anti-androgen, or they require something other cosmetic therapy only?
I do think these androgens, unnecessary exposure to these anti-androgens, because they can cause the potassium imbalances even sometimes. If the testosterone is in the normal range, my personal opinion would be go for the local depilatory procedures or epilatory procedures rather than exposing the patient to the anti-androgen levels. Most of the time they don't come for monitoring with the electrolytes or any other thing. And in a setup, it is not that easy managing with anti-androgens, I guess.
Thank you. If there are no questions, we'll close this session.
Yeah. Thank you.
Thank you, Dr. Sailaja, and I thank the chairpersons. And the next topic is on osteoporosis, how to decide treatment in OP setting and what are the newer guidelines for the treatment. And to chair this session, I invite Dr. Madhavrao sir, consultant endocrinologist, Guide Hospital, Kakinada, and Dr. Giridhar, consultant endocrinologist, Manipal Hospitals, Vijayawada.
And I request the chairpersons to introduce the speaker, Dr. K. Srikant sir.
At the outset, let me thank organizers for giving me the opportunity. I would like to introduce Dr. Srikant. I think he doesn't need introduction for this audience. He did his graduation from Guntur Medical College, post-graduation from All India Institute, and DM from Sanjay Gandhi PGI. He received Best Outgoing Student from Guntur Medical College in '97, received several gold medals, and he also received A.V. Gandhi Award for Excellence in Endocrinology. Over to Srikant.
Thank you, Dr. Madhara, and thank you for ESAP for giving this opportunity for talking on our endocrine topic. Anyway, without wasting much time, I will go on to the topic. So, osteoporosis, evaluation and management in our OPD sittings. It's predominantly, we diagnose that predominantly when we have a fracture, but bone is a living tissue, and osteoporosis is a disease where the bone mass deteriorates and the microarchitectural quality of the bone deteriorates, and it ends up in a fragility fracture or osteoporotic fracture. So this is the reason why, just like diabetes ends in microvascular and macrovascular complication, early detection of osteoporosis at low bone mass and microarchitectural deterioration prevents all osteoporotic fracture in due course of time as the age is progressing. The prevalence is, we think it is not so common, but what I realized is it is almost, according to International Osteoporosis Foundation, the prevalence is almost like 50 million in India. So it's almost 70 to 80% of diabetic prevalence. So that's why you should not neglect. Once upon a time, the treatments were not mature and it's not very aggressively pursued, and the results were also very slow. But definitely it's evolving and improving, and right now we have very good options for treating. What are the types? One is primary. As the age advances, the bone is likely to get weak, and the other is because of the hypogonadism after the menopause. Postmenopausal progresses the bone deterioration very fast because of the lack of estrogens. And secondary osteoporosis, predominantly any drug or any condition or any endocrine or non-endocrine disease which can affect the skeletal health in a negative way, also can lead to osteoporosis, that is called secondary osteoporosis. So what are the challenges and opportunities in management and diagnosis of osteoporosis is, one, it is grossly underdiagnosed. Just the way the reason for that is because of the absence of reliable, accessible and affordable test for diagnosing osteoporosis. This is one of the major hindrance. Just the way we have diabetes, random blood sugar, or a fasting and PP blood sugar, or a TSH for hypothyroidism, if you have that kind of test, it would be more prevalently or more easily screened for all eligible patients. And life expectancy has prolonged in India, so it is leaving more and more elderly patients at risk for osteoporosis and fractures. And the other reason is undertreated because of the affordability of the current agents like teriparatide and denosumab, and also the ability to treat and monitor, because these are all coming very new. And majority of the osteoporotic patients ends up in routine orthopedic OPDs with some bone pains and joint pains because of the lack of screening and because of their non-exposure to these therapies when they were young, when they are these are all one of the reasons. And also unavailability of organized osteoporosis workup, undervalued. People doesn't give as much as value to a cardiac disease to osteoporosis. These are all the factors which are causing. And opportunity, definitely it is a very good opportunity, just like diabetes. Multifactorial workup is available now with respect to multiple assays to diagnose and follow up. Better understanding of the disease of osteoporosis now rather than previous times. Awareness is also increasing, and good treatment options like anabolic therapies and advanced anti-resorptive therapies are available. And outcomes are also much better now. Coming to the signs, as you know, fragility fracture, any fracture is almost equal to osteoporosis. And if there is any other like kyphosis, loss of height, and all these things, bone pains, body pains, anything could be a reason to screen for osteoporosis. What is the definition of osteoporosis? This WHO definition is predominantly based on T-score, that is measured with the gold standard machine, that is DEXA scan. When the bone density defined by T-score, which is greater than minus 1.0, it suggests completely normal bone. If you have bone T-score of minus 1.0 to minus 2.5, we'd call it as osteopenia. When if it is less than 2.5, minus 2.5, it's called osteoporosis. Whatever may be the bone density, if there is an fragility fracture, it diagnoses that particular patient as established osteoporosis. These are the two machines. One is hologic machine, the other is lunar DEXA by GE. These are the two machines which are used predominantly in the current date for measuring osteoporosis. Who needs to be screened? Any woman who is greater than 65 years and men greater than 70 years or older can be screened for senile osteoporosis. Any postmenopausal at risk of osteoporosis also can be screened. If they are under 65, under 70, if there are any associated risk factors like duration of menopause or any other endocrine, non-endocrine or rheumatological disease likely to affect the skeletal, or any drug which can cause deterioration of skeletal health can be treated, or any adult with fragility fracture needs to be screened for osteoporosis. Another, apart from just T-score, which is only a single parameter and a DEXA scan, we also have another risk calculator that is called FRAC score, where we take into consideration age, sex, weight, height, previous fracture history, parental history, smoking, glucocorticoids, and several factors, including femoral neck BMD. Put all these things into this calculator. It is available online. Anybody can do it. If you will get a 10-year probability of fracture for any major osteoporotic fracture and hip fracture. So if this score is high, then also it is an indication for screening with a DEXA scan. So evaluation, predominantly the gold standard test is DEXA. We measure it lumbar spine, hip and forearm. And quantitative CT, other things are available, but they are not routinely used. It's only they use for cortical bone density and research setups. And you need a CT scan machine. It's even more rarer. So it is not a screening tool. So biochemical evaluation is extremely important. So once upon a time, we consider bone as a just a structural element, but it has got a lot of life in that, osteoclast, osteoblast and all. And we get a lot of information about bone by measurement of calcium, phosphorus, alkaline phosphatase, vitamin D, PTH. They are the basic things which we need before we go forward. Even FGF23 and 125-dihydroxy vitamin D3 will be helpful in certain cases of hypophosphatemia. This is also underdiagnosed disease, but it is more prevalent than we anticipate. Bone formation markers like osteocalcin, bone-specific alkaline phosphatase, P1NP, and bone resorption markers like cross labs, and urinary calcium creatine ratio is very useful tool for measuring the adequacy of calcium and vitamin D replacement. Urine phosphorus, these are the things. Risk factor evaluations, like all the historical risk factor evaluation, as well as all the secondary cause evaluation like hyperpara, vitamin D deficiency, hypophosphatemia, acidosis mediated osteomalacia, and Cushing's hyperpara. These things needs to be suspected and screened and ruled out before you really label them with osteoporosis. Not necessarily if you have no sign and symptom, but definitely you need to be looking out for all secondary causes before you label them and start the treatment. Sometimes starting a teriparatide in a undiagnosed hyperpara is pathetic, and simultaneously starting a bisphosphonate in osteomalacia is pathetic, and all these kind of mistakes should not happen. If you want to do that, you have to rule out. Nuclear medicine has got its own role, particularly in metabolic bone disease evaluation in the form of bone scan, and also sestamibi imaging for parathyroid pickup, and sometimes TIO localization, and also Dotanac PET CT for TIO localization, but this is not routinely diagnosed, but many of the orthopedic setups might be missing these cases. We are not getting to see them in the early stages, but definitely it is more prevalent than stated. And this is a case of, I am just quoting 3 cases. This is case of hyperpara presented with rickets. On further evaluation turned out to be high calcium. Majority of the labs in the local laboratories, majority in the local laboratories, the calcium came normal in this particular patient. When I suspected and sent for a different lab, then it turned out to be hyperpara. Then this is the osteomalacia, this thing, many orthopedicians would be seeing. And these are the cases of tumor-induced osteomalacia which we published. These are the tumors just like parathyroid tumors present anywhere in the body, either in the soft tissues or in the bone or in the meningeal sinuses, and can cause crippling osteomalacia because of loss of phosphorus from the urine, and very low phosphorus levels leads to osteomalacia. So these are the just 3 hardcore endocrine metabolic bone diseases which needs to be ruled out, and we have every setup to diagnose that. So what is the aim of therapy in osteoporosis? Mainly the prevention of fracture. How do you prevent it? You have to increase the bone density, particularly all the 3 areas, lumbar spine, forearm and total hip. It doesn't mean that if you are increasing with some method, these 3 areas only are increasing, but these are the 3 common areas of fracture. So we measure them with DEXA, these 3 areas. And improvement of bone turnover markers also, that is improvement of bone formation and decreasing in the resorption. Improvement of FRAX score and quality of life and quantity of life. What is the basic approach is maintain the balance versus between the resorption and formation. So reduce the resorption rate and maintain the existing bone mass and increase the formation rates. These are the 3 things that you have to do. Unless you understand the bone and its metabolism, you can't play with this metabolism, and unless you get it right, you can't get the BMD gain. Once you get the BMD gain, obviously it is associated with risk reduction in the risk of the fractures. So we have to categorize the patients into 4 categories: low risk, moderate risk, high risk and very high risk, because treatment decisions are all based on them. And if the T-score is greater than 1, -1, it is low risk. Moderate risk is -1 to 2.5. And young people, FRAX is also less than 20%, less than 3. We don't need to do, apart from calcium, vitamin D and supplementation and improving the non-pharmacological methods, we don't need too much. High risk individuals like T-score -1.0 to -2.5 with a history of rigidity fracture of hip or spine, and with a FRAX score is greater than 20%, greater than 3%, here you need to strong improvement in BMD, injectables needs to be suggested. Very high risk cases are always at risk, and we have to do everything in our capacity to improve the BMD and also reduce the risk of fracture. These are the patients with fracture while on therapy, multiple fractures, fracture while on drugs causing skeletal harm like glucocorticoids, very commonly used in our setups, and very low T-score and very high risk of FRALs, and FRAX score is also very high. There we need strong and fast improvement of BMD and rapid reduction of fracture risk. These are the ABCDs and beyond: abstinence from tobacco, excess alcohol, caffeine, all these things needs to be avoided, because anything can cause fall, that needs to be avoided. That's why alcohol is also not good. Behavioral lifestyle management and calcium, vitamin D supplements, exercise, weight bearing, low impact, fall prevention, good nutrition, everything is important. So let us look at the available options. We have 3 options. One is anti-resorptives, which prevents the bone resorption by bisphosphonates, demosobab, estrogen and SCRMs, like selective estrogen receptor modulators. Though they are there, they are gone out of favor, but I'll tell about them in the future slides. Anabolics like teriparatide and abaloparatide, and recently there is a new drug by name romosozumab, which is a dual action drug. It increases the bone as well as decreases the resorption. It is appears to be one of the most effective, most promising therapy for osteoporosis. As of today, it is not available in India, and it is one of the expensive treatment. So coming to the anti-resorptive, we have seen these drugs for the last 10 to 15 years. We have seen the positives and negatives of that. We have 4 agents in that: alendronate, risedronate, ibadronate and zoledronate. This is given once a yearly, this is once a month, these two are once a week. So other drugs are Deno, SARM, estrogen, all of them, they act predominantly by decreasing the resorption and thus producing some amount of bone gain and thus relative risk reduction in the fracture incidence. These are well known. The problem with bisphosphonates is they reduce the bone turnover overall. It means the formation is also suppressed and resorption is also suppressed. Because many of the osteoporosis, resorption is dominantly active, that also produces some amount of bone gain. But long run, suppressing bone formation is not good for any kind of bone. So these are the complications and long-term use like osteonecrosis of jaw, atypical fracture, atrial fibrillation, esophagitis. So they are also slowly going out of favor after the modern drugs are becoming available. SERMs usually receptor modulators, estrogen agonist at bone and antagonist at the breast. This is a dual action. It's the same estrogen receptor only stimulates, but it acts in two different ways, one at this place and this thing. Any person with breast cancer or at risk of breast cancer, this is one of the drug which can be given with both the benefits. Estrogen only for symptomatic postmenopausal women, shortest time possible we give, predominantly when there is hot flashes and all. There it also not as a primarily to improve the bone, but primarily to reduce the symptoms. This is the drug which has become latest, recently available in the market and regularly being used for osteoporosis management by name denosumab. It is an antagonist of rank ligand at rank receptor, reduces the maturation of osteoclast, that is bone resorbing cells. So obviously the destruction of the bone is slowed down predominantly. 60 mg subcutaneously once in 6 months. It's very convenient. It doesn't have to be taken by the patient. Once in 6 months, whenever they come to orthopedic or endocrine setup, we can give that. Bone density increases comparable to almost anabolic. So no drug holiday, negligible side effects, never stop. If planned to stop because of unaffordability, replace with bisphosphonates as soon as possible, because whatever the bone that has been gained should not be allowed to fall back again. And teriparatide is the drug which has been available, but initially it was very costly. Now the costs have come down because of the generic availabilities. Subcutaneous injection 20 micrograms, maximum 18 to 24 months, improves the bone quality, to be followed by anti-resorptive therapy to protect the gains. No advantage of combined anabolic and anti-resorptive therapies in the previous trials, but one latest trial has shown a good concomitant use also. I will tell in the future slides. Romosumab is a monoclonal antibody against a sclerostin. It's a bone formation inhibitor present in the bone. If it is inhibited, the bone formation is also activated. It is given 210 mg once a month for 12 months. Both anabolic and anti-resorptive actions have been proven and effective even after anti-resorptive therapy course also. So some vascular events have been reported, but lot of data is not available. Whatever may be the anti-resorptive or a formation agent, the relative risk reduction happens across all the drugs, across all vertebral, non-vertebral fractures, hip fractures and all major osteoporotic fractures. It is to the tune of 18 to 20% to almost 70% the relative risk reduction, of which teriparatide causes the maximum reduction in non-vertebral fractures, that too within 12 to 18 months. So this is best suited for very high-risk patients. What are the types of therapies? One is BMD gain, followed by maintenance phase, and followed by fall prevention and secondary cause management. These are the 4 lines we have to think. In the first phase, you can use either a monotherapy or a combination therapy using 2 agents together, or a sequential therapy. Start with anabolic followed by a anti-resorptive therapy kind of methods. Still lot of trials are happening with new drugs, and more data will come. BMD maintenance is usually a single agent. Fall prevention is improving all aspects like musculoskeletal health, vision, kinesthetic and this thing. Secondary cause is evaluation. These are the changes over 2 years when you give teriparatide denosumab combination. The combination has produced very good bone density gain compared to either agent alone. Followed by data study, they stopped both the drugs and continued only on denosumab, led to further increase in the bone density. So today, this strategy of teriparatide plus denosumab followed by denosumab appears to be the most effective strategy with highest bone gain and risk reduction. Teriparatide followed by denosumab is second. Denosumab alone is the third strategy. Bisphosphonates if they cannot afford all these three. So this is the system. Patient-centered approach. Of course, we have discussed everything about guidelines and everything, but not many patients will have the this thing. You have to take individualization into consideration before you this thing. These are the at-risk patients. Prior patients with prior fracture should be considered as the top priority to treat this. My take home is evaluation is the one of the important. 80% of the patients are not being screened. If possible, try to screen any susceptible patients with history of fracture, definitely screen. If they are health proactive, they are affordable, they wanted to take care of their bone health, definitely do screen them. Send to a place where every evaluation is available, our knowledge is available. Standard treatments, you start, anybody can start fall prevention, calcium, vitamin D, muscle exercises. Chronic care principles has to be taken into consideration. Just like diabetic patients is kept under long-term follow-up, these patients also needs to be screened for DEXA every yearly, 2 yearly, depending on the therapy that you are using. If you are using anabolic therapy, we do more frequent BMD. If you are using anti-resorptive therapy, we do less frequent BMDs. Very high-risk cases, the 4 strategies such I have discussed, you can initiate depending on the affordability of the patient. So they usually cost 8 to 10,000 between per month as the course. So if they can afford, this is the best strategy to start, and this is the in decreasing order. Abaloparatide and romosubab are not available in India. So, but in due course of time, if they are available, we can consider them. So I think my time is up. Thank you.
So we are already running late. 1 or 2 questions from audience.
Usually they are all to increase the screening numbers. People have invented those kind of machines, but all the studies and all the international guidelines, WHO guidelines are based on DEXA, because it takes into consideration the 3 most important areas: lumbar spine, forearm and hip. These are the 3 areas for almost 80%, 90% of this thing. So once we screen, if it is low, we can always go for a DEXA scan, screen, and if it is as per the recommendations, then we can follow. Yeah, pre-screening we can consider. Just like a glucometer test for blood sugar or BMI for obesity, you can consider that way. You can't base treatment decisions on the basis of that, I think.
One word of caution, don't take treatment decisions based on the whole body BMD. I have come across many patients where they do whole body BMD. Obviously it will be -3, -4. Even for young individuals like 20 years, 30 years, they give, some practitioners give bisphosphonates.
So that is one of the very bad practice. Bisphosphonates, they are not to be used like that. And I have seen one orthopedician also, who is a senior orthopedician. When the bisphosphonates have come, this thing, without screening, he started his wife on almost alendronate for 10 years. Okay, so when suddenly one day she had complained of some femur pain, he has seen a hairline fracture, but it is almost like femoral shaft fracture. And after 10 years of bisphosphonates, completely suppresses the bone turnover. Usually bone turnover cycle is 6 months and resorption formation happens in cycles. So when it is suppressed, you will have the tibial osteonecrosis of jaw. She had developed all the 3 complications: osteonecrosis of jaw and tibial osteonecrosis and femoral shaft fracture. So we had to use teriparatide for almost like 2 years in order to activate the metabolism, and then the fracture healed spontaneously. So, but the tibial fracture led to osteoarthritis, and she had to undergo replacement of the knee also. So, because of the knowledge gap, these are all happening. Like some pharma company will do cortical bone density and measures like -2.5, and then they give some orthopedicians it's easy because they are not exposed to this kind of workup and then systematic follow-up and all. It is happening. The only way to educate them more and more, and now the time is very right because we have every good agent and we have better understanding of the disease and all complications are also known. So I would suggest that is a not a good practice. I think.
Shrikant, the doctor is ultrasound doing the calculation. If it's normal, do you think that
Sir,
you can exclude osteoporosis?
If there is completely normal, no symptoms, no risk factors in a 30-40 years old patient, nothing to do.
No,
if it is
60 years.
60-70 years with a fragility fracture, history is there. Even if it is normal, we have to do a DEXA.
No history at all.
Then obviously, I have not done any study, but I have not this thing. I do by DEXA, so I never compared that vis-a-vis comparison. But maybe doing a calcium vitamin D supplementation for all of them is a standard that we can do. Screening for a DEXA is the only thing which I would suggest. If they are +1 or 2, I don't know. I have not compared, I have not gone to any study.
US has poor sensitivity and poor specificity, so we cannot take any decision on the basis of QS.
Yeah.
Quantitative ultrasound.
Without DEXA, can we start treatment based on FRAX score, sir? Are there any certain thresholds?
Without DEXA, see, that is it is like managing diabetes without RBS. Okay, so that has been the WHO definition based everything, treatment decisions, how much bone gain has happened. It is now a disease where you need to see treatment failure is also there is an option. Like teriparatide may fail, denosumab may fail, a combination may not give good results, and moreover you are giving 8,000 to 10,000 therapy, and DEXA doesn't cost, and we don't do very frequently like once in a month. It is once in 6 months or once in a year, and it is costing 1,500. So starting 40,000 therapy and not doing DEXA is not a wise option. If you are doing calcium phosphorus alkaline phosphatase and doing calcium supplementation and fall prevention without DEXA is acceptable. But if you are going for a high-risk patient and treating with anabolic and antiresorptive, I would strongly recommend complete workup for everything.
No studies have been conducted on the basis of FRAX score alone, madam. No
BMD, they are doing.
No pharmacotherapy studies have been conducted and documented improvement, that is reduction in the fractures with the FRAX score alone. No studies have been conducted. I think we are running late.
Thank you.
Thank you, sir.
Thank you, Srikant sir, and thank you, chairpersons. The next session is evaluation and treatment of hyperprolactinemia. I invite Dr. Jayanti Ramesh sir, Professor, Department of Endocrinology, KGH, Visakhapatnam, and Dr. Amulya, Consultant Endocrinologist, Origin Endocrine Center, Vijayawada, to chair this session. And the speaker is Dr. Kiran Mai, and I request the chairpersons to introduce the speaker.
Good afternoon, one and all. It is my pleasure to introduce Dr. Kiran Mai Alla. She passed from Guntur Medical College. She has done her MBBS there in May 2000, and she had done her MD Pediatrics from KGH in Vizag in May 2006, and she passed DM Endocrinology from KGH again in July 2012. She is presently working as consultant endocrinologist in Manipal Super Specialty Hospital since the last 2 years.
So there is a change. Somehow it got uploaded.
Yes, nice, Kiran Mai. That we have got a nice, very common endocrinological disorder, hyperprolactinemia, which is not only reversible to partially to some extent, reversible cause of amenorrhea, reversible cause of infertility. So I think we'll have the practical application of the evaluation as well as certain recent concepts of treatment. Please go ahead.
Yeah.
Good afternoon, everyone. Thanks, organizer, for having me here. This is the place from where I graduated. Happy to be here and part of this session. And a small correction. I'm presently moved out of Manipal hospitals, and I work with my own setup, Dr. Kiran's Endocure in Vijayawada. So that's a bit about me. And so today's presentation is on hyperprolactinemia, which is a quite common disorder, the common basis of referral for any endocrine OPD. Sorry. So the diagnosis of hyperprolactinemia is straightforward owing to the ease of ordering serum prolactin. So whenever there is elevated range of prolactin above the gender-specific range, like in premenopausal women, if it is more than 25 nanogram per ml, and in men, it is more than 20 nanogram per ml, or even this holds good for post-menopausal women as well. So when these ranges cross, we diagnose hyperprolactinemia, the normal range being 5 to 20 nanogram per ml. So there are wide variety of causes for causing hyperprolactinemia, the basis being either increased secretion of prolactin by the pituitary gland or inhibition of the dopaminergic inhibitory tone over the secretion of prolactin. So ranging from physiological to drug-related, and at the other end of the spectrum, it is the pathological causes. So physiological, intense exercise, intense emotions, or even the venipuncture stress can elevate the prolactin levels. High protein diet also has an effect on the prolactin levels, and pregnancy, as you all know, it is the most common cause of physiological cause of hyperprolactinemia, to the extent of 10-fold elevation is seen. And then coming to the drug-related causes, there are numerous drugs causing hyperprolactinemia on the list. Among which the most common culprits, because of the over-the-counter medication usage in our setup in the routine OPDs, dopamine receptor blockers like the metoclopramide and domperidone are quite common causes. And then not to mention the anticonvulsants, antidepressants, and neuroleptics, especially the risperidone to some extent. These are the common causes of referrals in an endocrine OPD. And to the other end of the spectrum, if you look at pathological causes, the prolactinomas, hypothalamo-pituitary disorders, including craniopharyngiomas, any cellular masses, or for that matter, pituitary disorders, including empty cell and hypophysitis, and primary hypothyroidism, and PCOS, CKD, and cirrhosis can also have prolactin elevation. So when do we suspect a hyperprolactinemia case? So unless they come with a serum prolactin elevation, these are a subset of patients where we need to look into. The typical symptoms are seen in premenopausal women and men. This is secondary to hypogonadotrophic hypogonadism. This is because of the inhibition of the kisspeptin, which inhibits GnRH pulsatility, and which leads to hypogonadism. So it is in premenopausal women, it causes typical menstrual irregularities and then infertility. And if it is severe, bone loss also can happen, but this is not that common as with postmenopausal women, and bothersome galactorrhea is not that common. In men, it is the same, the hypogonadism manifesting as decreased libido, impotence, infertility, and gynecomastia, very rarely galactorrhea. Postmenopausal women, it is, they are already hypogonadal. To manifest typical symptoms, it is not quite common, and therefore they are usually neglected. They present as incidentalomas, or because of mass effect, or because of bone loss evaluation. The symptoms of hypogonadism, they do correlate with the concentrations of prolactin, and mild hyperprolactinemia, they present with infertility most of the times, and this is because of the short luteal phase, and moderate levels of hyperprolactinemia present with menstrual irregularities like oligoandromenorrhea, and when the prolactin concentration shoots up more than 100 nanogram per ml, hypogonadism, typical features, they present with overt hypogonadism and hypoestrogenemia, causing hot flushes, vaginal dryness, and apart from the menstrual irregularities, complete amenorrhea. And in such scenario, bone loss is also seen. So unusual presentations are not uncommon. So you need to keep hyperprolactinemia at the back of your mind when you evaluate a case of primary amenorrhea or arrested puberty as well. Sometimes in medical emergencies like pituitary apoplexy, CSF rhinorrhea, and sometimes there is coexistent tumor with the coexistent secretion of somatolactotroph adenomas where acromegaloidism is also seen, and very rarely galactorrhea in men is also a presentation. So the first step is always serum prolactin evaluation. So deciding upon the cause is the next bet, and the evaluation is also always aimed at excluding the wide variety of causes which already are discussed, like the pharmacological or extrapituitary causes, and finally carefully monitor the neuroradiological picture of the hypothalamo-pituitary region to look at any hypothalamo-pituitary masses. So hereby I'll be presenting a cost-effective and evidence-based approach to the evaluation and management. So detailed history intake, so the evaluation should always be comprehensive, look into the detailed history, detailed physical examination followed by investigative workup, which includes labs as well as neuroimaging. So the history should include a detailed checklist of all the medications which are known to cause hyperprolactinemia. And any woman of childbearing age, we need to look into rule out pregnancy as well, raised ICT features, and any symptoms of hypothyroidism or renal disease should be asked for. So in examination, the general examination, chest wall injury, including the herpes zoster, they should be looked for, and any signs of hypothyroidism or hypogonadism should be looked for. And then not to forget the neurological examination, look for any visual field defects, especially the bitemporal field loss. So the labs including a liver, kidney, and thyroid function tests is recommended in all cases of hyperprolactinemia. And as I told already, pregnancy should be ruled out in all cases of, in any woman of childbearing age. So then checking for other pituitary hormones, these should be done if there is a mass in the MRI. So neuroimaging consists of ordering a MRI. MRI with and without contrast should be performed in any case of hyperprolactinemia. This is to look for any hypothalamo-pituitary region masses which has to be treated. And then unless until you're quite sure that the patient is on a drug which is known to elevate the prolactin. But even then, in certain scenarios, when the drug-induced causes, it is more than 100, serum prolactin more than 100 also, we suggest, we recommend MRI. And in antipsychotic drug use, the prolactin levels further shoots up to the extent of 300. So if the prolactin is more than 300, even in drug-induced, antipsychotic-induced hyperprolactinemia cases, we do recommend MRI. So when you look at MRI, if you find a cellular mass and pituitary mass, you need to go for ordering pituitary hormone evaluation, because pituitary adenomas can cause hypersecretion, and any other cellular masses can cause a pressure effect and leads to hyposecretion of other pituitary hormones. So when everything is worked out with a normal hypothalamo-pituitary region without any mass, and there's no drug history, anything else is ruled out, then we term it as idiopathic hyperprolactinemia. So the same thing represented in an algorithmic fashion, and we need to be cautious of two pitfalls during lab evaluation, the macroprolactinemia and hook effect. So what is recommended is a single measurement of prolactin in a single sample is recommended to make a diagnosis of hyperprolactinemia, but that should be without any excessive venous
venipuncture stress, because even mild to moderate venipuncture stress can also elevate prolactin to modest levels. So in such scenarios where you suspect excessive venipuncture stress, or there is discrepancy between the clinical as well as and the prolactin levels, then we need to repeat the sample on a separate occasion, preferably fasting level, and we need to take 2 to 3 samples separated at a gap of 15 to 20 minute intervals to minimize the effect of pulsatility of prolactin. So in this picture, you can clearly see that the levels of prolactin are way higher when it comes to lactotroph macroadenomas. So all other causes, including microadenoma and drugs or any other pregnancy, all that, there is a slight overlap in the prolactin levels. But this is not the general rule. Like you can see that there are exceptions. Usually the serum prolactin levels correlate with serum prolactinoma, the prolactinoma size. So the microadenomas, they present with modest elevation of prolactin to the extent of 200 nanogram per ml, and macroadenomas, where the size is more than 1 centimeter, it presents with 200 to 1000 nanogram per ml. And then when it is giant macroadenomas, they shoot up to even more than 1000 to an extent of 50,000 as well. But this is not a general rule. Sometimes there are exceptions where the giant adenomas also can be, they are poorly differentiated and they do not secrete prolactin that much. And these are the subset of patients who do not respond well to the therapy. So as I said, there are 2 pitfalls which needs to be kept at the back of mind when you order serum prolactin. One is hook effect, where this has to be suspected when there is low prolactin in a strongly when a strong suspicion is there with a macroadenoma. And this is because we need to look into, because this mimics and misleads us to label it as a non-functioning or non-functioning adenoma, because just because the prolactin levels are low. This is because of the saturation of the antibody sites in the assay. This effect is eliminated by looking at a repeat sample, ordering for a remeasurement at 1 in 100 dilution. So next is the macroprolactinemia, where we suspect it when there is elevated levels in the absence of symptoms. Here there is no treatment is required. This is because of the bioinactive forms, because of the macromolecules which are relatively late to clear. So in this case, pre-treatment of the serum with the polyethylene glycol helps. So coming to the treatment, why should we treat a case of hyperprolactinemia? There are 2 indications why we need to treat. First thing is because of the lactotroph adenoma size, or for that matter any other adenoma causing compression, the neurological symptoms because of the size, and then symptoms of hypogonadism, and if it is a bothersome galactorrhea. And third indication is when there is a mild hyperprolactinemia, but still the woman is planning pregnancy because of short luteal phase defects, infertility is there, then this is again an indication for treating such a case. So always the treatment of choice in any case of hyperprolactinemia will be dopamine agonist, including prolactinomas of all sizes. So other modalities of treatment we do recommend when there is dopamine agonist receptor agonist resistance, or when the patient is on drugs like antipsychotics, which will be knowing shortly. So coming to the choice of drug, it's always cabergoline, that is the first choice and the recommended one, and most of the cases. And bromocriptine is the other preferred drug, wherein that is used for economical reason and in pregnancy because of larger cumulative experience. So treatment, I'll be focusing on based on the etiology. So coming to microprolactinomas first, which is quite common in the regular OPDs. So when to start, how to increase the dose, when to stop. these questions are always like, I do have, we need to recheck once in a while, because they just drop in and prolactin levels are controlled or not. Based on that, we need to go further. So when to treat a microprolactinoma? All microprolactinomas do not require treatment. It is important to note this point. Just reassure when it is asymptomatic. And in case of postmenopausal women, there is no treatment required. Just take care of their bone health with bisphosphonates, which is covered appropriately by the previous speaker. So indications for dopamine agonist therapy is like when there is troublesome galacturia, the symptomatic patients, and menstrual irregularities, and the woman is expecting regular cycles, and there is a desire for fertility, and men with hypogonadism and bone health is an issue. So start with cabergoline, which is the recommended drug, because it is having a greater efficacy both in terms of reduction in prolactin levels as well as tumor size decrease comparatively, and it has been accepted well by the patients, better tolerated. So the initial dose being 0.25 milligrams twice a week and or 0.5 mg once a week, and increased gradually once a week until the prolactin levels are normalized, looking at the side effect profile as well. So the mean dose usually is 1 milligram per week, and then bromocriptine, if it is used, 1.25 milligrams at bedtime, and increasing it to twice a day. So the adverse events are common, mostly gastrointestinal, where nausea and vomiting are quite common, which can be minimized by giving the dose at bedtime, starting dose, and gradually titrating. So this is followed by postural hypotension and dizziness, and valvulopathy is of concern only in those patients who are receiving high doses. This is more common in the doses with which we treat Parkinsonism. But with the doses routinely we use the cabergoline dose. This is not much of concern, but what is advocated is when cabergoline dosage is more than 2 milligrams per week, subject the patient to regular cardiac screening, like with 2D echo. So we have a strong data, comparative data, which clearly indicates that the prolactin levels are very well controlled with both the drugs, cabergoline and bromocriptine. But we can see that cabergoline is quite superior to bromocriptine in terms of decrease in serum prolactin concentration. So after starting the drug, we need to know how to monitor the response of to dopamine agonist therapy. So after 1 month of starting of cabergoline, or for that matter bromocriptine, call for a review, ask for any side effects, and then monitor the serum prolactin. And then the subsequent treatment will depend upon how the patient is responding. Looking at the prolactin, so the three scenarios. First is the prolactin is normalized, good, continue the dose, looking at the side effects, and probably your like the patient's concerns of hypogonadism will be answered within few weeks to months of time. And second scenario is when the prolactin is improved, like that is in the declining trend, but it is not normalized. And so such a case, cabergoline has to be increased, looking at the side effect profile as well, usually up to max of 5 milligrams per week. So set of patients who are intolerant or they have inadequate response, increasing the dose of cabergoline to max available dose in the literature is 11 milligrams per week, or switching over from one dopamine agonist to another. And then transpenoidal surgery or ovulation induction when the patient is wishing for pregnancy, and if they are not interested in conceiving, gonadal replacement therapy is indicated. So how to withdraw? It is like the gradual withdraw after at least the patient is on stable prolactin concentration normalized for at least 1 year, and then after at least the patient having a serum prolactin within normal range for at least 2 years and or more, and there is no longer visible mass on MRI at least for 2 years, then this is the time where we consider discontinuing dopamine agonist therapy. So in long-term follow-up also, like after stopping the drug, need to check serum prolactin after 3 months and yearly thereafter, and whenever there is shoot up in the prolactin levels, we need to order an MRI. So same is the case with macroprolactinomas. So no matter how big they are and how cystic they are or how severe neurological symptoms they do have. So because dopamine agonists, they do shrink the masses and neurological symptoms get relieved. And then vision has to be reassessed, MRI has to be taken after 6 to 12 months. And about a word about discontinuation of therapy, it is like gradually you can taper the drug, but you need to attempt discontinuation only in case if it is modest size macroadenoma to the extent of 1 to 1.5 centimeters. So don't even think of withdrawing dopamine agonists when there is a giant macroadenoma to the extent of more than 2 centimeters. So same thing represented in the algorithm. So prolactin level falls within few weeks, decrease in the mass happens in coming few months, and visual and pituitary function also a couple of days to weeks normalize. So causes for D2 receptor resistance or like because of the lack of D2 receptor expression, where we say as poor response when they fail to normalize prolactin or reduce the tumor size by more than 50% after at least 1 year of therapy. Optimal therapy is not defined, but usually majority do well with 2 milligrams per kg, per week. And then, so this is already discussed, switching over to one or other dopamine agonist and escalating the dose further and considering transpenoidal surgery followed by, if necessary, radiotherapy for the remnants. In case of macroadenoma, this is what we suggest as other modalities when we come across intolerance or resistance. So the recurrence rate after withdrawal of cabergoline is to the extent of 30% in microadenoma, and it is 40% in macroadenomas. So these are the indications already covered for transpenoidal surgery. So a word about prolactinoma in pregnancy, where most of them shrink because of the estrogen receptor changes and hemodynamic alteration. They do shrink well, so spontaneous remission is possible to the extent of 40%. So we stop dopamine agonists when the woman becomes pregnant. But in case of macroprolactinomas, we need to check for the visual fields every trimester, and if at all needed, when the patient is having impending neurological complaints or any other severe headache, we do the MRI should be done without contrast after the in the second trimester. So finally, a word about idiopathic hyperprolactinemia, same as microprolactinoma treatment, where you just follow up the case yearly if it is asymptomatic, and same way you taper like that of microprolactinoma if it is symptomatic. And hypothalamic pituitary diseases, as per the cause, we need to treat. If mass cannot be removed, same dopamine agonist therapy should be instituted. One last word about drug-induced hyperprolactinemia, which is very common in our referral basis. So if it is asymptomatic drug-induced hyperprolactinemia, no need to bother, reassure, no treatment is necessary. And if it is symptomatic, discontinue the drug if it is feasible. Or second option is switch over to a drug which is having a similar action, but that does not elevate the prolactin. And the third option being addition of estradiol or testosterone to men and women and men respectively for their hypogonadal symptoms and for their low bone mass. And finally, talking to the treating physician, cautious administration of dopamine agonist as per the clinical scenario. So the MRI recommendations already covered. So antipsychotic drug usage, which is quite common, a cause of hyperprolactinemia. Here it is important to note that drug cannot be discontinued because of its essentiality in the treatment to maintain the mental health. So in such a scenario, what we can do is change to an antipsychotic drug which will not raise the prolactin like quetiapine, addition or addition of the antipsychotic like aripiprazole, which has both agonist and antagonist properties, dopaminic suppression as well as agonist properties, which is added to the current antipsychotic drug like risperidone, which will dampen the elevation caused by risperidone, or addition of estrogen and progesterone.
Dr. Kiranmai?
Yeah.
Time is up, yeah.
This is the last slide.
We'll discuss the
So,
point,
yeah.
okay?
So, yes, sir. So, in hypothyroidism, hyperprolactinemia and enlargement of pituitary gland can occur in long-standing, poorly managed cases, which can be reversed with just levothyroxine therapy. We need not give a dopamine agonist in such a case. And already covered, macroprolactinemia is a benign condition. They do not require any treatment. We just need to diagnose it, ordering a polyethylene glycol test. Thank you.
Thank you very much, Dr. Kiranmai. Exhaustive. Any questions? One or two? Any questions from the audience? I mean, she has given a gist of it nicely and single pointers. Very nice. Your slides are very nicely done because it's very easily understandable. Yeah, what happened? Any questions? I mean, what is your approach to the antipsychotic? Like nowadays we have a lot of endocrinology and antipsychotic medication interaction and endocrinology problems. One of which is hyperprolactinemia is that. What is your approach? Like how do you interact with your psychiatrist? Like, I mean, the presently available, we know that risperidone does these sort of things. We also know that maybe shifting risperidone to olanzapine would be okay. But in such situation, we know that the olanzapine has got metabolic disturbances leading to metabolic syndrome. So in that situation, I mean, what is your, this one talking to the, I mean, the patient as well as patient physician, psychiatrist, as well as yourself? This sort of interaction, how do you think that can be done?
Yes, sir. Like, if possible, changing out to other drugs which will not raise prolactin, like the quetiapine, in conjunction with the treating psychiatrist. Otherwise, if it is not feasible, changing out to aripiprazole, which will not elevate and dampen the prolactin levels which are caused by risperidone. That helps, but that has to be talked to the treating physician, and then we need to take a call. If it is not symptomatic, we just follow the case and just take care of the gonadal symptoms. But in that case, giving estrogens can really, like, it is of concern in antipsychotic induced thing. And yeah.
Another question is that you projected that large tumors, though cystic, are mostly responsible. They're responsive to dopamine related. Then what is the role of surgeon then? Where do we refer, when do we consider surgeon's role in our situation as an endocrinologist in the management of macroprolactinomas?
Yeah. So initially, definitely we need to start with dopamine agonist therapy, though the severe symptoms of neurological symptoms are there. Even the size is very much bigger, because it really helps in immediately within starting of carbapenem, within few days itself the neurological symptoms come down, vision returns to normal. But then when there is invasion of the cavernous sinus, or the tumor is abutting the optic chiasma, and there are medical emergencies like the pituitary apoplexy, then such a scenario we need to take a call. And yeah.
That's very nice, man. Thank you. I think it's lunch time. We'll pack up. Thank you very much, Dr.
Thank you.
in the body. Some of this testosterone is converted to 5-alpha reductase, which is necessary for the external genitalia growth. Some of it is aromatized to estradiol, which is necessary for preventing bone resorption, for bone growth, and for a few other features in the body. And testosterone, which is mainly responsible for a majority of the human reproductive functions. And if you look at prevalence of hypogonadism, we've got a lot of definitions. Most of this will give you a total testosterone value of around 325, 200, 300, 350. For all practical purposes, most guidelines and textbooks will tell you that any total testosterone level less than 350 nanograms per deciliter would be considered suspicious for hypogonadism, and any value less than 200 nanograms per deciliter, which is an early morning sample, would be definitive for hypogonadism. And you see that as age goes on, the older the men age, the more likely are to achieve an andropause, and people who are over 60 or 70 years of age, most of them are likely to be hypogonadal. This is what you see in a lot of people. You got an age-related androgen decline. The total testosterone levels go down, the free testosterone level go down, and the sex hormone binding globulin goes up because your estrogen secretion goes up and your adipose tissue goes up, which also increases the estrone levels. And the mean testicular volume decreases as you age. The older you are, the younger you are, the more is your testicular volume. The older you are, the lesser is your testicular volume. We generally have two broad types of hypogonadism. Primary, which involves the testis, and secondary, which involves either the hypothalamus or the pituitary. These again can be either acquired or congenital. The commonest congenital cause of hypogonadism at the testicular level is Klinefelter syndrome, which is XXY syndrome. Undescended testis, especially if it is not brought down early in life by orchidopexy, is one other common cause. And rarely you can have an androgen receptor or enzyme defect like 5-alpha reductase or androgen insensitivity syndrome. Acquired can be because of testicular trauma, can be because of radiation, can be because of infections, the commonest of which is mumps. Can be because of drugs like ketoconazole, spironolactone, which have temporary effects, and chronic diseases like cirrhosis. Secondary hypogonadism, something which we commonly see in clinical practice, is Kalman, and not all variants of Kalman will have anosmia. Some of them can actually, Kalman type 2 can present with anosmia. Kisspeptin deficiency can also present with anosmia. Hyperprolactinemia, especially in men, is an often missed one. Women, it is easy to spot because they will complain of galactorrhea and they will also have irregular cycles. Men, unless and until you actively seek hyperprolactinemia, you are not going to find it. Cellular mass lesions or tumors, especially in the setting of headaches, any trauma, irradiation or infections. Inflammatory diseases which involve the pituitary like sarcoidosis, tuberculosis, histiocytosis, or iron overloads, especially in the setting of thalassemias or hemosiderosis, can present with a hemochromatosis like picture. Acquired causes, these can be short acting, especially in people who have had severe illness. Immediately after an illness, if you find low testosterone levels, it's always a wiser precaution to repeat the testosterone levels after a few days. Any malnutrition, you will have low testosterone levels. Then you will have a refeeding rise in the LH and FSH. Sometimes people even develop what is known as a refeeding gynecomastia because the high LH aromatases some of the new fully formed testosterone to estradiol. After a few days, this gynecomastia will settle down and the LH, FSH and testosterone levels come back to normal. Obesity can present with hypogonadism, the so-called MOSH, male obesity associated secondary hypogonadism. This doesn't usually require any treatment. A simple weight loss of 10% of the body weight will restore fertility as well as libido and sexual function. And sometimes opioids which suppress GnRH can also present with this kind of picture. These are usually short-acting forms of hypogonadism. Many a time, this is something which we miss in a lot of our patients, prepubertal onset. If somebody has presented with small testis, especially if the volume is less than 4 ml, it suggests that you've had a prepubertal onset of hypogonadism. If the testes are small but larger than 4 ml, it probably indicates that you have a pubertal arrest, either because of an infection, because of hyperprolactinemia, or because of tumors. If you have cryptorchidism, that probably means that there was a lack of testicular descent, there was testicular damage, and this testis is not functional. It is imperative that you bring the testis down because otherwise this might lead to testicular tumors. Gynecomastia especially is very common in androgen insensitivity, PAIS and minimal androgen insensitivity. A voice which is still juvenile, which has not broken. Epiphyses which have still not fused even at 17 or 18 years of age. People who are still growing into adulthood. Somebody with a unicoid habitus where the arm span is more than 5 centimeters, more than the height, or the upper span to lower span ratio is, the lower segment is longer than the upper segment. People who have sparse body or facial hair, but if you do not have any other features of hypogonadism, only absence of facial hair is not indicative of testosterone deficiency, because less facial hair is a classic feature which is seen in South Indians. Low bone mass can be seen in a lot of people with hypogonadism. Some people can even present with fractures. And once you start testosterone therapy, there is a rapid accumulation of bone mass. And reduced sexual desire activity is one of the commonest clinical features which points towards hypogonadism. In adults, people will actually complain, the commonest presentation most people will have is decreased libido. The second commonest would be an erectile dysfunction. Some people can actually present with unexplained infertility even though have normal function, especially people who have Sertoli cell-only syndromes, these kind of disorders. Some people can present with muscle wasting, secondary osteoporotic fractures, absence of hair loss, increased adiposity and obesity, and some people can even present with depressed mood. In fact, mood disability and mood disorders are common in almost all causes of erectile dysfunction and hypogonadism. Even when the primary condition remits, the depression can remain and cause a perpetuation of erectile dysfunction. And to screen all of this, we have multiple questionnaires. In fact, if you actually go through literature, you will find more than 10 to 15 questionnaires. They are topical, they are related to region, and they look at various aspects, both functional as well as the psychological aspects. The commonest ones we use are the ADAM and the MMAs. This is one of the most commonly used ones, the St. Louis University ADAM questionnaire. And among these, kindly focus on question 1 and 7. If you have a decrease in libido or sex drive, or if your erections are less strong, if any one of these two is positive, in all probability you are having a functional disorder. In all probability you are having an organic disorder. Or if any of the other three questions, you have decrease in strength or endurance of erection, if you have lost height, which indicates an osteoporotic fracture, decreased enjoyment of life, which can be very subjective. Even medical students have enjoyment of life, doesn't mean we have ED. You are sad or grumpy is true for most doctors. Recent deterioration in your ability to play sports, again true for a lot of us. Are you falling asleep after dinner or in lectures is again true for most of us. And has there been a recent deterioration in a work performance, again is a very general question and true for most of us. So that is why they usually focus on 1 and 7. To give you a brief overview of how this actually pans out in clinical practice, I'll give you a couple of cases. You got a 46-year-old who is an IT engineer who's had progressive weight gain in the last 3 years, strong family history of diabetes, coronary artery disease and hypertension. He has obesity, obstructive sleep apnea and diabetes. Presents with loss of libido and an erectile dysfunction. Fasting is 130, HbA1c is 8.2, prandial is 160, TSH is 3.3 and the uric acid is slightly elevated as expected in somebody who's got a higher BMI. The lipids are slightly elevated. He has normal gonadotropins and low testosterone, which is classically seen in people with obesity. The entity known as MOSH, male obesity associated secondary hypogonadism, where the estradiol, which is secreted from the adipose tissue, suppresses GnRH and the gonadotropins. That is why you have a low testosterone, normal gonadotropins, and presentation with this kind of a picture. The prevalence of hypogonadism is as high as 45 to 50% in people with diabetes. If you actually go into deep history with any of your patients with diabetes, most of them would actually report some amount of erectile dysfunction. And many people with type 2 diabetes do have sexual dysfunction because hypogonadism, vascular dysfunction, neurological dysfunction, and obesity go together. In fact, in the EMAS, the European Male Aging Study, almost 3/4 of the people who actually had diabetes and reduced testosterone were overweight or obese. And if your BMI is more than 30, which is their definition for grade 2 obesity, the testosterone was 144 nanograms per deciliter, lower than those who had a normal weight. And if you regain your normal weight, your testosterone almost invariably increases and libido is restored. And this was another meta-analysis which actually looked at almost 7,000 cases for of diabetes and controls. The difference in testosterone between the control and the test groups was 76 nanograms per deciliter, which is very significant. And men with higher testosterone concentrations, this relation goes both ways. If you have type 2 diabetes, you are more likely to have lower testosterone. If you have higher testosterone, you are less likely to have type 2 diabetes, probably because you are more active in sports, and testosterone also has beneficial effects on your lipid mass. And this is how it usually works. If you are obese, more production of estrogens, decreased GnRH secretion, LH peaks are cut down, low total testosterone, decreased FSH, low spermatogenesis, increased inflammatory cytokines, more of insulin resistance, and decreased kiss peptin signaling because of decreased leptin. These are all the pathways in which you can have hypogonadism in MOSH. The second case, a 52-year-old male banker who's got a BMI, good BMI of 22.6. He has fatigue, lethargy and tiredness, complaints of reduced shaving frequency, loss of libido and erectile dysfunction. He is well virilized, A3 and P5, testicular volume is 15 ml and an SPL of 8. This is what we found, a definite low testosterone. LH is low, FSH is low, pointing towards a secondary cause of hypogonadism. And when we did serum prolactin, which is a test which should almost always be done in people with secondary hypogonadism, we found that it was high. You were looking at a simple case of hyperprolactinemia. TSH and free T4 were normal. The pituitary showed a macroadenoma. And the treatment for this is simple initiation of cabergoline therapy. The minute you started, within 6 months, once there is a reduction in the prolactin levels, there is a normalization of your LH and FSH, and automatically the testosterone levels will be restored. In the third case, you got a 54-year-old male farmer, type 2 diabetes of 5 years, strong family history of diabetes, CAD and hypertension. You can actually see that he has gynecomastia. He does not have recession of the hairline. He has fine wrinkles. You can actually appreciate the smile wrinkles here, absence of wrinkles here on the forehead for somebody who is 55 years old. He has erectile dysfunction. The FBS was 140, HbA1c was 8.6, cholesterol was high, testosterone was low, and the FSH was 68. This pointed out towards a primary testicular cause, and the karyotype showed a Klinefelter syndrome, which had not been detected till date. Klinefelter is actually a trisomy, which is the commonest genetic cause of hypogonadism. The global prevalence reported varies from 1 in 5,000, 1 in 500 to 1,500. It's probably closer to 1 in 1,000. This is very common and it has myriad presentations. Many a time they actually don't present with very small, they'll actually present with very small form testes, and there is a spectrum of presentation of Klinefelter. There can be some amount of virilization in Klinefelter and this can be missed. The Sertoli cells are much more affected than the Leydig cells, and the hypogonadism can be missed because the testosterone can be enough to miss detection. The patient can be virilized enough to miss detection, and that is why a lot of times, until and unless they approach us for fertility issues, the milder cases of Klinefelter are often missed in clinical practice, and most of these diagnoses are usually not made till adulthood. We have a lot of presentations including varicose veins and other features where Klinefelter syndromes can present, but usually these people have low testicular volume, classically small form testis, slow pubertal development. You have a case of pubertal arrest or very slow pubertal development, and hypogonadism develops almost universally by late adolescence, but it is not very commonly detected. And this is what the Endocrine Society says about the diagnosis. Do a proper physical examination, take a good history, do a proper physical examination of this case. Do a normal hormonal assay. The first priority is do a testosterone, LH and FSH. If you are looking at a secondary case, do a prolactin level. If you are thinking of initiating this patient on testosterone, it always makes sense to do a prostate-specific antigen level. Also look at the karyotyping, and you might also have to do an MRI if you are suspecting a prolactinoma or a pituitary disorder, and a bone mineral density to look for causes of decreased bone density. And this is what I've always said. Ideally, do a total testosterone if you have to do only one test. If you can do all, do a total free and sex hormone binding globulin. The best one is do an LC-MS-MS. If you can't do it, do a CLIA. RAA is the third priority. Because testosterone levels are highest in the morning, you have to, for males, you have to do the testosterone levels in the morning. It is generally lower in the late afternoon, and the values can be as low as 20 to 50% by 9 p.m. And range between 300 to 1000 nanograms in most labs. For all practical purposes, anything over 350 is normal. You have to have low testosterone levels on 2 occasions, as well as signs and symptoms consistent with hypogonadism, like I've told you earlier. And a lot of times, exclude reversible illnesses, drugs and nutritional deficiency, confirm the low testosterone, find out the cause, whether it is primary or secondary, and evaluate accordingly. Management, more often than not, this is where our patients usually come to us with this part of the presentation. Everybody wants a testosterone injection. But ideally, this should not be the first line of management. If fertility is an issue, if you give them testosterone injections, you can kiss the fertility part of the treatment goodbye. You will actually have to look at the aspirations of the patient and try to maintain normal testosterone levels. Don't maintain the testosterone levels very high or the testosterone levels very low. You should just give them enough testosterone so that they have symptom elevation and normal symptoms. If it is secondary hypogonadism and fertility is an issue, you can give them gonadotropin therapy also. There are a few conditions in which testosterone should not be administered. Absolute contraindications is somebody with a metastatic prostate cancer or a breast cancer. Relative contraindications, you have a prostatic nodule, the reason for which is not really known. Unevaluated prostate-specific antigen more than 4 nanograms per ml. A high hematocrit, because testosterone can raise your hematocrit. Severe lower urinary tract symptoms with benign prostatic hypertrophy associated with American Urological Association scores. Or poor congestive heart failure. This is again debatable because newer studies actually are telling us that testosterone does not actually cause an aggravation of your CHF. And if somebody has a desire for fertility in the near term, like I've told you, you cannot give them testosterone. And the various preparations of testosterone we have are oral, injectable, and gel in order of preference. Least preferred to the most preferred. The commonest ones we use are the mixed testosterone esters of enanthate, cypionate, or undecoinate. Very commonly we use undecoinate, but my personal experience with undecoinate has been that the testosterone, blood testosterone levels actually go very high, 800 to 900 nanograms per ml. I don't prefer giving it in a lot of patients. It is lipophilic, leading to sustained release from muscle depot. The other testosterone esters, like the commonly used ones, mixed injection we give sustanon, which is a mixture of multiple esters, works pretty well, but you will have to gradually up-titrate the treatment. Start with 50 mg, escalate it to 100 mg after 3 to 4 months, 50 mg every 3 to 4 weeks, escalate it to 100 after 3 to 4 months, then 150 after 3 to 4 months. If you start with 250, you are going to have a problem of anger issues. In an elderly person, you are going to be faced with problems of priapism, which can be a major emergency. So don't start with 250 mg straight away. And the goal you want is a mid-cycle level near the middle of laboratory reference range. For instance, if you are giving them a 3-weekly cycle, try to measure the testosterone on day 11 of cycle. Oral undecoinate, 40 to 80, twice or thrice daily, variable absorption. It is unnatural that it gives you a high DHT to testosterone ratio, and you have to test the testosterone 5 to 6 hours after dosing. Many people miss their doses. As far as the gels are concerned, gels are expensive, but they are very difficult. For instance, in a country like India where there is a lot of sweating, gels are not very practical. The minute you apply gel, they get washed out by your sweat. You have to apply it in a non-genital area, shave the area and apply it, and ensure that you don't pass it on to your partner. And you have to check the testosterone levels 2 to 8 hours after application. Skin irritation is not commonly seen, but in a hot climate, it is not quite practical. You have some side effects like erythrosis, increased acne, slight risk of prostate cancer, and like I've told you, sperm production decreases with testosterone. Weak evidence, but we have seen definitely in the first few months of therapy, you do get gynecomastia because of conversion of testosterone to estradiol. Male pattern bonding will be exacerbated. Worsening of BPH symptoms can occur. Growth of breast cancer is equivocal, and worsening of sleep apnea, at least in the first few days, is seen with testosterone therapy. As far as the question of cardiovascular side effects are concerned, the recent evidence actually says that people with hypogonadism and a pre-existing high risk of cardiovascular disease testosterone replacement therapy is not much different when compared to the placebo, and you can safely offer them testosterone therapy. This was a bone of contention for many years, but almost all the recent studies actually tell you that the risk is not much. And this is how you monitor the testosterone levels. Initially, discontinue. Check the BMD. Most of the time, the BMD will be restored. Many of the endos here do it. Look for adverse events. To conclude, hypogonadism is very common in males. Even higher when you got obesity and type 2 diabetes, but many people actually don't approach a proper doctor. Most of our patients go to quacks for this condition because they are offered testosterone, which gives them an easy way out, but it is hugely counterproductive in the long run. And one major problem which is never addressed with testosterone, two major problems which are never addressed with testosterone therapy. The first question is why? Why do you need testosterone? The second question is, how long are you going to give them testosterone therapy? These questions are never answered if you don't have a proper evaluation. You do have increased occurrence of metabolic syndrome, dyslipidemia, and atherosclerosis in people who have hypogonadism. So whatever therapy we give, whether we give them testosterone or we give them LH and FSH, the management should focus on symptom improvement, alleviating the signs, and maintaining normal testosterone levels with the least amount of testosterone replacement therapy given, and overall the biopsychosexual health should be given importance. Patient should be informed that there is a time limit and there is a monitoring for the testosterone therapy. You have to evaluate the prostate, you have to evaluate the hemoglobin and the hematocrit, you have to evaluate the testosterone levels, and the patient needs to be on regular follow-up. It's not a prescription that can be given once and the patient has to follow it up for life. The patient has to follow up with you regularly. If he's the kind of person who doesn't follow up with you, then it makes better sense not to put him on these kind of therapies.
Thank you, sir.
That's it. That's the end of the presentation, and if there are questions, I'd like to take them.
Thank you very much for the excellent presentation, sir. Sir, do you have any experience in prescribing testosterone undoconate oral preparation, sir?
No, I have not prescribed undoconate because I had a few bad experiences with undoconate. Every time I give the injection, I always see, when I check the levels mid-cycle, I always see them around 800 to 900. Because the protocol is first injection at 2 weeks, then at 10 weeks, and then every 10 weeks thereafter. Right? Okay. I have never seen values below 500 with undoconate. I stopped using it.
How often this PSA level will elevate, sir, in the follow-up sessions?
Not many. If you give a proper dose, I have not seen PSA elevation, but you have to do a prior screening before you start PSA, especially in people who are practically, people say 40, but ideally more than 50. Anybody over 50, you have to do a PSA, and this follow-up is only according to guidelines. Practically, I think it should be slightly more frequent. Yes. You can't do an annual PSA. You'll have to do at least a 6-monthly PSA, or at least a 6-monthly ultrasound and scrotal ultrasound.
Yeah. Any questions from audience, please? Yeah, that's an excellent.
Thank you.
Now I request Dr. G. Haritha, Dr. Sunita Madam to come onto the stage. The topic is pituitary incidentalloma approach by Dr. Krishna Chaitanya.
Good afternoon to one and all.
Good afternoon to everyone. Dr. Sai Krishna Chaitanya, he's a consultant endocrinologist from KIMS Hospital, Ongole. He has done his general medicine from Kannur Medical College and DM Endocrinology from SWIMS Tirupati. Over to you, sir.
Thank you, ma'am. First of all, I would like to thank my teachers because of whom I am here today. I would like to thank the organizing committee for giving me this opportunity. And with this, I would like to start my topic. My topic for today is approach to incidentalloma. And I would like to thank the chairpersons for the kind introduction. So coming to the definition, pituitary incidentallomas are the pituitary abnormalities which are identified on the imaging studies, which are performed for reasons unrelated to the cella or the pituitary gland. Coming to the prevalence varies widely depending on the study population as well as the methodology. When you look at the microincidentallomas, the prevalence varies anywhere between 10 to 40%, whereas macroincidentallomas, it varies between 0.1 to 0.2%. In children, the data are very sparse, but a recent study has shown that the prevalence is supposed to be 2.2% of the MRIs. Coming to the most common pathologies, the most common pathologies in adults being the first and foremost is the pituitary adenoma, followed by Rathke's clepsis. In the children, the most common pathology is Rathke's clepsis, followed by other lesions. In the pituitary incidentalloma, we are more worried about the functionality of the pituitary incidentalloma. The functional adenomas constitute about 8.8 to 24% of all the pituitary incidentallomas. Coming to the evaluation, always in any pituitary incidentalloma, we need to evaluate for hypersecretion irrespective of its size. So we are going to evaluate for two main hormones, that is prolactin and IGF-1. As prolactinomas are the most common functional tumors among the pituitary incidentallomas, the first and foremost hormone which we are going to evaluate is prolactin. And the second one is IGF-1. As somatotropinomas are the second most common, we are going to evaluate IGF-1. And mild hyperprolactinemia, which has been already discussed by Kiran Mai madam in the previous section, the causes can be incidentalloma related or it can be unrelated. And the incidentally detected somatotropinomas are on a rise. In the recent studies, it has been clearly shown that the incidentally detected somatotropinomas, the incidence is increasing. When to evaluate for the incidentally detected corticotropinomas? The routine evaluation for incidentally detected corticotropinomas is not required. The testing is required only in patients with suggestive clinical manifestations of Cushing syndrome. Evaluation for hypopituitarism. After evaluating for hypersecretion, next most thing is in evaluation, we need to evaluate for hypopituitarism. When to evaluate? We need to perform testing for hypopituitarism when the tumor size crosses more than 6 mm. We need to evaluate for ACTH deficiency, where we evaluate the 8 AM serum cortisol levels along with ACTH, and TSH deficiency, where we evaluate free T4 along with normal TSH levels, which suggest TSH deficiency. Gonadotropin deficiency in men is documented by low serum LH and FSH along with low AM testosterone levels. In women, we document estradiol along with FSH and LH. Growth hormone deficiency, stimulation tests are rarely needed at diagnosis. And Endocrine Society recommends two protocols. First protocol is, in case of macroadenomas, it recommends two protocols. First is free T4 and morning cortisol and testosterone level estimation. And the second protocol is estimating free T4 TSH, FSH, LH, and testosterone, cortisol, ACTH, and IGF-1 level. The second protocol avoids repeat testing in any patient. So better to go with, if the patient is affordable, better to go with the second protocol. And if the patient is conservatively monitored, hypopituitarism testing should be repeated after 6 months and then annually. Posterior pituitary involvement. Posterior pituitary involvement, the diabetes insipidus is very rare and it indicates a different etiology than an adenoma, like Rathke's clepsis, craniopharyngioma, hypophysitis, or metastasis. And coming to the imaging, the most recommended imaging is pituitary-specific magnetic resonance imaging. So we need a pre- and post-contrast sagittal as well as the coronal T1 weighted images, and the image slice thickness should be less than 3 mm, ideally 1 to 2 mm, and with a minimal interslice gap should be there, and coronal high resolution and fast spin echo should be used instead of great spin echo T2 weighted images, which is more important to obtain through the cella, images through the cella. And the optional sequence is dynamic contrast enhanced imaging, where we repeat images at various time points, that is initially after administration at 15 to 30 seconds. We know that during the imaging for pituitary incidentallomas, the normal pituitary enhances after 60 to 80 seconds, and the adenoma enhances a bit later in T1 weighted contrast images. It will enhance after 90 to 120 seconds. So 1.5 to 2 minutes is required for the enhancement of the pituitary microadenoma. So delayed enhancement is a characteristic feature of the pituitary adenoma. Coming to the magnetic resonance pitfalls, we have the susceptibility artifacts, we have a motion artifacts, we have volume averaging, and the false positive examinations. We can clearly see that in imaging studies, the positivity rate for pituitary microadenomas is around roughly 40%, but the autopsy studies, it varies anywhere between 10 to 14%. So there is a high false positivity rate which needs to be taken into consideration. And in imaging, in normal MRIs, routinely these pituitary incidentalomas are detected on routine imagings like a normal MRI, where you have a subtle changes like bulky gland on one side where the microadenoma is present, and deviation of the infundibulum, so irregularity of the cellular floor. These are the different subtle MRI changes which are seen on a routine MRI, where you need to suspect a pituitary adenoma and go for a pituitary specific MRI imaging. So specific imaging findings seen in few lesions, like a thickened enhancing cyst wall or calcification, which suggests the possibility of a craniopharyngioma, and a thickened enhancing cyst wall with restricted diffusion is also seen in infected Rothkopf cleft cysts, and the presence of septation, fluid levels, and presence of off-midline location suggests the lesion is more likely a hemorrhagic pituitary adenoma rather than a Rothkopf cleft cyst. So midline location is characteristic feature of the Rothkopf cleft cyst, whereas off-midline location suggests a cystic pituitary adenoma. A RCC may coexist with pituitary adenoma. Then you can have a lesion exerting a mass effect upon the midline T1 bright cyst, which suggests this unusual diagnosis. So coming to the natural course, microadenomas, unlike the macroadenomas, they rarely enlarge, and apoplexy is also very low. And untreated paucisymptomatic somatotropinomas and corticotropinomas require evaluation for specific comorbidities. And neuroophthalmology baseline evaluation follow-up are needed in patients with lesions. When the lesions are only close to the optic chiasm, we need to go for a neuroophthalmological evaluation. In studies conducted between 1990 and 2011, they have seen that among the non-functioning microincidentallomas, only 10% increased, and 83% did not change in size, and the complication of pituitary apoplexy was noted in only less than 1% of cases, whereas in macroadenomas it was 5%. Coming to the macroadenomas, 63% had no increase in size over a period of 8 years, only 24% increased and 13% decreased, and the median growth rate in macroadenomas was found to be 1 mm per year. And symptomatic apoplexies is anywhere between 0.6 to 9%, which is roughly an average of 5%, and the risk is 4 times higher, with tumors crossing more than 2 centimeters compared with that of small tumors. Coming to the imaging surveillance in case of a microadenoma, first and foremost, we have a baseline, a diagnosis which we do it, and after 1 to 2 years, for a period of 3 years, we continue the surveillance. If no increase in size, then less frequently thereafter. If the tumor is less than 5 mm, even after 3 years, there is no need for further follow-up imaging, unless and until patient develops some symptoms. In case of a macroadenoma, we need to have a baseline imaging, and at 6 months, we need to have one more MRI, and thereafter annually for 3 years. If no increase in size, then we can take a less frequent approach based on the clinical features. Clinical and biochemical surveillance, the patient need to be evaluated clinically and biochemically at baseline after 6 months and annually thereafter for 3 years. Coming to the indications for surgery, the main indication is a visual field defect due to the lesion, and second, other visual abnormalities like ophthalmoplegia resulting from the lesion, and a lesion abutting or compressing the optic chiasma or the optic nerves, pituitary apoplexy causing a visual disturbance, any hypersecreting tumors other than prolactinomas. These are the indications for surgery in case of pituitary incidentalloma. Surgical outcomes. When you look at the surgical outcomes in macroincidentallomas, patients with pituitary incidentallomas, they exhibited lower rates of anterior hypopituitarism if they are, when compared to those with symptomatic patients. Pituitary incidentallomas, we consider they are asymptomatic. So the anterior hypopituitarism and the residue and the low rates of reoperation were noted. If they are symptomatic, these rates are higher. Visual outcomes. So it has been clearly shown that vision improved in 50% of the patients with pituitary incidentalloma compressing the optic chiasma regardless of the preoperative symptoms, and only 6% has transient postoperative diabetes insipidus. Coming to the basic approach, any patient, when you note a pituitary incidentalloma, first and foremost is history, clinical examination, and a biochemical examination. On biochemical examination, we'll come to know whether the patient is having a functional or a non-functional tumor. And when the patient is having a functional tumor, it can be a prolactinoma or other hypersecretory tumors, the most common being somatotropinomas. When it is a prolactinoma, go for the medical management, which has already been discussed. And other hypersecretory tumors, we need to go surgery with a medical treatment, and surgery should be with the intent of cure. Coming to the non-functional tumors, we can classify them into microadenoma and a macroadenoma. In case of microadenoma, the clinical biochemical imaging surveillance, which we have already described. In case of macroadenoma, if the patient meets the surgical indications, then go for surgery. If the patient doesn't meet the indications for surgery, then keep him on surveillance. Coming to the factors predicting the recurrence, you have the post-operative residue, which is the very most important factor predicting the recurrence of the pituitary tumors. Higher the post-operative residue, higher the rate of recurrence. And second one is the age. Age is if the age less than 40 years, the recurrence rate is more. Age more than 40 years, the recurrence rate is less. So the younger the age, the recurrence is more. And coming to tumor size, higher the tumor size, the more the recurrence. More the invasion, more the recurrence. And also the immunohistological types, higher Ki-67 index, all these predict high rates of recurrence in a patient with pituitary adenoma post-operatively. Thank you. Thanks to one and all.
Thank you, Dr. Chaitanya. It's a very nice presentation. And I have a few questions. Actually, the non-functioning pituitary incidentallomas most commonly are the gonadotrope adenomas. Do you suggest any biochemical evaluation in those cases?
Most commonly they arise from they have only subunit production, ma'am, so we don't need any biochemical evaluation for that. Only hypersecretion we evaluate and hyposecretion, as we have already discussed, but we evaluate.
Okay. Is there any role for specific subunit evaluation so that to confirm that the tissue is from the pituitary?
Yeah, we can do an alpha subunit estimation, which can be used, but it's not routinely performed, as we don't need it. And all the indications are, we have a clear-cut indications for surgery.
Okay. Thank you. And again, another question is, depending on the size of the adenoma, is there any change in the MRI timing for a bigger lesion frequency, difference in the frequency of MRI?
So main thing is the visual field, ma'am. So visual field estimation is the most important thing whenever the lesion is approximating the optic chiasma. But as far as the size is concerned, only micro and macro we have. But apart from that, more than 1 centimeter, the surveillance is the same. And if the lesion is abutting the optic chiasma, we'll be more stringently following up the patient, and we'll most likely go for a surgery with the intent of cure.
Okay. Thank you. Thank you.
Thank you. Thank you.
Any questions from the audience? Thank you.
Thank you.
Moving on to the next session, recent advances in diabetes management. The next topic is role of endocrinology in DKD by Dr. R. Santosh. I invite Dr. T. Sunanda, HOD, Department of Endocrinology, Narayana Medical College, and Dr. Banu Praveen, endocrinologist from Vijayawada, to chair the session.
Good afternoon, everyone. Now topic is role of frenulone in diabetes kidney disease. Now I am introducing Dr. R. Santosh. He did MBBS, MD, JIPMER at Pondicherry, DM Endocrinology at Chandigarh. Presently consultant endocrinologist and director at the Magna Centers of the Obesity, Diabetes and Endocrinology at Hyderabad. He got an award, Abdul Kalam Excellence Award for Healthcare 2017. So many publications, national and international. Over to sir.
So thanks to the organizers for inviting me to this beautiful conference in this good city. And it's a very nice property also which I came here. I came here to this particular hotel and was really happy with all the arrangements, even the hall, everything is so beautiful here. So I'm really glad to be here. So I'll be talking about the role of finerenone in diabetic kidney disease. And I'm not sure of how many people have already started using finerenone in their clinical practice. So I'll be briefly touching upon what is finerenone and what are the phase 3 trials that are suggested with finerenone. So as is the tradition, I'll be starting with one patient. He's Mr. Raj. He's a 63-year-old male with type 2 diabetes. He's been diagnosed with type 2 diabetes since the last 8 years. He comes with an HbA1c of 7.4% and an BP of 137/88. He's on optimum doses of ARB and hydrochlorothiazide. So if you see what is his complaints, he says that aside from my usual ailments, I feel good and I hope to stay like this for many more years to come. That's what he says. But the patient's doctor is worried about his renal condition and he has diagnosed him with CKD. Now, what are his values for his CKD? I'll just let you know in a couple of slides. But Raj is actually one of the 77 million adults across India who actually have type 2 diabetes and one of the 33 million people who have CKD plus type 2 diabetes. And therefore, this particular diagnosis of CKD in type 2 diabetes should not be taken lightly. It's quite common in our condition, in our country. So what is the big deal actually? So what if the creatinine is a little bit high, eGFR is a little bit low, if the urine albumin is a little bit high, what difference does it make in the patient? Look at the mortality rates. If you look at the 10-year mortality rates of a person who does not have CKD or type 2 diabetes, it's 3.4%. But presence of diabetes doubles the mortality, the presence of CKD triples the mortality, and a patient with type 2 diabetes and CKD, he has 6 times the mortality. That means only 20% of the patients who are having diabetes and CKD are actually going to survive after 10 years. And this is a huge, terrible number actually to take care. And we as healthcare professionals need to do something about this immediately. What are the diagnostic parameters for CKD? So we usually use 2 criteria. One is the presence of albuminuria by checking the urine albumin creatinine ratio if it is greater than 30 milligrams per gram. And if there is a reduced kidney function in the form of eGFR that is less than 60. So if you look at the latest guidelines, they talk about the various degrees of urine albumin creatinine ratio and kidney function, both making a stamp on diagnosis of kidney disease. So if you want to just put it roughly, you can say that, there can be a group of patients who have a normal albumin and normal eGFR. There can be a group of patients who have a low eGFR but normal albumin. There can be a group of patients who have high albumin but normal eGFR. And the worst patients will be those who have low eGFR and high albumin also. So these are the patients who are more likely to develop end-stage kidney disease and require dialysis also. What is better than albumin creatinine ratio or eGFR? So albumin creatinine ratio is supposed to have a better prediction for CV mortality than eGFR for cardiovascular mortality. And you can see along the complete range also, even in the normal range also, an increasing albumin creatinine ratio has a direct proportional to the cardiovascular mortality. What do the guidelines say? The guidelines say that you should screen a person with diabetes with urine albumin creatinine ratio and eGFR. How often should you do it? At least we should do it once in a year. Now in those patients who are already having declining kidney function, you might want to do it twice in a year or thrice in a year also. And remember, especially as far as albumin creatinine ratio is concerned, one report is never enough for diagnosis. You must have at least 2 or 3 reports in the first 6 months to diagnose the patient as CKD. Now let's go back to Mr. Raj. And if you see Mr. Raj, if he had seen only his eGFR, which is 47, he appears to be at moderately increased risk for CKD progression. But if you add the other data which he has, that is, he has increased USCR of 852 milligram per gram, then he falls under extremely high risk for ESKD progression. That means he will develop end-stage kidney disease very quickly. And therefore, the physician was right in worrying about this person. Now, if you make slight changes in the treatment and you change the reports of Mr. Raj little bit also, you can actually reduce the risk of this cardiovascular and ESKD progression. And in this particular patient, if you see, there is 610 milligrams per gram of urine USCR. If it reduces by 30% each time, you can bring the person to a range where the risk to progression of CKD will be much lesser, and you can progress the cardiovascular disease risk also in this particular group of patients. So what is the pathophysiology of diabetic kidney disease? So this is a very simplified slide of diabetic kidney disease pathophysiology. There are 3 drivers in CKD progression. One is hemodynamic, where there is elevated blood pressure and intraglomerular pressure. This second driver is metabolic, where there is a poor glycemic control. And third, there is inflammation and fibrosis, all of which lead to tubular interstitial damage, glomerular sclerosis, mesangial expansion, glomerular hypertrophy, kidney fibrosis, etc., etc. So if you go back to 2001, there was the data of renal study that was published, where losartan was used to improve the hemodynamic parameters, to improve the tubular-glomerular feedback and the glomerular pressure. And they saw that if you use such an agent such as ARB, you are able to reduce the risk of renal disease significantly. And therefore, after that, all the guidelines said that you must use ACE-ARBs in all the patients who have type 2 diabetes, especially who are at risk for progressive of kidney disease. Now, if you fast forward directly to 2019 and 2020, all patients are on ACE-ARBs, they are on optimal BP control, optimal statin use, everything is there. By the addition of this new group of drugs, that is SGLT2 inhibitors, they found out that kidney disease can be prevented even further. That means SGLT2 is helping not only in the metabolic parameters, they are helping in the hemodynamic parameters also. Therefore, SGLT2 inhibitors are wonder drugs as far as prevention of renal disease is concerned. But still, in spite of that, there is still residual risk is present. So what can we do for these particular patients? Then there is one more circle over there, the purple color circle, where inflammation and fibrosis seems to play a role. And what drug can help in inflammation and fibrosis is what we are going to discuss today. So inflammation and fibrosis is mainly because of mineralocorticoid receptor overactivation. And why does this mineralocorticoid receptor overactivation occur? It can occur because of various ligands such as aldosterone and cortisol. It can occur because of some non-ligand interdependent activation also. And in diabetic kidney disease, for reasons that are unknown, genetically there is increased mineralocorticoid receptors available at the kidney. And therefore, it results in higher albuminuria. Activation of this mineralocorticoid receptor causes damages at various organs. And the 2 main organs that get affected by mineralocorticoid receptor activation are kidney. So kidney, if mineralocorticoid receptor gets activated, glomerular damage, proteinuria, tubular injury, etc. will occur. Heart is another organ which gets really affected by mineralocorticoid receptors. Myocardial hypertrophy, ventricular remodeling, reduced coronary blood flow, ischemia, perfusion, all of them occur because of activation of mineralocorticoid receptors. Then what about the drug that I'm going to discuss today, finerenone? So finerenone is a bulky, non-steroidal mineralocorticoid receptor agonist. It goes and binds to that particular, it goes and binds to mineralocorticoid receptor in such a way that the downstream effects of mineralocorticoid receptor goes away. It's an antagonist. So already if you see, mineralocorticoid receptor antagonists are already present. So spironolactone is already there. Eplerenone is already there. Then why we have to make a new molecule such as finerenone? So if you have to compare between spironolactone and finerenone, so spironolactone is a very small, it's a flat molecule, whereas finerenone is a very bulky molecule. Finerenone has an extremely high efficacy for mineralocorticoid receptor. It has a high selectivity for mineralocorticoid receptor also. Now, spironolactone, it acts not only on the mineralocorticoid receptor, it acts also on the androgen receptors. And therefore, it ends up causing gynecomastia in gents, and it also causes decreased sexual drive in many patients. The other difference between finerenone and spironolactone is finerenone has a very short half-life. And because it has a short half-life, the tendency to develop hyperkalemia is lesser with finerenone as compared to spironolactone. And therefore, you can see the indications. More or less, aldosterone antagonists, the earlier ones, the spironolactone and eplerenone, are recommended for the management of congestive cardiac failure and resistant hypertension, but none of them got approved for the management of diabetic kidney disease, whereas finerenone, being a mineralocorticoid receptor antagonist which causes lesser hyperkalemia, has now been approved for the management of CKD associated with type 2 diabetes as well. So in India also, finerenone has been approved with the same indications all the patients who are having type 2 diabetes with CKD, if you use finerenone, we can use it to reduce the risk of sustained EGFR decline, end-stage kidney disease, cardiovascular death, non-fatal myocardial infarction, and hospitalization for heart failure. And that is now available in India, and we've been using it for the last, I think, close to 1 year now. So what are the studies that are there with finerenone? Now, all the latest studies in kidney, they don't include only patients with low EGFR. They are including patients with high albumin also. So huge range of patients are included in all the recent kidney outcome trials, and the finerenone trials are no exception. The two marquee trials with finerenone are these, the Figaro DKD and the Fidelio DKD. So they have very, very funny names. They have, all the Beethoven symphonies as names for their trials. Nevertheless, so basically what they did is, all of these trials, they had a run-in period, they had a screening period followed by patients who were either given finerenone 10 or 20 mg, or they were not given placebo, and they wanted to find out what happens. Figaro was mainly a cardiovascular outcome trial, whereas Fidelio was more of a kidney outcome comparison trial. And the latest trial is Fidelity. So Fidelity is a combination of Figaro and Fidelio. It's a pre-specified analysis of individual patient data from Fidelio and Figaro. And they had now data of 13,026 patients who were either given finerenone or placebo and followed up for 3 years. All the patients in these trials were having type 2 diabetes with CKD, and they were already on maximum tolerated dose of renin RAS inhibitors. Potassium should be less than 4.8. As I said, they have included all patients from the various spectrums of kidney disease, and they have seen both the cardiovascular CV composite, and they have seen something called as a greater than 57% EGFR kidney composite. So why did they use this 57% EGFR kidney composite? Means it is a sign of doubling of serum creatinine. So as the serum creatinine doubles, the EGFR is supposed to drop by around 57%. So at baseline, in this Fidelity trial, you are able to see that all patients are having type 2 diabetes, and all of them were on maximum doses of renin RAS inhibitors, that is either ACE or ARBs. Most of them were on statins, and if you could see, very few of them were actually using SGLT2 inhibitors. Very few of them. Why? Because when the trials were being done, SGLT2 inhibitors were very new drugs, basically. They were just introduced into the market, and therefore only 7% of those patients in these trials were actually using SGLT2 inhibitors. What happened to the kidney outcome in the Fidelity trial? If you compare finerenone with placebo, you are able to reduce the relative risk of kidney disease by this many. Its hazard ratio is 0.77 only. So almost there is a 23% decrease in renal disease, and mainly it is driven by the outcome where you are able to prevent or delay end-stage kidney disease. What about the heart risk, the cardiovascular morbidity and mortality? 14% reduction as compared to placebo, and mainly it is because of prevention of hospitalization for heart failure with this particular drug. And majority of the effects of this particular drug is because it helps in reducing the UACR. So if you compare to placebo, you look at it, there's almost 32% decline in the urine albumin creatinine ratio as compared to placebo. The cardiovascular mortality and all-cause mortality on those patients who are using finerenone as compared to placebo was also better. Therefore, this finerenone turns out to be a very good molecule in not only preventing diabetic kidney disease, but also preventing for hospitalization for heart failure and reducing the cardiovascular mortality. The main thing that everybody worries about with these group of drugs is hyperkalemia, is it not? So hyperkalemia definitely will be seen with this particular group of drugs, but the number of patients who are discontinuing the drug because of hyperkalemia is almost negligible. And no patient died because of hyperkalemia in this trial. And over 13,000 patients were followed up for 3 years in these trials. And the number of hyperkalemia episodes are very less and very comforting. And if you compare these with all the other trials where they have used dual RAS inhibition, for example, aliskiren plus ACE-ARB or ACE-ARB only, or placebo plus patirimor plus spironolactone, you are able to see in all, if you compare them with all the different trials, still finerenone was causing the least amount of hypokalemia, which is very, very comforting for us. Now many subgroup analyses were being done. What if the patient is having high HbA1c? What if the patient is having long duration of diabetes? What will happen to them? Doesn't matter. Even if the patient has diabetes for a very long time, the effects of finerenone will remain same as per the subgroup analysis. If you look at the patients who are having high HbA1c, normal HbA1c, low HbA1c, doesn't matter. Finerenone will work the same in preventing the cardiovascular and kidney outcomes. If the patient is on SGLT2 inhibitor prior to starting finerenone, also it doesn't matter. Finerenone will further help those patients, whether they are on SGLT2 inhibitors or not on SGLT2 inhibitors. And if the patient already has atherosclerotic cardiovascular disease, also you are going to help by giving this particular drug. Then the Health Institute of US, that is the NHS database, NANES database, was used to estimate the potential population level effects of finerenone. And what they saw that if you are using finerenone in people with type 2 diabetes, in all the type 2 diabetes patients in US, almost 38,359 cardiovascular events will be prevented. And therefore the guidelines were very quick to adopt this particular molecule in the management of diabetic kidney disease. So they say that all diabetic kidney disease patients should be managed by good glucose control, good BP control, good lipid control, plus the use of RAS blockade, SGLT2 inhibitors, and mineralocorticoid receptor antagonists. So they are not giving it as a choice. They are saying if it is possible, you give all of them. You give ACRBs, SGLT2 inhibitors, and finerenone if possible. So of course, India is a pay from pocket. So not everybody is going to afford finerenone. But luckily for us, right now we have at least the generic versions of SGLT2 inhibitors that are available, and many of the patients are getting benefited with this particular molecule. So all guidelines are now saying you start using finerenone because the data which is for the prevention of nephropathy is very good in this particular condition with the use of this particular molecule. Potassium being the only thing that we as clinicians, we have to be very careful while using this particular molecule. So when to not use this molecule? We should not use this molecule if the patient is already having a potassium of greater than 5. Don't use. Wait till his potassium becomes normal and then okay. If the patient is already having an eGFR of less than 25, don't use, because again, hyperkalemia will be very high. Patients who are having hepatic impairment, don't use. And patients who are using certain co-administration of selected medications like strong CYP4 inhibitors, don't use that. This particular patient whom I said, Mr. Raj, he was not on any of these particular criteria, so he was started on finerenone. Now, what do you do about, okay, this again, we are going back to basics. When to start this particular medicine? When the potassium is less than 4.8, it can be started with a lot of confidence. Between 4.8 and 5, it may be considered, and above 5, it is not recommended. So don't use finerenone when the potassium is above 5. At least wait for it to become normal. eGFR, if it is very low, less than 25, don't use. Between 25 and 60, you use 10 milligrams OD. And if it is above 60, you can directly start with a dose of 20 milligrams OD. When do you monitor the serum potassium? You're supposed to monitor as per guidelines after 1 month and after 4 months. So what I do in my clinical practice is I measure the serum potassium after 1 strip of the tablet is over. Because the tablet is expensive, so the patient purchases only 10 tablets from the pharmacy and goes. He reports the serum potassium. If we are finding an increasing serum potassium, we are a little bit worried about this particular patient. If he's okay, we ask him to purchase more and continue. Now during treatment, what happens? If his potassium keeps changing, what we'll do? If it is less than 4.8, you can maintain him on a 20 mg dose if he's already on 20 mg. Or if he's on 10, you can increase it to 20. If it is between 4.8 and 5.5, just maintain status quo. So if he's on 10, continue 10. If he's on 20, continue 20. But if it is above 5.5, irrespective of the fact whether he's on 10 or 20, just stop the drug for some time and restart with 10 mg once the potassium goes below 5. So the key takeaways of this particular molecule are, remember the 5 5s. Number 1, if serum potassium is less than 5, you can start. If it is above 5.5, don't start. If the eGFR is less than 25, don't start. Above 25, you start. And the key treatment effects are, if you give this in this particular group of patients, you are going to reduce the risk of end-stage kidney disease by 1/5. And you are going to prevent hospitalization for heart failure greater than 1/5 also. Therefore, making this as a very, very good molecule in the management of diabetic kidney disease, at least for all the patients who afford it. So with that, as the organizing secretary of SCCON Hyderabad, please block your dates. somebody should reach you out with the logistics. If they don't reach, please register directly and contact us on the email provided. We'll help you. So looking forward to host you all in Hyderabad on 14th to 17th December. Thank you. That's all.
Thank you, sir, for your nice presentation. Any questions from audience?
So no questions means everybody has understood everything, or nobody has understood anything. More than
Thank you, sir.
Thank you.
The next session is Evidence to Practice, Clinical Perspectives of Diabetes Management with Newer Generation Insulins by eminent speaker Dr. KVS Harikumar Garu. I invite Dr. K. Subbarao, endocrinologist from Guntur, and Dr. C.H. Venkatrakesh, endocrinologist from Vijayawada, to chair the session.
Good afternoon to one and all. So today's session is evidence to practice, clinical perspectives in the management of diabetes with newer generation insulins. This session is conducted by Dr. KVS Harikumar Garu, who is a consultant endocrinologist at Magna Centers and Fernandez Hospitals, Hyderabad. And Sir had a lot of publications, around 225, which are published in indexed journals. And Sir has won Dr. A.R. Sheth Gold Medal from Endocrine Society of India and J.S. Bajaj Oration Award from National Academy of Medical Sciences, New Delhi. With this, over to you, sir.
Thank you, Chairpersons, for the kind words, and good evening, everybody. Thanks to the Endocrine Society of Andhra for inviting me. And next 15 to 20 minutes, we shall discuss something about the newer generation insulins. This is the disclosure. I have been sponsored by Novo for this talk. We will discuss two aspects of the current generation insulins, how they change the diabetes practice, something about ultra-long basal insulin, and second about co-formulation. And something which is not there in the slides also, I will be talking about usage of the ultra-long basal insulin. And most of you would have used this in your clinical practice by now, either a single one or, as I said, a co-formulation. The degludec is one of the second generation basal insulins. The difference from the first generation being more peakless, longer duration of action, and less hypoglycemia to the patient. So you have a multiple benefits associated with the second generation basal. It is injected in a dihexamer formation. The phenol gets depleted, the zinc diffuses slowly, and which will give you gradual release of these single insulin molecules. Most of the times when you have used this, it actually mimics the physiology of a continuous subcutaneous insulin infusion. That is why most of the times the patients get better controlled with the usage of these insulins than when compared with the normal mix insulins, otherwise which are like PZI insulins, which will have more of a inter-individual and intra-individual variability. This is the trial evidence which compared the hypoglycemia benefit across, these are the three different trials, Begin, Switch and Devote, more than 16,000 patients. You have improvement in the nocturnal hypoglycemia, severe hypoglycemia, as well as overall hypoglycemia, including your phase 3 studies, CVOT data, as well as the real world data. And when you compare with the glargine U100, the first generation basal insulin, if you look at it, the lower within the day variability also is significantly less when you use the degludec than when compared with the glargine U100. Almost 20% reduction, 20% is with the degludec and 82% with the glargine. So you have a significant difference in the reduction in the variability. Why this is important? Some of you who have been using the CGMs in the clinical practice, you would have seen the TIRs and TVRs. So you would get a better TIR whenever you are looking at a molecule which is going to give you a consistent supply of insulin across the time frame. So you will have better TIR, and time below range is what we are all worried about. That is the time spent in the hypoglycemia time. So you have lesser level 1 and level 2 nocturnal hypoglycemias. This is the data, the confirmed data, which looked at comparison with the glargine U300 versus degludec. So it does show that there is some difference in the reduction in the hypoglycemias with the degludec insulin. So 30% lower rate of hypoglycemia versus glargine U300. This we have already shown that when compared with the glargine 100 we have seen, and comparison with the glargine U300 also, you have some reduction in the within the day variability. This is the graph what you get with the degludec as far as the day curves of glucose insulin ratio, and this is the graphs which you get with the U300 glargine. So that means to say that on a given day, once the patient has reached a steady state, you will have less variability of the insulin what is being released into the circulation. So this is the same in the table, which says that the glargine U300 has a 30% lower potency versus degludec because of that. So if you have lesser potency, obviously you require a higher dose of glargine U300, and you will have a lower dose of degludec, 23%, which will give you a better fasting than when compared with the glargine, which is seen in the BRIGHT study. Now, these are the RSSDI clinical practice recommendations. I am not sure whether you can read what is given in this highlighted portion. The glargine U300 requires 20% extra dose than when compared with the degludec. So, because of its, I would say, suboptimal efficacy, you will require a higher number of units. So, there is better adherence is seen with the confirmed study. You will obviously have more adherence if your product is going to work well, give you the objectives what you are looking for. So, in short, the ideal basal insulin and insulin degludec fits the bill because it is flat, peakless activity and minimizes the risk of hypoglycemia, longer duration of action allowing dose flexibility and minimal variability. In the last 6 months or 7 months after the time it is approved in the pregnancy, we have been using it mostly now in the pregnancy setup, in the GDMs especially. Type 1s, type 2s, there were some data earlier, but now we have been using this almost in most of the GDMs, where a single shot will give you almost a peakless profile and will give you a stable glycemic control to most of the times. Usually they have more of actually a postprandial peaks than when compared with the fasting peaks, but a single insulin instead of a 3-time short-acting insulins is giving you a good glycemic control with minimal risk of hypoglycemia, maybe 3 units, maybe 5 units per day would do the job comfortably in most of the patients. So another added the indication for this is actually the GDM, which has been approved in February or January 2023. So after listening to something about the basal insulin, we will go to co-formulation, that is the combination of a long-acting and a short-acting. So this is why it is called co-formulation. I will come subsequently. High carbohydrate diet is the commonest Indian reality. Starch, pure, lot of studies are there which looked at, and almost 60 to 70% of our diet is carbohydrate rich, and higher carbohydrates means higher postprandial spikes and more amount of refined carbohydrate, further the spike is going to be more. So it is the Indian Diabetes Care Index which looked at what is the A1C, what is the fasting level and what is the postprandial level, and all this have said that more than 80% of our patients had postprandial hyperglycemia. And if you look at, if you want to control your A1C, I'm sure most of you would have seen the Monier data and the Asian data, which looked at the postprandial contribution to the A1C is significant right across the spectrum of A1C in Asians, unlike Caucasians where it is more relevant in the lower spectrum. So you require to control your postprandials across all segment, especially in Asians and Indians, to have a good A1C control. Insulin, because if you use actually a premix, which is technically a mixture of a intermediate acting and a short acting, they don't retain their properties the moment they are combined. They have a single peak and they have a gradual downslope. Unlike this, where they both are living in the same injection, but the shorter acting or the faster acting aspart will behave the same way as otherwise if you are injecting separately, and the longer acting degludec also will behave separately as if you are injecting separately. So that is why it is actually not called a premix insulin, it is called a co-formulation, because they are just put together in the same injection and will retain their properties. So you have a mealtime control with the insulin aspart and a stable glycemic control, what you would otherwise get with a basal component. So this is the first co-formulation which has been used almost now more than 4-5 years of its existence in the Indian market. So looking at RSSDI, ESI clinical practice recommendations, Idagasp is recommended as a choice of insulin initiation in patients whom you feel that the OHA failures, and always you should avoid using insulin as a threat, because at some point of time most of the patients do require insulin, and concerns about insulin usage are by and large minimal with the current generation devices and the needles. So should be considered whenever patient fail to achieve the targets within after usage of 3 oral agents, and you should start with a once daily dosage. Sometimes you can start with twice, and if you want to up titrate, you can go to twice daily. The comparison between Idagasp versus basal insulin with the Glargine U100 and Idagasp once a day, and you see the more number of patients reaching your A1C targets, obviously because you're controlling your fasting, you're controlling your postprandial with the same injection. So whenever you actually think of starting insulin, instead of having a basal alone of using and then going on to a basal plus regime, basal plus meaning basal plus one-time prandial control. Basal bolus is the ideal where you are controlling 3 prandial peaks, but a basal plus regime is being achieved with a single actually injection. So you would get a 1.4% superior A1C reduction, similar fasting control as a basal component, and a better PPG control. So 72% more patients are able to reach their targets with the usage of this than when compared with the basal alone. That is why most of the times now, whenever you are thinking of initiating a insulin, it has actually been shifted to a basal plus regime, and if you still require further up titration, you can just make it twice. That will do the job rather than going into a basal bolus regime. So impact on quality of life, obviously that will improve the quality of life because of a advantage of being a single shot injection. 94% manage their day-to-day activities better. 89% of patients had better quality of life, and it is majority of patients found it comfortable to use in different social situations. Some of it is important because as most of them have got a duration of action of 36 hours, especially when you are using a single only a basal insulin. If somebody is traveling, somebody has got a delayed meal, somebody has got a meeting or some other thing, you can actually have a delayed injection. You are not going to have a dip in performance of the insulin release. So that is why you don't have those peaks and troughs of insulin with these newer generation molecules, unlike the older generation insulins. The current usage of these will obviously reduce the pill burden. Definitely, depending on the other comorbidities, you will continue your metformin, you will continue gliptin, you will continue gliflozin, but beyond that, you may not require anything with these molecules. So that is important to understand that you will require some OADs along with the usage of insulin. And when you compare IDA-GASP versus the basal bolus therapy, actually the difference, when you look at the basal bolus, is considered as the gold standard of any management of diabetes. But with the less number of injections, that is only 2 injections versus 4 injections, you have a similar fasting control and similar A1C control, and a significantly lower dose of total insulin what you are going to give to the patient, and obviously fewer number of injections. Most of the times patients are happy taking 1 or 2 rather than 4 per day. So that is why the RSSDA practice recommendations which looked at given this insulin intensification option also with the IDA-GASP than when compared with the basal plus. With the basal plus, it has got similar efficacy, less nocturnal hypoglycemia, and convenience of a single shot. And a basal bolus, identical reduction of A1C, less hypoglycemia and less dose, and obviously there is prevention of more secondary weight gain. So all those benefits have put it as one of the best possible agent as far as insulin types are concerned. Cost effectiveness, if you look at it, some of it by and large the cost is comparable with the current second generation, first generation insulins. First generation are definitely a bit less than when compared with second generation. But when you look at the risk of hypoglycemia, the risk of weight gain, the risk of other complications associated with it, the cumulative cost is going to be much more cost effective in using these molecules, especially in patients who have not been able to achieve the glycemic targets with first generation insulins. So IDA-GASP is a prudent choice for Indian scenario, which has lower hypoglycemia, more mealtime flexibility, simple regime, convenience of device, better quality of life, and cost effectiveness. On top of all this, it gives you a best and effective glycemic control. I have finished here. Any questions or comments, I shall be happy to take.
So thank you, sir, for nice presentation. Any questions?
Please. Degludec versus Glargine U100 or U300? Okay. See, the CVS or renal protection, there is no extra advantage like that. The biggest advantage what it has is about the hypoglycemia protection, which is a significant risk factor for all the other risk factors. So there is a significant data to suggest that the incidence of hypoglycemia is much less with that.
Sir, any other question from audience? Sir, I want to ask one question.
Yeah, please.
Sir, this Degludec and Aspart, it is available as 70 and 30 combination. Do you think there is need for development of 50 and 50? Because most of the times when we are calculating the dose of basal bolus, it is not 70-30. Most of the times, if you carefully calculate the basal part and the bolus part, it is either 60-40 or 50-50. So we are stressing so much upon carbohydrate diet, and we are still fixing to 70-30, which doesn't actually match with that meal, at least to our patients. So one more advantage of developing this 50-50 is we can give single insulin 3 times, where the basal part calculates for the 24 hours, that need is met, and the postprandial rise, which is met with the 50 part. Is there utmost need, and the company needs to focus in that?
Okay, 2-3 things I'll say. The 50-50 with the conventional we'd already have with the regular zinc ones. Now, most of the times what has been observed even in trials and in practice is when you use 50-50 in the night, your fasting hyperglycemia is more, because your 50% basal component is not sufficient enough to suppress your glucose production in the morning, so you're going to have a fasting hyperglycemia. Now coming to this combination, this has got a longest acting second generation analog, which may prevent that fasting hyperglycemia. But issue remains, if some of the people have the habit of having a breakfast at 9 and having a lunch at 12 or 1, ideally you should have at least a 4-hour gap between your 2 injections of these basal. So if you are having somebody has a lunch at 3 o'clock and dinner at 7 o'clock, now those are the times you are going to have some of those cumulative effect, even though studies have said that the stacking is not going to alter your pharmacokinetic profile and lead to hypoglycemia. But when you are looking at a degludec 3 times, which is going to be a bit more challenging in practice, that is why if at all you have to use, ideally you use twice morning and evening, and maybe use a shorter acting for a lunchtime. I mean, something mimicking your basal bolus regime almost parallelly. When we look at anything in that mix and match zone, the patients get confused. Because what insulin in what time, I mean, ideal job is to have the same insulin, the classical 1, 2, 3 regime. You use it once, twice or thrice. Same insulin should be injected, same time frame. So that will make it easy for adherence. When you look at, that is why most of the people, even when you use 50-50 now, we use 50-50 in the morning and afternoon, and we use 30-70 in the night. Because most of the time the dinner is not at the same quantity as your lunch and breakfast. So if you are giving same 50% of prandial component, you are likely to have hypos in the night and hypers in the morning. So somewhere that adjustment has to be done. Thrice daily premix of use, I mean co-formulation is very difficult, I would say, because when the duration of action is 36 hours and you are injecting them 3 times in 24 hours, it's not a easy thing.
Because the ultimate aim of any insulin is minimizing the complexity of regimen as much as possible so that they adhere to it and achieve that. And one more thing regarding GDM, sir, what you told is correct. The basal part, when we are adding, so far we are using glargine or the premix part. Glargine, when it is substituted by this degludec, the duration of action increases and the total duration of total insulin dosage comes down. And regarding that short-acting insulin, the aspart part, particularly we see this phenomenon in GDM patients, where sometimes we have to give 4 times the short-acting part, and it's not be visible for 3 times. But if you are giving 3 times the regular insulin, again the postprandial component will not be covered. So, will not be possible to mix this in single formulation, like one insulin giving immediate release and the other insulin covering for the 6 hours part. Well, because we can't give, when we are trying to give 3 times, the postprandial rise will be there, the regular insulin. And when we are giving the aspart part, again, it is not acting for though the duration of action, they say 4 hours or up to 6 hours, is not acting for 6 hours.
See, ideally, if you are looking at analogs, the duration of action is only 4.5 at the max. So you are not getting that much control. But if you look at it, you should, that is why, have a good basal in the background so that the prandial only covers for the meal-related glucose excursion. If you have, we didn't have a good basal still now. I mean, glargine, there is no doubt, is better than when compared with NPH. But now there is much better than, I mean, glargine is much inferior than you compare with a degludec or U300. So that is why a second generation shift has given you a complete control of a good basal insulin secretion, which was not available till now. So if you have a good basal in the background, a short acting for 4 hours itself will do the job. Only you may require 4 injections in some subsets, especially in type 1s, not in type 2s. Those also, the kids who say go to school, have 1 injection there, come at 4 o'clock, have a meal there, you give another injection, have another meal at 9 o'clock, have another injection there. Those are the very limited subset where you actually require 4 times prandial component. But conventional type 2 will do well with once or twice co-formulation. You don't require any prandial component at all. And you have good amount of drugs to control your prandial rise. I mean, all your OADs will help you in controlling your prandial rise.
GDM we can't use the OADs.
Obviously, in GDM you can't use except for metformin. We use metformin routinely, but not others.
At what dose of the basal part would you suggest splitting into twice daily, so even this degludec?
See, conventionally more than 30 units per day, if you are not achieving to your A1C, you should split. But if higher A1Cs, I generally, if something beyond 10 A1C, I use 6 and 6 or 8 and 8 twice daily to start with. So that you can actually up titrate gradually rather than start once and then go on to add another one. So it makes it easy for patient also to titrate the meal, and both major meals are covered with this drug. So that is how I use.
That's all. Thanks, sir.
Thank you.
The next talk is Timely Concepts, Advances in Basal Insulin Therapy by Dr. Jayadev sir. I invite Dr. Gopal Datta, Consultant Endocrinologist, Ramesh Hospitals, Vijayawada, and Dr. C.H. Srinivas, Consultant Endocrinologist from Vijayanagaram, to chair the session.
Good evening. Seeing that most of the audience are eager to leave, we'll try and complete the session in time. So, the speaker is Dr. Jayadev sir. Sir has done MRCP in UK and completed CCT in diabetes endocrinology from UK. He is presently working as a consultant endocrinologist in Shanti Endocrine and Diabetes Hospital, Vijayawada, and he is very active in research. Over to sir for presentation.
Thank you to Gopal and Dr. Srinivas, and thank you to ESAP, Dr. Lavanya and the team from Guntur. And good evening, doctors. My job is in the next 20 minutes just to probably contradict the previous speaker, Dr. Harikumar Garu, who has spoken about basal insulin. So I am also going to talk about basal insulin therapy and the advances. And as treating practitioners, we use basal insulin all the time or most of the time in type 1 diabetes. All our type 1 diabetes children, young adults require basal insulin, and they will be taking mealtime insulin as well. All the type 2 diabetes patients at some stage will fail on oral hypoglycemic therapies and will require a basal insulin therapy. So Glargine 300, the advances in basal insulin therapy with all the benefits which are mentioned here, will probably be going through what we had heard about the degludec insulin. Glargine has been a gold standard basal insulin analog for a long time. There are many other companies which have come up with Glargine, and we are using them as well. So they are all the biosimilars which are there along with Glargine. So all the efficacies and the lower hypoglycemic episodes, lower risk of nocturnal hypoglycemia, higher time in range, flexibility of dosing, and less painful dose because of the smaller volume is what is going to be there with the Glargine 300. We still use NPH insulin. Isophane insulin is still used a lot, even in type 1 diabetes. It is used in type 2, it is used in gestational diabetes. So we are not here knocking NPH insulin, which was detected way back in 1946. All we are trying to say is, given the peak of NPH insulin which is there, the insulin activity, you've got the advances. Detamir has come up, and then we know by the trade name Levemir. Degludec is here, we know by the trade name Tresiba, and then you've got the Glargine 300, which is fighting against the Glargine 100, which has been the gold standard. Even compared with Glargine 100, you can see the flatter profile of Degludec, which lasts almost 42 hours in the body. Glargine 300 is almost 36-hour duration action, but they are truly once daily injections. You can just give them once a day and forget about it. In the clinical trials, I'll probably cover one of the questions which was asked, how much dose of basal insulin can be given to these patients. So Glargine 300 and Glargine 100, they are the same. The molecule is the same. The way the molecule is highlighted, the alpha chain and the beta chain and the extra arginine which is there in the beta chain, it is exactly the same as Glargine 100. But there is a major difference in the pharmacokinetics and the pharmacodynamics of the drug. You can see that it is a concentrated form of Glargine. So we are well known with Glargine and we are comfortable with it, and now we have got a concentrated form which is 300 units per mil. More compact dosing, which leads to gradual release. So if there is a more compact dose and it sits there under the skin, the chances that the body proteases will denaturate the drug which is there is slightly higher. That is where the 20% higher dose requirement for Glargine 300 is. It is not a weaker drug compared to Degludec. It is just the way the molecule is there under the skin and it gradually gets released so that the duration of action is much, much prolonged. So even though it is the same molecule as Glargine 100, the pharmacokinetics and pharmacodynamics of the drug are entirely different. So it is a once daily injection, reduced hypoglycemia, reduced weight gain, adherence is there, and it can be given independent of mealtime, and I'll share the data as well. So why should we select new generation insulin? If you've got NPH insulin, if you've got glargine, why do we go for second generation basal insulins compared to the older insulins or the first generation basal insulins? All the important parameters are given here, and I'll share the data for it. And this is all coming from clinical trials. You've got PKPD trials comparing it to glargine 100. Those are type 1, type 2 diabetes patients are also included in some of the trials. The addition program where glargine 300 has been compared to glargine 100. Real world studies, type 1 diabetes studies. The BRIGHT study which is mentioned here is the one which compared head to head with degludec. Glargine 300 versus degludec. So this is PKPD studies in type 1 diabetes. You can see compared with glargine 100 which is in the violet, glargine 300 which is in the green is showing better insulin concentration, and the glucose infusion rates in the CLAMP study are much flatter compared to the higher glucose infusion rates which are happening with glargine 100. So much stabler profile, so it is not acting the same way. Even though the drug is the same, it is a concentrated form, the mechanism of action of the drug is entirely different, and this is in the type 1 diabetes patients. Not only that, you see a reduced risk of nocturnal and severe hypoglycemia. Glucose levels below 70 or below 50 on this forest plot. If you compare glargine 300 to the left, which is in the green, and glargine 100, which is violet on the right, you can see it is trending towards the benefit of lesser risk of hypoglycemia with glargine 300 as opposed to glargine 100. So it brings us to head-to-head studies, glargine 300, glargine 100. Type 2 diabetes patients, we all manage type 2 diabetes patients who fail on oral anti-diabetic drugs, who fail on oral plus single basal insulin, who fail on multiple basal bolus insulins and oral therapies. And all these patients were included in this addition study where glargine 300 was fighting against glargine 100 over a period of 6 months. So that is the study duration for type 2 diabetes. You can also see type 1 diabetes patients being investigated in the addition studies. And what these studies show at 6 months on the left hand side is similar HbA1c reduction. There is no difference between glargine 100 and glargine 300. The glucose levels are the same. But the risk of hypoglycemia anytime, risk of nocturnal hypoglycemia is lesser with the newer generation basal insulin compared to the glargine 100. And at month 12, which is exploratory data going on from month 6 months, you can see a slight improvement in the HbA1c, which does reach statistical significance. It is 0.01 for the p-value favoring glargine 300 as opposed to glargine 100. There was less weight gain with glargine 300, which indicates probably there was less hypoglycemia and less snacking. That is the observation which was there. And more patients are having a better A1C reduction with glargine 300 at 12 months in the addition study, which includes the addition 1, 2, 3, and this is the type 2 diabetes population. ETOS is a real world study. In the studies that I've just shown here, in the addition study, the basal insulin dose, glargine 300 or glargine 100, was given up to 60 to 70 units or at times 80 units as a single shot of insulin. The pen can carry 80 units. Quite a few patients were getting 80 units of the dose as a single injection. It wasn't given as a twice daily injection because of the truly flat profile. So basal insulin can be escalated, and all these trials had a treat to target rate of 70 to 110 milligram per deciliter as a fasting blood sugar target for these patients. Coming to real world study, this included a third of the patients from India, glargine 300, and this is just real world type 2 diabetes patients who fail on oral therapy or may not have failed, but they are insulin naive, they have been given the glargine 300. There was HbA1c improvement, there was improvement in the blood glucose levels, lesser chance of hypoglycemia, very minimal risk of hypoglycemia below 54 milligram per deciliter. 0.13% is very low. It is much lower even than some of the oral drugs we may be using at times. There was minimal weight change, and in fact the mean insulin dose in ETOS study was somewhere around 0.2 to 0.3 unit per kg body weight of the starting insulin dose. That is what they went up to. So somebody started on 14 or 16 units, they went up to 24 units in the real world study, and they were still getting a reasonably good HbA1c reduction. These populations are different to the population which was studied in the addition study. So that would be the difference there. Coming to BRIGHT study, this is a type 2 diabetes study, insulin naive patients who failed on oral therapies who were given either degludec 100 or glargine 300. There was no difference in HbA1c. You can see for non-inferiority it reached a statistically significant p-value, but for benefit there was no statistically significantly different value for degludec to glargine 300 during the titration period and also during the maintenance period. Why they have divided two phases is when we start somebody on insulin, the first 3 months are critical, the first 12 weeks of therapy. We have to escalate therapy quite rapidly, otherwise glucose levels don't come down that well. So the titration period is important, and then the maintenance period was given as the next 3 months. Glargine 300 and IDEG 100, you can see from baseline to the end of the study at 24 weeks, the HbA1c reductions were almost similar. So 8.7 to 7%, 8.6 to 7%. So this was again a intervention study, aggressively addressed, and high doses of basal insulin were given, and the patients were achieving their targets of glucose reduction. The BRIGHT study also showed that hypoglycemia at any time of the day, you can see during the titration period, during the first 3 months when the doses were escalated, it started at a standard dose of 10 units for degludec, and for glargine 300 it started around the 0.2 unit per kg body weight as a starting dose, and the dose was escalated on a weekly basis. You can see the confirmed hypoglycemias below 70 and below 54 were lower with glargine 300 for incidence and also the event rates for all the patients who were studied. And for the nocturnal hypoglycemia, you can see the event rates were lower with glargine 300. So favoring glargine 300 as regards to lesser risk of hypoglycemia when they were given glargine 300. And the titration period, if somebody gets hypoglycemia, the chance of increasing the risk of getting hypoglycemia is there, and chance of discontinuation is higher. That has been proven, and that is why this 12-week period can be critical when we are starting patients on drug which can reduce the risk of hypoglycemia, which can have an outcome over the long period of time. So we want our patients to take the medication we are giving to them. So again, the BRIGHT study in a theoretical representation is showing the lesser chances of hypoglycemia during the titration phase, and it can have a potential benefit for type 2 diabetes patients to reach their goals safely. Can it be used in renal impairment? There is plenty of evidence across the studies, all the studies we have just discussed now. You can use it across the EGFR spectrum, and you can safely reduce the glucose levels and lessen the risk of hypoglycemia, and it is of no concern. So it is approved to be used in renal impairment. How about elderly and high risk patients? So if you've got patients who are above 70 years of age, there was in fact in the BRIGHT study a better A1C reduction in the glargine 300 group compared to degludec 100 group, and they reached it much more safely with a lesser risk of hypoglycemia. Otherwise, the HbA1c reductions were similar when you see all the other drugs which are being compared to addition, ATOS, BRIGHT, and DELIVER study. So how do we compare? We have compared glargine 300 to glargine 100. We have compared glargine 300 to degludec. How do we compare it with premix insulins? We are so familiar with premix insulin, human mixed-start or other, I'm taking brand names, but just to be familiar with. So any premix insulin, there have been no head-to-head trials. So glargine 100 has been compared to premix, glargine 100 has been compared to glargine 300, but they are comparing glargine 300 to premix in a indirect treatment comparison model based on the statistical model. So they have taken the same studies, the addition studies, and they have taken the study which was mentioned in the previous talk, BOOST study, the Onishi et al. Study, and other premix insulin. So they are comparing glargine 300 to the standard premix insulins that we always use in our clinical practice to treat type 2 diabetes patients. And the key outcome is there was no difference between glargine 300 and premix insulin as regards to final HbA1c levels, final insulin dose, or weight gain. They were similar between once daily glargine 300 or premix insulin, which was most of the time given as a twice daily dose. Not only that, the chances of hypoglycemia, the incidence and event rates were lesser with glargine 300 compared to premix doses. So clearly highlighting the benefits of the long-acting, ultra-long-acting second generation basal insulin. Idagasp has also been compared against glargine 300. Again, it is an indirect comparison. There is a nice diagram to illustrate it. Glargine 100 has been compared to glargine 300. We've heard about those studies just now. Idagasp as a once daily dose has been compared to insulin glargine, and we heard about the trial data in the previous talk. So what this showed was between Idagasp and glargine 300, which was given as a once daily dose, there was no significant difference in HbA1c or final insulin dose, but the weight gain with glargine 300 was less compared to a co-formulation which included a mealtime insulin and a ultra-long-acting insulin. Again, the hypoglycemia risk better with glargine 300. You can see that on the forest plot compared to Idagasp. So the event rates weren't much different between both the arms, but the overall hypoglycemia incidence to 24 hours or at 24-hour glucose levels below 60, 70 milligram per deciliter were better with the glargine 300 compared to Idagasp. Moving on to CGM time in range data. With all this basal insulin, which is a flat acting insulin, and the sugar levels being stabilized, all these data are against either degludec or degludec-asp, and all these clinical trials, if we look at the data, more patients in glargine 300 spent more time in range, and lesser patients were their time below range. Not many patients were their time above range. So glycemic variability was lower in glargine 300 in these clinical trials and compared to the degludec. So these are all real world data, PKPD studies, RCT evidence, which was there in type 1 and type 2 diabetes population. So coming to flexibility, how do we give the injection? So let us say we want to start somebody on glargine 300. We just, based on an individual's weight, we multiply it by 0.2 units and give it as a once daily dose. And that once daily dose, with that flexibility of 6-hour window, where you can give it at 9 o'clock at night or 6 in the evening or 12 at midnight, without any relation to meal, has been taken from this data which was in type 1 diabetes population. So that has been extrapolated to type 2. If the glargine 300, which is in the green shade in this slide here, whether it was given in the morning or at night time, the glucose values were very, very stable. There was no peaks or troughs which were happening irrespective of the timing of the glargine 300 dose. Whereas with glargine 100, you can see peaks and troughs. So glargine 100, usually you don't have that label of using it as a flexible dosing in a 24-hour period. So you can have that +2, -3 hours. It can be beneficial. At times it can be a bit detrimental as well if the patients are experimenting with changing their dose frequency quite often. So this is the device where glargine 300 is given, 2GO pen, and the device itself, they've hidden it. It is manufactured in India. It is manufactured in Hyderabad. The design may have come from the main company, but the fact is, it has got a dedicated cartridge holder and a pen, and it is very accessible, easy to use at 300 units per mil, and each pen has got around 450 units of insulin in it. So if somebody is using 15 units of insulin per day, they will easily carry they can complete the cartridge within a matter of 1 month. So full month supply will be there by using the use and throw cartridge device. So in summary, I think I've covered the subject of basal insulin and the competition which is there between various basal insulins. If the competition is there, obviously it will be a good thing. We are all familiar with glargine and we use it. And glargine 300 is nothing but glargine, but with a better PKPD profile and effective and a glycemic control agent. And that is the insulin that I've discussed today. Thank you.
Thank you, Jaydev sir, for your brief note on this basal insulins. I would like to invite questions from the audience on this topic. Can you tell me something about weekly insulins in the pipeline which are in near future?
Yeah, I think what we are trying to see is improving the insulin therapies which are there. So we have got insulins which lasted 4 hours, 8 hours with the meal-acting insulin. Then you've got the 12 hours and the 24 hours, 36, 42 hours. There is plenty of data in the last 2 years that you can give one insulin once a week with the same doses that we are talking about, multiplied by 7 days. And if you give that insulin as a basal insulin once a week, along with the oral agents, this has been in type 2 diabetes population. The glucose control is as good as any of the basal insulins which are going around. And the hypoglycemia risk is no different compared to the basal insulins. That is the icodec insulin which is being asked. I think if I got the question right, is that the right one? Yeah. So the duration of action of insulin, just the way the technology is going about the manufacturing, you are going to get a basal insulin given once a week, hopefully in the near future in our country, and it is available in Europe as things stand.
One of the most common queries which we receive is like what to do with the sulfonylurea dose or the drug as such when you start insulin.
Again, a very important practical question, what to do with sulfonylurea when we start insulin. If you are going to start basal insulin, I think it will be a good idea just to stick with the sulfonylurea to cover the mealtime period. So do not discontinue the sulfonylurea. But if the basal insulin requirements are going up and you are giving either a basal plus or a basal bolus therapy or a premix or a co-formulation, then the idea is to discontinue sulfonylurea. So don't use it with a mealtime insulin. Having said that, there are clinical trials from Scandinavian countries where they were using premix insulins along with sulfonylurea, and they found the glucose levels being much more stable and the insulin requirements being lower, but with the problem that the hypoglycemia risk was higher. In our country, it brings us to a slightly difficult scenario because sometimes patients don't take insulin all the time for the full month. They may be taking it for 3 to 4 days and they may discontinue it. And if at that stage there was a drug which is as effective as a sulfonylurea in the background, it may still be a good thing for the patient so that their glucose levels may not be high. And there have been instances where I have used sulfonylurea along with insulin more than the basal, especially when there is a consideration the patient may not be compliant with the medication.
So if there are no more questions, we'll conclude the session. Thank you.
Thank you. Thank you.
Moving on to the last session of the evening. The first topic is optimizing the outcome in pediatric growth hormone deficiency patients with treatment option by Dr. Ram Mohan. I invite Dr. Monica Anita, Assistant Professor, Andhra Medical College, Visakhapatnam, and Dr. Kalyani, Associate Professor, NRA Medical College, Mangalgiri, to chair the session.
I invite Dr. M.V. Ramamohan to speak on optimizing the outcome in pediatric growth hormone deficiency patients with new treatment options. He has graduated from Andhra Medical College and he is a consultant endocrinologist in Diabetes and Endocrine Clinic, Nellore, and in Apollo Specialty Hospitals and Vijaya Specialty Hospitals, Nellore. Over to you, sir.
Thank you, Monica. Thank you, Endocrine Society of AP, for this opportunity, and I would like to congratulate Dr. Lavanya for wonderful organizing this conference, ESAP 2023. And today's my topic is optimizing the outcomes in pediatric patients with new treatment options, mainly the growth hormone deficiency patients in pediatric age group. We have a short-acting everyday growth hormone genotropin is there. Now we are coming up with long-acting once-a-weekly growth hormone, which is going to be released in next 1 to 2 weeks duration. And we know that mainly there is the chances of or compliance are the main issues in growth hormone deficiency, and low adherence to injections affects the treatment outcomes. In this study, you can see that 66% of children who missed more than one dose of growth hormone per week had significantly reduced height velocity. That means that many children tend to miss growth hormone every day, and this can be overcome with once a weekly injection. So improving the treatment adherence is the key for better outcomes. That means that compliance and adherence are very, very important in any treatment options, and clinicians have concern about daily treatment regimens, and we are going with compared to daily treatment regimens, once weekly regimens are more, patients have more adherence to them, and patient and caregiver choice also affects adherence. If you compare the daily treatments with weekly treatments, the weekly treatments have a better adherence, and patient caregiver choice is also more for that. And success of long-acting preparations has been demonstrated in many disease studies. For example, we have hemophilia treatment, type 2 diabetes treatment, having once a weekly GLP-1 agonists and long-acting regimens. These long-acting regimens have been shown to be more patient-friendly and more family-friendly compared to short-acting regimens. So what are the potential benefits of long-acting growth hormone preparations? So daily decrease the injection frequency is very, very important one for kids. They are very afraid of daily injections. So this once a weekly injection is more adaptable and more acceptable by all the kids. Potential to minimize efficacy, maximize the efficacy, potential to improve adherence and increase the flexibility. These are the common points which are positive for these injections. So this is a once weekly somatrogon. Utilizes CTP technology to extend its half-life. That means that there is a fusion of salicylated and glycosylated CTP, that is carboxy terminal peptide, which is going to increase the half-life of this drug under subcutaneous area. The half-life is compared to recombinant growth hormone, which is 2 to 3 hours. This half-life is around 28 hours. So coming to the somatrogon efficacy and safety, once weekly somatrogon is supported by 5 years efficacy and safety data in pediatric growth hormone deficiency. We have phase 2, phase 3 and different phase 3 trials and 2 trials which have shown to be good beneficial effects, which is a good number of patient population. So somatrogon phase 2 dose ranging efficacy and safety study with OLE in children with growth hormone deficiency. This is comparing with somatrogon with somatotropin once a daily. You can see that so primary efficacy endpoint of annual height velocity is the primary efficacy endpoint, and once weekly somatrogon demonstrated a 5 to 10-fold longer half-life compared to daily growth hormone, and also steady state was reached after 7 to 10 weeks, and the Tmax and compared to somatropin, the somatrogon has a very good efficacy, and you can see that adverse outcomes were also very less compared to somatropin, and once weekly somatrogon normalizes IGF standard deviation levels over time. That means that compared to our daily dose, once a weekly injection is shown to be non-inferior, and it has shown to be very, very efficacious in our patients. So patients on somatrogon continue to achieve height gains and improvements in height standard deviations. So you can see that after 5 years of data, there was very good improvements in the height standard deviations. So safety summary, there were no adverse side effects and no patients withdrawals. Safety and tolerability of somatrogon were similar to the main study, and there is improvement in the standard deviations were very good, and annual incidence of injection site reactions were very less. So coming to the immunogenicity, that is called anti-drug antibody development was very less compared to somatropin, and no adverse events were found. So summary of the phase 2 study, the daily dose was given as 0.66 milligram per kg per week, and observed mean standard deviations values increased, and height velocity is comparable with somatropin. Safety profile was similar to somatotropin, and there were overall treated with the long acting, there were a good improvement in clinical parameters of growth, height, velocity, changes in the height standard deviations. So based on 1 year of somatrogon, 0.66 mg per kg per week has chosen as a dose comparable to 36 micrograms per kg per day somatotropin in phase 3 study. That means that the dose which is commonly given in longer half-life injection is 0.66 milligrams per kg per week. So, somatrogon global phase 3 study, we have 83 clinical sites including 21 countries with global studies were done, and in a non-inferior study with somatropin, it has been shown that you can see that treatment difference in height velocity 12 months. So, somatrogon favors height velocity after 12 months, and it was non-inferior to daily dose. And the age, sex, peak growth hormone subgroups showed similar height velocity response to somatrogon compared to daily injections. And patients achieved similar changes in the height standard deviation to daily growth hormone with once weekly somatrogon. That means that the patients, the standard deviations were very similar to daily doses, and similar bone maturation was also found in the two groups. So mean IGF value normalized at 1 month of somatrogon treatment, and it took 1 month to normalize the mean, and that means 4 half days were taken, and safety profiles of somatrogon and daily growth hormone were similar in the two groups, and the adverse events were very less. So presence of anti-drug antibodies in patients taking somatrogon did not impact the efficacy and safety outcomes. And summary of height velocity at month 12 by ADA status, you can see that in both groups it was equal. So global phase 3 study summary, it says that somatrogon and somatotropin resulted in similar height velocities, and it is non-inferior to daily insulin, and long-acting insulin can be adopted. It is already approved in US FDA and in US, and now it is coming to India. So this is a somatrogon OLE open label extension phase 3 non-inferiority study compared to somatropin, and one more open label study. Here you can see that the height velocity, height standard deviations were equal, and if you cross over also, you can see improved, these patients and caregiver reported a improved interference scores. That means that in an open label study, the patients accepted once weekly injection more compared to daily injection. And you can see the treatment experience favored by patients and caregivers. The favoring somatrogon points were much higher compared to daily injection. And so 9 of 10 days treated with once weekly somatrogon missed 0 injections. That means that most of the patients accepted this injection, and the missing their drug was very less, and all cause adverse events were less. And summary of treatment burden study, you can see that 12 weeks of somatrogon treatment results in a significantly improved mean overall life interference total score, and the acceptability was very good. So coming to the overall summary, we know that growth hormone deficiency is most common pituitary hormone deficiency in children. The major clinical features of short stature and poor growth velocity. Accurate and timely diagnosis is the most important in management. Adherence to daily growth hormone therapy is suboptimal. Long-acting preparation of growth hormone have potential to improve the adherence and clinical outcomes. Somatrogon is a new molecular entity which has high half-life of around 1 week duration, 30 hours of duration, working for 1 week, weekly once it can be given. And phase 2 and phase 3 trials have shown similar height velocity achieved once weekly somatrogon with once daily somatropin. So that means that it can be adopted in place of once daily injection, and the reports and the trials for outcome trials were very good, and there were less injection site reactions, and there were no adverse events in this group. So thank you so much. And we welcome this new drug that is under the name of Genrizon or somatrogon injection, which comes as a single syringe of 20 milligrams, 24 milligrams per vial, which can be adjusted by 0.2 milligrams doses, and 12 milligrams can be given as a single dose. So dose commonly given is 0.66 milligrams per kg per week. So thank you.
It is a very clear and detailed presentation, sir. Now we can take 1 or 2 questions.
So the most important factor in growth hormone deficiency is about the cost of the drug. And nowadays, mainly you are coming up, this genotropin is coming up with around maybe 14,000 rupees per injection. 9,600. So good.
Sir, is it a fixed dose therapy?
No, it can be adjusted.
You said 0.66 mg per kg per week.
In the trials they have used that dose.
Can titrate it up to maximum dose?
No, the trials have shown better efficacy with the dose it has shown. Yeah.
0.24 mg, 0.66.
Okay. The best efficacy was found with 0.66.
The maximum dose is 0.66 mg per kg per week. The minor side effects are similar to regular.
Yes, injection site reactions were the common thing.
We can close the session.
Thank you.
The next topic is adrenal insufficiency challenges in management by Dr. Geeta Priyadarshini. I invite Dr. Raviteja KV, Consultant Endocrinologist, Visakhapatnam, Dr. Venu Madhavi, Consultant Endocrinologist, Visakhapatnam, to chair the session.
Dr. Geeta Priyadarshini completed her MBBS from Ashram Medical College and MD General Medicine and Endocrinology from Andhra Medical College. She is a consultant endocrinologist at Ramesh Hospitals and Geeta Endocrine Super Speciality Clinic. So, Madam would enlighten us on adrenal insufficiency, challenges in the management of adrenal insufficiency. Over to you, ma'am.
A very good evening, one and all. Thank you for the introduction. And first of all, I would like to thank Endocrine Society of AP and particularly Dr. Lavanya for giving me this opportunity. So my topic today is challenges in the management of adrenal insufficiency. Normally, when the clinical picture is very evident and the investigations are clear-cut, adrenal insufficiency is very easy to manage. We can diagnose easily if the diagnostic values are clear-cut, and the management is replacement of glucocorticoids and mineralocorticoids. So what are the challenges we face in the management of adrenal insufficiency? First, I will deal with diagnosis, then with treatment aspects. Normally, we evaluate the adrenal function with these lists of tests. Random serum cortisol, it is done mostly in patients who are critically ill. And early morning serum cortisol, when coupled with ACTH, it can be used to diagnose primary adrenal insufficiency. And the cosentropin stimulation test is considered as a gold standard test to diagnose adrenal insufficiency. Metyrapone test and insulin tolerance test are the tests to evaluate the entire HPA axis. So, what are the challenges with these tests? As I said, the cosentropin stimulation test is the gold standard test for evaluation of for the diagnosis of adrenal insufficiency. So, from the previous guidelines, we have so many questions. So, what is the most appropriate route to administer this cosentropin, IM or IV? What is the most appropriate dose, whether it is low dose, 1 microgram or 250 microgram, and what time should be the sampling done, at 30 minutes after cosentropin or 60 minutes after cosentropin. So first, coming to the route of administration, IM is the most convenient approach to give in OP patients, and according to the literature, there is no significant difference has been observed between the two routes. And coming to the dosage, 250 micrograms vial is commercially easily available, and for 1 micrograms we have to prepare the solution on serial dilutions, and the storage is also difficult, and 1 microgram has less sensitivity. It results in high false positive rates. So 250 micrograms should be considered in cosentropin stimulation test. And coming to the sampling, I'll discuss in the next slide. So with this 250 micrograms cosentropin stimulation test, what is considered as normal response? With established immunoassays, If the cortisol after cosyntropin is more than 18 to 20 micrograms per deciliter, then it is considered normal. With other second generation immunoassays and assays like liquid chromatography and mass spectrography, the cutoffs can be a little lower, around 12.5 to 17.5 micrograms per deciliter. So these cutoffs are obtained based on the data combining both 1 micrograms and 250 micrograms cosyntropin stimulation test. The patients are both inpatients and ambulatory patients, and included patients who are on glucocorticoids and who are exposed to opioids. And there is a lack of clear distinction between 30 and 60 minutes cortisol values during the cosyntropin stimulation test. So to avoid these confounding factors, recently there is one study published by Hasni et al. They have taken 305 patients, and among them 242 were excluded. Excluded patients were inpatients who are on glucocorticoids, who are exposed to opioids, who are on estrogens. So these are the various exclusion criteria. And finally, 63 patients were finally found to have the normal HPA axis, and they were included in the final analysis for cosyntropin stimulation test with 250 micrograms. So this, according to this graph, at 0 minutes, that is a basal cortisol, the lowest value is around 3 micrograms per deciliter. And at 30 minutes, the lowest value, you can see it is around 15 micrograms per deciliter. And at 60 minutes, the lowest value is around 17 micrograms per deciliter. So the bottom line from this graph is, if the cortisol at 30 minutes after cosyntropin stimulation test is more than 14.5 to 15, it can be considered as a normal response. And if it is more than 17 to 18 at 60 minutes, it is considered as a normal response. So according to this study and from other similar related studies, so when there is clinical suspicion of adrenal insufficiency, we measure basal serum cortisol. If it is more than 10, AI is ruled out. If it is less than 3, it is a definite case of adrenal insufficiency. If it is between 3 to 10, we go for cosyntropin stimulation test. If the value is more than 15 micrograms at 30 minutes and more than 18 micrograms at 60 minutes, AI is ruled out. If it is less than 15 at 30 minutes, less than 18 at 60 minutes, AI is confirmed. Then we go for evaluation of etiology, whether it is primary or secondary adrenal insufficiency. So these are the diagnostic challenges. And coming to the management, as I already told, management is a replacement of the deficient steroids, glucocorticoids, mineralocorticoids. And androgens are particularly in women who complain of, premenopausal women who complain of lack of energy, mood swings like depression and anxiety, so in these patients, DHEA can be given once daily for a 6 months period. If there is no clinical improvement, then these androgen supplementation can be stopped. So coming to the challenges in management, I will go in the case presentation format. So coming to the first patient, a 55-year-old man was brought to the emergency room in respiratory distress. He was hemodynamically unstable, altered mental status with a high-grade fever of 40 degrees centigrade. He was admitted to the ICU because of septic shock due to community-acquired pneumonia. He was intubated and he had persistently low blood pressure despite adequate fluid resuscitation, and he is requiring high-dose vasopressor therapy. So the questions here are IV steroids indicated in this case? Yes or no? So the answer is definitely yes. And can this case be called SERSI? Can this condition be called SERSI? According to the previous guidelines, yes, it can be, we call it as a SERSI, but according to the recent literature and guidelines, it is not a SERSI, it is simply a refractory shock, a case of refractory shock. So SERSI is a concept that was first introduced in 2008 by an international multidisciplinary task force convened by the Society of Critical Care Medicine to describe impairment of the HPA axis during critical illness. SERSI is characterized by dysregulated systemic inflammation resulting from inadequate intracellular glucocorticoid-mediated anti-inflammatory activity for the severity of patient's illness. So this is defined as SERSI according to the previous guidelines. And according to the updated consensus statement of Society of Critical Care Medicine in 2017, if the random cortisol in this type of patients is less than 10, it is diagnostic of SIRC. If it is more than 35, we can rule out SIRC. If these, the values are intermediate, then we go for cosintropin stimulation test and we see the delta cortisol. If it is less than 9 microgram per deciliter, then it is diagnostic of SIRC. But these are not, SIRC, the definition and these diagnostic criteria has changed. Simply, these type of patients, this condition is called a refractory shock. It is not a SIRC because the low increment in plasma total cortisol in these conditions, it is likely the result of a substantial increase in cortisol distribution volume, which is due to low CBG levels in critical illness. So free cortisol will be in the higher levels. So there is this, adrenal glucocorticoid production will also be higher in cases of severe stress. So there is a substantial increase in cortisol distribution volume, and this low increment cannot be explained by rather than already maximally stimulated adrenal cortex that is unable to produce more glucocorticoids. So this low increment in total cortisol in response to ACTH is thus merely indicative of high severity of the illness rather than the poorly responsive adrenal cortex to the synactin. So what is SIRC then? SIRC is described in patients with prolonged critical illness of around 3 to 4 weeks duration. In these patients, due to the prolonged hypercortisolemia and elevated circulating bile acids and bilirubin, all these parameters has an effect on pituitary at the level of hypothalamus pituitary level. They exert a negative feedback inhibition at the hypothalamus pituitary level, resulting in loss of ACTH mediated stimulation of the adrenal cortex. And we use several drugs during the critical illness like opioids, phenytoin if the patient has seizures, rifampicin. So all these drugs may aggravate the SIRC phenotype also. So this condition is called as SIRC in patients with prolonged critical illness. And the possible symptoms and signs of SIRC are encephalopathy, delirium, fatigue, continued and unexplained need of vasopressor therapy, electrolyte disturbances like hyponatremia and hypercalcemia, new onset eosinophilia. So the critically ill patients can be divided into 3 categories. Those who have a pre-existing intrinsic HPA axis disease acutely triggered by stress event and newly diagnosed adrenal insufficiency. And the second category is acute shock, now not responding to IV fluids and vasopressors, as this case, it is called as refractory shock. In these cases, cosintropin stimulation test is not advised. We can directly start hydrocortisone. If there is a response, we can continue the steroids for 5 to 7 days. If there is no response, we can stop the steroids. And prolonged critically ill patient requiring mechanical or pharmacological vital organ support for several weeks with symptoms and signs compatible with adrenal insufficiency, these patients can be considered, can be put in under the category of SIRC. And clinical evaluation, the symptoms will be non-specific, and there are currently no established or validated diagnostic tests. Although absence of an increase in plasma ACTH and cortisol is suggestive of SIRC in these type of patients. And in these patients, we can consider hydrocortisone 60 mg IV over 24 hours, 40 mg given in the morning and 20 mg in the evening. And as soon as the patient, there is clinical improvement, we can taper the dose. Coming to the second case, 42-year-old female diagnosed with primary adrenal insufficiency 2 years back was referred to the Department of Endocrinology for the persistence of tiredness, weakness, giddiness, and progressive weight loss. At diagnosis, cortisol is low, ACTH is high, 365, chest X-ray, CT, and thyroid function tests were normal. Hence diagnosed as primary adrenal insufficiency, and she was started on treatment. She was apparently normal for 1.5 years. But for the past 6 months, she was admitted twice to the hospital with features suggestive of adrenal crisis requiring IV hydrocortisone and IV fluids for improvement. And during both these episodes of crisis, she had no other precipitating factors such as fever, diarrhea, or any infection, Compliance to medication is very good, and she is not on any other medications. So due to the recurrent episodes of crisis, the dose of prednisolone was increased to 10 mg in the morning and 5 mg in the evening. Even then, she continued to have persistence of symptoms with progressive weight loss, for which she was referred for further evaluation. So this patient, diagnosed case of primary adrenal insufficiency on adequate dose of steroids with good compliance. With even increased dose of steroids, she has symptoms of adrenal insufficiency. So on examination at the present evaluation, she is thin built, hyperpigmentation, hyperpigmentation is present, no vitiligo, grade 1 goiter, her blood pressure is lower side, pulse rate is 120. Investigations showed a random serum cortisol of 0.7 and plasma SDH of 560. So what can be the diagnosis and what should be done in this patient? So one clinical clue is there, the patient has grade 1 goiter, so the thyroid function test was done, suggesting thyrotoxicosis, suppressed TSH and elevated T4. So this is a case of new onset Graves' thyrotoxicosis in primary adrenal insufficiency, presenting as recurrent adrenal crisis. So at the time of diagnosis, thyroid function tests were done in this patient, which were normal, but this is a case of autoimmune adrenal insufficiency. So we have to screen annually for other autoimmune endocrine disorders in patients with primary adrenal insufficiency to prevent this type of incidents. Coming to the case 3, this is a case of 27-year-old female with classic 21-hydroxylase deficiency at birth. She has been adherent to therapy her entire life till date. She had vaginal reconstruction at 19 years and has been using dilators periodically since then. Currently on hydrocortisone 10, 5, 5 and flutacortisone 0.1 mg with breakfast. She had regular menstrual cycles and urine testing documented monthly ovulation. On physical examination, she is not Cushingoid, mild facial hair is present. She is married and wants to have children, but not conceived. She has regular menstrual cycles, she is compliant to medication, urine testing documents monthly ovulation, but she wants children and not conceived. So what is the key laboratory parameter to monitor when adjusting her glucocorticoid therapy? Whether it is 17-OHP, testosterone, follicular phase progesterone or gonadotropins. We'll see the answer. So CAH is a most challenging condition to manage in all types of adrenal insufficiency. Treatment involves balancing glucocorticoid and mineralocorticoid doses to effectively address both adrenal insufficiency and androgen excess. So we need a balance between these two conditions. We have to prevent development of symptoms of hypercortisolism, and we have to suppress the androgens. So the key parameters we monitor during follow-up are serum 17-hydroxyprogesterone and androstenedione. These are the traditional indicators of adequacy of glucocorticoid treatment in CAH. But complete suppression of serum 17-OHP is not a treatment goal. It indicates the over-treatment. And androstenedione level should be referenced to age and sex-specific norms. And for women who experience a delay in conception, normally to document ovulation, we do luteal phase progesterone on 21st day. If they are more than 10, then ovulation, we confirm that ovulation has occurred. But in these patients, to document ovulation, we do follicular phase progesterone. It should be maintained less than 0.6 nanogram per deciliter. So this is the last line. In follicular phase progesterone should be done. The goal is less than 0.6 nanogram per deciliter. If it is more, if the follicular phase progesterone is more, it indicates the progesterone is mainly from the adrenal origin. Then there is a need for night dose of extra steroid. Coming to the case 4, 33-year-old woman is referred for evaluation of fatigue. She has a history of PCOS. Menses became regular after starting on birth control pills. Other medications include metformin. Her primary care physician referred her for evaluation of any underlying endocrine disorder explaining her fatigue. She has chronic back pain and has received glucocorticoid injections. She does not look Cushingoid. And on evaluation, basal cortisol is 7. At 30 minutes, it is 16.4, and at 60 minutes, it is 19.5. How to interpret this results in this patient? Does this patient has a normal adrenal function? So she is on some glucocorticoid injections. She has received glucocorticoid injections for chronic back pain. She does not look Cushingoid. She has symptoms of chronic fatigue, and she is on OC pills. The values are like this. So if the values are lower, then we can say that the patient developed endogenous adrenal insufficiency due to exogenous glucocorticoids. But the values here are normal, but the patient is on OC pills. Increased CBG levels may take a part in getting these values. So how to evaluate in such cases? So here we can see from this graph that a cutoff free cortisol of less than 0.9 microgram per deciliter in liquid chromatography mass spectrometry assay predicts total cortisol of less than 18 with excellent sensitivity and specificity. Sensitivity is around 100%, specificity is around 90%. So if we measure free cortisol in those type of patients, if it is less than 0.9, it correlates well with total cortisol of less than 18, so we can label them as adrenal insufficient. Coming to the case 5, a 65-year-old admitted with high-grade fever for almost 1 week duration. There is a history of usage of over-the-counter medications for arthralgias. He is not a known diabetic or hypertensive. On examination, he is Cushingoid with purple striae over abdomen. He has moon phases and he is obese. There is a left gluteal bed sore with abscess. Pulse rate is 82, BP is low, GRBS is 109 milligram per deciliter. So the patient is in sepsis with left gluteal abscess, and there are features of Cushing's syndrome. The patient is on over-the-counter medications for arthralgias. The first thing that comes to our mind is exogenous Cushing's with endogenous adrenal insufficiency, and the patient is in adrenal crisis. So the practical guidelines for assessment of HPA axis in patients taking glucocorticoids: any glucocorticoid less than 4 weeks, the adrenal insufficiency is not likely, and no additional glucocorticoid is needed if the patient takes morning prednisolone less than 5 mg per day or equivalent. Patients on more than 20 milligrams of prednisolone for more than a month is assumed to have adrenal insufficiency. If the patient is on prednisolone 5 to 20 milligrams per day for more than 4 weeks, we have to evaluate the HPA axis. So back to the case, it is a diagnostic and management dilemma. The random serum cortisol was sent. It is around 16.8 microgram per deciliter. Review of his past medications did not show any evidence of usage of steroids. Now, what can be the possible diagnosis? This is a question. I got the case. I didn't get a. I don't know how to manage this type of patient. I thought of exogenous Cushing's with endogenous adrenal insufficiency, but the random cortisol came as 16.8 microgram per deciliter, and there is no past medications history of any steroid usage. So it can be endogenous Cushing's with sepsis. And whether steroids are indicated in this case. There are no questions from the audience side, so I am asking the question. I don't know how to manage this patient, sir. Patient is admitted with 65-year-old, gluteal abscess, sepsis. He is on some medications for arthralgias. First, I thought as exogenous Cushing's with endogenous AI and crisis, but the cortisol came around 16.8, ruling out adrenal insufficiency.
Usually when we take synthetic steroids, you can't measure it, but sometimes synthetic steroids are showing up in the serum cortisol measurements. Rarely patients may be using directly hydrocortisone kind of preparation. So still the chances are he is probably on exogenous steroids.
But
This patient-
cortisol is 16.8, sir. Random.
You can still detect cortisol in some of the preparations.
Okay.
Some of the preparations are almost the same, that they are measuring is the same. So if somebody is on hydrocortisone, you can still measure cortisol and it will be normal.
And whether steroids are indicated in this patient now to, okay.
That may be a case of previous exogenous Cushing's with a recovered HPA axis now having a normal sepsis reaction.
Madam, if the patient is in crisis now, at presentation,
Yes.
then the random serum cortisol of less than 33 is considered as deficiency.
But according to newer criteria,
Madam, I had an exactly similar patient like yours with a history of exogenous steroid intake with sepsis with a cortisol of around 40 microgram per deciliter. So I was very doubtful whether it is actually endogenous compounded with exogenous. So here all possibilities we can have, like exogenous Cushing's with recovered HPA axis with well functioning adrenals. So this could be just a reaction to sepsis. And the other thing is endogenous Cushing's. There are two possibilities, ACTH dependent and ACTH independent. What I would do is, at least to rule out endogenous ACTH independent Cushing's, I will do an ACTH. If ACTH is detectable, at least it will rule out endogenous ACTH independent, ACTH is normal, then it will rule out adrenal Cushing. So we are left with two options, like ACTH dependent Cushing's, or it is just exogenous Cushing's with recovered HPA axis. And from then on, it's very difficult. I had done 24-hour urine-free cortisol and all to just see whether it is in the normal range or not. If they are really very high, then I'm not sure it is Cushing's. It could be even stress response. But for that patient, given the benefit of doubt, I had put that patient on etomidate. I don't recommend on this patient because that patient had very turbulent sepsis. He was not responding to antibiotics, antifungals with cortisol of 42 with history of exogenous Cushing's, where I cannot rule out endogenous Cushing, and managing that hypercortisolemia is very important to control the sepsis. I had put that patient on etomidate, but this patient, I'm not sure.
This patient died on third day, so
okay.
I have a doubt whether to start steroids in this type of patients. With this, I conclude. Thank you.
Thank you, ma'am, for such a lucid presentation. Definitely, adrenals is one of the most interesting topic of endocrinology, and you made it more interesting with very interesting case scenarios. So I hope many of the doubts have been already clarified with these challenges, especially in diagnosis and treatment. And so just I would like, before opening the house for discussion, I would like to just stress another point, because this cosentropin is easily available nowadays. So what precautions and in which situations there will be falsely stimulable or falsely non-stimulable? Can you just elaborate? Already in one case you have discussed about the OC pills.
I didn't get it.
So when we use cosentropin stimulation test, so there will be some situations where we can get falsely stimulation. I mean, we may get, just you told OC pills, one case scenario have been discussed. Like that, you have, just to make this point more highlight, you can discuss any another situations where we can see that false interpretations of these results of this stimulation. False positives or any false negatives.
With low dose cosentropin, false positives are possible, and with altered CBG levels, false positives. And any drug, enzyme inhibiting drugs like ketoconazole and all?
Yes.
No.
Usually most common another situation which we see is post-pituitary surgery patients. There will be stimulated, but definitely there will be need of this supplementation. That is another scenario. And even they say like in fatigue syndrome or chronic fatigue or fibromyalgia, it will be falsely low, and where we don't need to supplement. That is because nowadays we are using more this synactin. So we should be knowing these special scenarios. And another thing about the last case, it was really very interesting, and many house also participated well. So maybe to decide whether to give the steroids or not, maybe what I thought is in very special scenarios, because it was a random serum cortisol, if you want to take a call, because this steroid, if you give the steroids, definitely there was not much mortality benefit. It would only help in the weaning of this vasopressors early. That's what many of the studies have shown. And a very big study where the mortality was high, in that study only it was shown little mortality benefit. So whatever it is, we have to take a decision whether to give or not. There are many possibilities, like recovering of HbA1c also is one of the consideration. Maybe as Dr. Harsha suggested, I would like to do ACTH also. But on top of that, we can even consider doing synaptin stimulation test, whether there is a rise, if it is a delta change, which is more than 9 also, we can be assured that the patient is having good adrenal function. And even in ACTH might be low, or it can be even higher side also, because it is a recovery of adrenal axis. That's what I feel from my side. And now the discussion is open for the house.
Ma'am, actually, low cortisol itself will cause an increase in TSH levels. Right, ma'am? Low cortisol will cause an increase in TSH levels. So, when associated with autoimmunity, we can also consider subclinical hypothyroidism or hypothyroidism associated. So, when do we consider it as a reflex increase in TSH, and when do you consider it as subclinical hypothyroidism?
If we are in doubt whether it is due to low cortisol or the patient has inherent subclinical hypothyroidism, better go for measuring autoantibodies and confirm.
There was a paper suggesting in BMJ almost 15 years back, if you treat subclinical hypothyroidism and the patient comes back and says, I'm fatigued, I'm not well, measure cortisol is the clue which was given in that series of cases. So the clue may be if they are feeling unwell with thyroxine, usually patients still complain on thyroxine, but obviously there will be other clues to adrenal insufficiency. So antibodies potentially can help there as well, but feeling unwell with thyroxine should give a clue towards adrenal insufficiency. The reverse case anukunta, the hyperthyroidism, there was a precipitating adrenal crisis.
If there are, just I have one more last query, ma'am. We were just discussed about the DHEA supplementation. Because we are in the era of precision medicine, we have to just cover all the, because quality of life is also important. And if you really want to give DHEA for consider to some patient, especially we give for female only, obviously, because adrenal androgens are the more than they are more important for females for sexual well-being also. So what dose you will be giving and what precautions you will take, because it is a steroid, we cannot just give like that. It is actually a controversial topic also. What is your take on that?
Actually, they are indicated only in premenopausal women who are typical of who are with typical symptoms of low libido, decreased energy, alternative mood swings. They are advocated, and it is given around a dose of 25 to 50 mg per day, single dose at the morning, and it is a trial for 6 months. If there are no improvement in symptoms, we can stop the drug.
Yes, ma'am. True. But we definitely have to take care of this, seeing any cardiovascular risk factors, cholesterolemia, dyslipidemia and all also have to be taken care, because we don't know how the steroids have long-term effects. But as you suggested, 25 or 50 mg, that will be considered, and when there is no improvement in the well-being, we can stop it. So we can close the discussion now. Thank you.
Let's move on to the last topic of the evening.
I am privileged to introduce the next speaker, Dr. G. Sri Harsha sir, who has done his MBBS and MD from Andhra Medical College and did his DM from Sanjay Gandhi Institute of Postgraduate, Sanjay Gandhi Postgraduate Institute of Medical Sciences. He has won a gold medal in pharmacology in his second year of MBBS, gold medal in MD, and he was a best outgoing student. He has presented papers in state and national conferences and presented posters in Endocrine Society India Conference 2019. Currently, he is practicing at Hormone India Endocrine and Diabetes Center, Vishakhapatnam. Over to you, sir.
Yeah. Thank you, team ESAP, for giving me this opportunity, and I would like to request you to bear me for 10 or 15 more minutes, because I know this is end of the session and it is very tiring for all of you. So the topic here I am to talk about is NAFLD and diabetes. I feel somehow that this NAFLD escapes the radar. It's mainly the fault of the unnecessary ultrasounds that are being done, where the only finding that is reported is fatty liver. We are so used to seeing this fatty liver report in the ultrasound reports that we take it too casually. We know that the problems of NAFLD and its dangerous interaction with diabetes, but somehow we take it too casually. And when I ask my gastro friends what drugs are approved, they say no drug is approved for NAFLD because there is no evidence, long-term evidence for any drug to be used for NAFLD. Hence, I take this opportunity to present the overview. We should know the definition, basic definition, I mean, the prevalence, the interaction deadly combo of diabetes and NAFLD, risk stratification. This is very important because we need not order expensive tests like fibroscan in our routine clinic. We can just get away with basic liver function tests and risk stratify the patient, and if we feel we should refer the patient to a hepatologist or a gastroenterologist, only then we should refer them. This is followed by management and more emphasis on what diet and how much of weight loss and what medicines are actually approved for NAFLD in diabetes patients. So the worldwide prevalence studies can put it at any range depending upon what set of patients they include and what set of diagnostic measures they have taken. But many famous studies like the Dallas Heart Study, which included patients between 18 to 65 years of age, had put the prevalence of NAFLD at around 30%. It is again the most commonest cause of, and in the future it's going to be the commonest cause of cryptogenic cirrhosis. And it's again the most prevalent cause of HCC without underlying viral infection. So this study done from India by Dr. Sanjay Kalra, sir, has put that incidence of NAFLD, which includes all the spectrum of NAFLD steatosis, NASH and fibrosis at 56% in between the age group of 25 to 84 years at 50%. So this is again just like the studies elsewhere, large studies elsewhere, that put the incidence and prevalence of NAFLD of around 40 to 60% in patients with diabetes. So NAFLD is defined as, it's a macrovesicular steatosis. That's the basic first stage. This is followed by hepatitis, where there is inflammation, followed by cirrhosis, which is the last stage. So again, this should happen in the absence of significant alcohol intake, and out of the spectrum, NASH accounts for 50% of the total burden of NAFLD. Stages of fibrosis, from stage 0 to stage 3 of increasing severity, and see, up to 10 to 20% of type 2 diabetes patients already have severe, significant fibrosis of stage 2 and stage 3. So we know that we cannot separate these two disease entities because liver is one of the metabolically active organ. It's very important when it comes to glucose metabolism, and diabetes promotes the progression of NAFLD. and NAFLD promotes insulin resistance. So both of them have an interaction where both of them accentuate the progression of each other. So NAFLD predicts diabetes. It is as common as metabolic syndrome. And if you see the associated factors with type 2 diabetes, abdominal obesity, higher BMI, acanthosis and all, out of all of them, NAFLD stand out very prominent that it has the strongest association of all things among the metabolic syndrome. And not only that, people with diabetes and underlying NAFLD has higher chances of having macrovascular complications. So the association between NAFLD and macrovascular complications in diabetics is very strong. However, the same cannot be said about microvascular complications. The association is much weaker between NAFLD and microvascular complications in diabetes. Again, we see the interaction between the fatty liver and its progression to cirrhosis, and how this fatty liver causes increased insulin resistance, and how hyperinsulinemia in some way it promotes the liberation of more pro-inflammatory cytokines, along with that pro-coagulant factors which increase macrovascular complications. And again, insulin resistance at the liver, it results in more cytokines which again accentuate the progression of NAFLD. So diabetes does more harm to NAFLD than NAFLD does to diabetes. So what can we do as an endocrinologist or physicians when we see diabetic patients? We should be cautious that at least 50% of them, whether they are lean or obese, could be having NAFLD. And because we see a huge chunk of patients, huge fraction of our patients in our clinics will be diabetics, and at least 50% or 40-60% might be having NAFLD. So basic thing we should do is we should risk stratify the patient. We should use this FIB4 index, fibrosis 4 index, which includes 4 parameters like age, ALT, AST, and platelet count. And if needed, we can also order a fibroscan, that is transient elastography, and biomarkers, non-imaging based biomarkers like blood tests can also be ordered, but they are to be ordered only from good labs. So what is this fibrosis 4 index? As I said, it's very simple. We need not do any expensive investigations. We should just consider the age, ALT, AST, and platelet count. What is given routinely in the laboratory reports that the upper limit of AST, ALT is 40 or 45 is not correct. The American College of Gastroenterology, they say that the upper limit is not what is routinely given in the lab. The upper limit in men is just 33 and women is just 25. So even mildly increased ALT, AST should be considered as markers of NAFLD. And many patients with NAFLD have SGOT, SGPT less than 40. So definitely use this FIB4 index. If you want to wait for the increase in ALT and AST, you might miss early NAFLD. So the FIB4 index is less than 1.3. There's very low risk. You can just watch and wait. If it is more than 2.64, definitely the patient has a possibility of advanced fibrosis. If it is between 1.3 and 2.67, it has intermediate category. However, this FIB4 index cannot be applied to the extremes of ages. It's not approved in people less than 35 years, and it's not very sensitive or specific in people more than 65 years of age. Other than that, we have this liver stiffness measurement, that is transient elastography, also known as fibroscan, and ELF, that is enhanced liver fibrosis, which is basically using 3 blood tests with individual scores given to them. And it is the LSM, that is the fibroscan, is the best validated imaging technique. It's not very expensive, but it is very specific and sense to. But however, I have to say that not all patients need a fibroscan. Not all diabetic patients need a fibroscan. The first thing to be done is a FIB4 index. So even recent guidelines, they all suggest that when you see a type 2 diabetes patient and he has likelihood of NAFLD, what you do is you risk stratify the patient. Then if you feel there is need for fibroscan, then only you order a fibroscan. If the fibroscan shows there is high propensity for fibrosis, then you definitely refer to a gastroenterologist. If there is less propensity, then you can use the drugs which have been proven to be of efficacious in reversing NASH and or slowing the progression of fibrosis, or in some cases slowing or reversing fibrosis too. See, management from endocrine perspective. The first thing we write routinely: diet, exercise, weight loss. But however, to be specific, how much of weight loss and what amount of weight loss is very important, because the weight loss that is necessary for PCOD is something different from that what is necessary for NAFLD. If we remember, in PCOD it is said that even if somebody is very obese, losing 5 to 7% of body weight will help in regularizing the menstrual cycles. But however, when it comes to NAFLD, losing between 5 to 10% will only reverse steatosis and steatohepatitis. But if somebody wants to lose or reverse fibrosis, they have to lose more than 10% of their body weight. So when we identify that the person has fibrosis, we should target for a weight loss of more than 10%. The data is from the Look Ahead trial, which studied the predictors of diabetes. This is a very good study where a subset of population were studied for reversal of fibrosis. And both aerobic and anaerobic training is important. So we ask, just like diabetes, where we say of 150 minutes per day of moderate intensity exercise, or 75 minutes per day per week of severe intensity exercise, coupled with 2 or 3 sessions of anaerobic activity. So see what the weight loss, it says that mild weight loss will improve steatosis, steatohepatitis, but it will not improve fibrosis. Once you want to reverse fibrosis, you have to lose more than 10% body weight. So aiming for more than 10% body weight only give you the best chance of reversing fibrosis. So medical management, early diagnosis is very important, because if you want to prevent cirrhosis, studies have shown that it's very difficult to reverse fibrosis. Once fibrosis starts, only few medications have the potential to slow the progression of fibrosis, leave alone reversing fibrosis. Because diabetes itself is a marker for the progression, rapid progression of NAFLD to cirrhosis and HCC. Until now, we don't have any FDA approved, although we extensively use and write vitamin E for NAFLD, it doesn't have very long-term data beyond 2 years of its safety. See, we discussed 3 important drugs. We leave metformin and SGLT2 inhibitors. I know I cannot end this session without speaking about SGLT2 inhibitors. But see, vitamin E, pioglitazone, and GLP-1 receptor agonists, these are the medications which have been proven to reverse steatohepatitis. They can be huge medicines, thousands of medicines which can reverse steatosis. But we don't want just reversal of steatosis. We want reversal of steatohepatitis and medications that delay the progression of fibrosis. So among them, three medications have been consistently shown through many studies that they are useful in reversing steatohepatitis. First among them is vitamin E, pioglitazone, and GLP-1 receptor agonists. So vitamin E, it has been shown beneficial for NASH without type 2 diabetes. But however, in one study where it was studied along with pioglitazone, in type 2 diabetes patients, there was no extra advantage of using vitamin E in type 2 diabetes patients. So type 2 diabetes with NASH, vitamin E will not work. So we shouldn't be prescribing vitamin E to type 2 diabetes patients with NASH. We can give it to NASH without diabetes. And the other drug which has in recent years taken a back seat is pioglitazone, with tons and tons of evidence that it's very useful for patients with type 2 diabetes and NASH, because it reverses NASH in not only diabetics, it reverses NASH in pre-diabetics and even those without diabetics. And the good point is that it's also reversing fibrosis in some studies, although the dose that is used is slightly higher than what we routinely use in Indian patients. So it delays the progression of NASH also in type 2 diabetes. I am attaching the data from the meta-analysis. And the other drug is GLP-1 receptor agonists. They don't directly act on the liver because there are no GLP-1 receptors on the liver. So whatever they do it indirectly. Only liraglutide and semaglutide have been studied in biopsy-proven NASH. We know about trials of liraglutide and semaglutide, but their primary objective was something different. The secondary outcomes might be improvement in liver parameters, but the primary objective of having a liver parameter was only studied with liraglutide in very few number of people, and semaglutide with around 300 or 350 people. So, and the good thing is in patients with already proven NASH. So both of these drugs were useful in slowing the progression of fibrosis and reversing steatohepatitis. And semaglutide 2.4 weekly ones is also being studied, and it is found to be safe in NASH with compensated cirrhosis and type 2 diabetes. So we can use the semaglutide in compensated cirrhosis in type 2 diabetes. And tirzepatide reduces steatosis, but it doesn't improve NASH. So we don't want drugs that only improve steatosis. We want something beyond improving steatosis. So again, the data what we see that we have only 2 drugs, that is liraglutide in just 52 patients and semaglutide in 320 patients, studied in patients with NASH with proven biopsy. So drugs with too little evidence. Now we come to drugs with too little evidence. There we find metformin and SGLT2 inhibitor. As I said, I cannot conclude this talk because these days we are bombarded with talks on SGLT2 inhibitors. Statins don't have evidence. Fibrates, ezetimibe, pentoxifilin, omega fatty acids, and FXR receptor agonist, that is obeticholic acid. So metformin is again extensively used previously. It's used off-label for NAFLD, but it is not recommended as a standalone drug. But there is a silver lining for metformin, that it has consistently shown that it reduces the chances of HCC because it inhibits the mTOR pathway. So metformin we give in NAFLD not to prevent the progression of NAFLD, but because it reduces the chances of HCC. So metformin has a silver lining when it comes to NASH. Then come to SGLT2. Many people might be disappointed, but they just improve steatosis. There is no study of saying that they improve steatohepatitis. So as I said, we don't want drugs which only improve steatosis. We look for drugs that improve steatohepatitis. So conclusion, NAFLD is common. If somebody asks me what are the 3 commonly neglected things in diabetes patients, I would say it is vaccination, cancer screening, and the third thing is NAFLD, because we are so commonly used to seeing NAFLD in ultrasound reports. I feel it somehow escapes the radar and we just even forget to mention it in the diagnosis, primary diagnosis. So NAFLD is important for diabetes because it causes insulin sensitivity. But other thing we have to understand and remember is diabetes enhances the progression of NAFLD, and diabetes is a risk factor for HCC in NAFLD. Use FIB4 index. There is no need to go for fibroscan. Target weight loss 5 to 10% to reverse steatohepatitis. If you want to reverse fibrosis, you want to target much more. Target more than 10% weight loss. Use medications of proven benefit in type 2 diabetes patients with NAFLD. Vitamin E is useful, but not for those with NASH and diabetes. It's only useful for NASH without diabetes. Pioglitazone, the drug which had taken a back seat, is very good. It has one of the best drugs with tons of evidence for type 2 diabetes and NASH. Semaglutide is the GLP-1 receptor, although we have liraglutide also, but the number of patients for just 30 or 50 in liraglutide. We have 320 in the semaglutide. So one of the best GLP-1 receptor agonists as far as NASH is concerned and type 2 diabetes is semaglutide. Metformin, SGLT2, they only improve steatosis. So the point of writing for them for steatohepatitis is not there. Yeah, thank you.
Sir, I have a question for you. What is the role of saroglitazar?
Yeah, that's an important question, ma'am. So saroglitazar, it has been studied. What they say is that it improves steatosis only. It doesn't improve steatohepatitis. As I said, there are thousands of drugs that improve steatosis. So we don't want only improvement in steatosis. We want steatohepatitis. And many of these drugs which had, as I said, semaglutide and pioglitazone, they do a biopsy at the starting of the study and at the end of the study, like 48 weeks, like that. So only those drugs which had shown improvement in biopsy will be useful. We don't want drugs which just say that the ALT had come down or some other marker or a fibroscan has shown improvement. So drugs which show biopsy proven results will be given the highest priority. So as far as saroglitazar is concerned, it is not shown that benefit, although it is, I understand that it is heavily promoted as a drug for NASH and hypertriglyceridemia and diabetes.
One more question, sir. Lean NAFLD, how do you manage? Lean NAFLD, how do you manage?
So lean NAFLD, people say they are pseudo-lean, as we know that lean obese people who have higher abdominal obesity. So lean NAFLD, if they have diabetes, we can definitely go for pioglitazone, what I feel is.
Is there any role of gut microbiota on NAFLD?
Yeah, gut microbiota, I have not studied them extensively, but from what I know is that definitely there is a role, because there are some genotypes which predispose individuals to NAFLD, and gut microbiota, they are now implicated in everything, every disease from cancers to autoimmune disease. So definitely there should be a role, because all the gut products, they go to the portal circulation and the liver. So definitely there should be a role of gut microbiota in NAFLD.
Any other questions? Okay, so that was a lucid presentation. Thank you.
So I would like to invite all the endocrinologists present here for a group photo. Onto the dais.
పైకే ఎక్కిన తర్వాత సంగతారు.
Before ending our session today, so I would like to propose a vote of thanks. Sir. Meer andaru randi sir.